data and see what happens. The various small studies showed a positive trend, so more and more people are getting into it. But we have now a sort of a polarization. We have one group which swears by HIPEC and one group which swears against HIPEC. They say that the evidence is not enough and we need to wait further before we go ahead. So what are the basic controversies, as Dr. Rama had said? They evolve around two things. One is the role and other is the technique. For today's discussion, I would only speak about the role. We will not take up the technique today. So it's essentially, as he said, it is about the rationale, utility, efficacy, morbidity, the cost, and the evidence. So this is one very recent editorial which had come in International Journal of Gynec Cancer. And Dr. Vergote, he's the person who was the principal investigator of the trial for neoadjuvant chemotherapy followed by interval cytoreduction, which led to the standard of care of interval cytoreduction. So he has been a critic of HIPEC. So he has put in certain questions about the role of HIPEC. So that means how can a single treatment affect it, whether the results are there due to only the hypothermia or the chemotherapy also has an effect, whether the morbidity, the survival outweighs the morbidity. Scientific evidence as such is mainly based more on meta-analysis and individual small studies. We have very few RCTs, so that becomes suspect. And the one study, he had some objections to it about some imbalances. So we'll just take it up one by one. The rationale is very obvious. We have been discussing about the rationale for the last 10 years, that ovarian cancer remains limited to the peritoneal cavity for most part of its natural history. And intraperitoneal therapy targets disease on the peritoneum, but we should remember that the effect is most on a microscopic disease rather than a microscopic disease. So intraperitoneal therapy leads to higher concentration of drugs, hypothermia has its own unique effect, which I'll talk about. Another benefit is that chemotherapy is immediately given after complete cytoreduction, so there is less time for tumor repopulation. Systemic toxicity is less because the pharmacokinetics are such that the drug remains limited more to the peritoneal cavity. And basically, most of the randomized clinical trials have shown a benefit of intraperitoneal therapy. That's a normothermic intraperitoneal therapy in the past 2-3 decades. And one of the limitations of intraperitoneal therapy was formation of adhesions leading to loculations, leading to areas not exposed to the drug. So HIPEC overcomes those limitations. Now, regarding hypothermia, this is also well known. There may be direct effects on the cell and on the perfusion, and leading to increased blood flow, increased chemotherapeutic effect of drugs like cisplatinum, which are potentiated by hypothermia, and as well as indirect effect due to the release of heat shock proteins, which themselves trigger an immunologic cascade acting against the tumor cells. So I'll just remind the results of the intraperitoneal therapy. And then these results are basically long-term results which were published last year itself. And they show that 10 years later also, the IP therapy enhanced the survival. This is about, enhanced the survival by about 10 months. And another thing is that people who completed the therapy, intraperitoneal therapy, had the maximum benefit. So this is a recent meta-analysis or a recent long-term follow-up of that study, which shows a persisting and a durable effect of intraperitoneal therapy. The other important thing in this long-term results was, if you see the gap between the two lines, the top line is microscopic disease and the bottom line is macroscopic disease, but all under 1 centimeter. So this was considered optimal surgery, 1 centimeter disease, and the problem is there's such a lot of difference, so maximum benefit is in microscopic disease, and that is what we should aim at when including patients for our therapy. The problem with many of the trials in HIPEC are they've included patients of 1 centimeter disease also. So this is a summary of intraperitoneal normothermic trials, and most of the trials showed a positive outcome, except of one negative trial, that was GOG 252. It was a 3-arm study. The only thing was this study included stage 2 and stage 3 patients. So there were a lot of good prognosis patients also in this group, so that diluted the effect of intraperitoneal therapy. So this one the headline was thought-provoking that whether we should abandon intraperitoneal therapy. This is also last year's, but the headlines are different and the conclusion is different. If you see the forest plot analysis of the last 1 decade of trials, they all favor intraperitoneal therapy. And the conclusion was that though the number of trials have been very less, but whatever evidence is there, that supports a survival advantage of intraperitoneal therapy. So this gives us a rationale of targeting the peritoneum in advanced ovarian cancer. So what were the barriers of IP therapy? It was very effective, but still it was not uniformly accepted. So that was basically due to the requirements in terms of infrastructure, or rather expertise. Then placement of catheters and all, giving of chemotherapy required extra time and effort, skilled team. And then there were more side effects with this therapy, and these side effects were mostly related to the catheter. That was pain, GI symptoms, and blockage, infections, all were catheter related. So all these would be not seen in a HIPEC therapy. So if you see this HIPEC, we've had a whole lot of meta-analysis, individual studies and all, which are very small. But the problem is they are all very heterogeneous population, heterogeneous patients, different drug regimens, different drug doses. So, but they all tend to tell us that there is a survival benefit of HIPEC in whatever you do. So I'll just concentrate a bit on the randomized files which have been published. The first one was by Lim et al. And he had a mixed population of a primary debulking as well as interval debulking, and a subgroup analysis did not reveal a benefit for the primary debulking group. So the problem was that there was a very limited number of cases. There were only 58 cases and 49 in the HIPEC and control. So the number of cases very, very small, and stratification and all was not very clear. So this study was not very convincing. It doesn't go against HIPEC, but it doesn't even tell us that there is evidence to support HIPEC in the initial surgery or primary surgery setting. The next is the interval setting, which is the most OV HIPEC study by Vandriel, which is the one which is quoted everywhere, which has shown a PFS benefit of 4 months and an overall survival benefit of about 12 months. And this used a single drug cisplatin at 100 milligram per meter square, FIGO stage 3 patient, and a residual disease of 2.5 millimeters. So this was a very specific study, and that is the normal what we do now. It is only HIPEC should ideally be used for a microscopic disease or a residual less than 2.5 millimeters, which is CC1. LIMS study, which showed no effect in a primary setting, showed a survival benefit in the subgroup of patients who had surgery after neoadjuvant chemotherapy, and he had a smaller PFS difference, but a larger overall survival difference. The PFS difference was 2 months, but the overall survival difference was about more than 12 to 13 months. The third study was by Cascales. He used cisplatin 75 milligram, stage 3, and again the same tumor size. And his sample size was not reached because he had shown a PFS benefit, but he abandoned the study because OV HIPEC study was already out and it showed a survival benefit for HIPEC. So it would have been unethical for him to continue. So that's what he gave the justification and stopped his study. Now, OV HIPEC 1, the one which is the basis of all HIPEC therapy post-neoadjuvant chemotherapy, is basically 3 cycles of chemotherapy in stage 3 cancers. They had initially taken patients up to 1 centimeter residual, but then subgroup analysis they made for 2.5 millimeters. The randomization was done just prior to this, at the time of surgery, prior to opening, so prior to the procedures, where the anticipated complete resection would be done. So this was one objection, that there could have been bias for more resection. And then after surgical HIPEC, one group got HIPEC, one was received only adjuvant chemotherapy. So here the RFS and the overall survival both favored the high-PEC arm, and this formed the basis of getting this therapy in the various guidelines. So the other thing, just wanted to highlight the characteristics of this study. The main thing which has to be seen here is the duration of hospitalization was not much difference, 8 days and 10 days. Time between surgery and the start of first chemotherapy was 30 days and 33 days. And again, 90% plus patients completed the adjuvant therapy. So high-PEC did not affect adversely the further treatment. It did not increase the hospitalization. And overall stay and the overall complication rate was in the range of 24 to 25%, equal between both arms. So that was in this report. So then the same trial, this was 10 years ago, and now they presented the 10 years data for this trial in the last ASCO. And the final 10-year data also shows a survival benefit persisting for the high-PEC group. And what they said in the conclusion was, addition of high-PEC delays recurrences, improves overall survival, and does not impact subsequent therapy. Another interesting finding was high-PEC was the most effective in BRCA wild type or BRCA-like subgroups. So this is the subgroup where we don't have much answers, much options later. So as a contrary to this, just two more complications of high-PEC. This indicates by 2 minutes I started late. Complications of high-PEC were presented very recently, a month ago. The authors highlighted that over 2 decades of high-PEC, the complication rates haven't changed much in spite of advances in treatment, surgical facilities, etc. But the most important thing is this study showed only overall rates and not high-grade complications, and the complication rates were in the range of 20% to 25%. And the authors concluded, if you see the conclusions down, the authors concluded that the complications are not negligible. But if you see the editorial comment, which has come again from Bergot, in summary, the complication rate has not decreased, and complication rate of cytoreductive with high-PEC remains high. So they have put as not negligible, and the editorial gives a slightly biased view that it is a higher rate. So anastomotic leaks and all are also same between both the things. Scorpion trial was only a cytoreductive trial without high-PEC, and it showed a similar rate of complications which are seen in the other high-PEC trials. So there was not much of additional complication because of high-PEC. Recurrent cancer, again, we have 2 studies. The first study showed a very big benefit, but there were a lot of errors in conducting the study, the planning, the statistical analysis, so it is being disregarded. The second study was from MSKCC, and they didn't show much of a difference between the high-PEC, non-high-PEC group, but the only problem was they used platinum sensitivity. They had put a mark up to 2.5 years. Beyond that, they didn't take the patients. And more patients in the standard arm underwent complete gross resection. 12% more patients underwent complete gross resection, so that must have skewed the result. There are many case control studies which have shown a benefit of high-PEC in survival, but one randomized trial which has recently come out, which was presented last at ASCO, was the CHIPOR randomized trial in recurrent ovarian cancer. That is a platinum-sensitive relapse after 6 cycles of chemotherapy. The patient underwent high-PEC or no high-PEC. Endpoint was survival, and they found a significant survival difference in both the arms in favor of high-PEC. So this is the first RCT which shows a benefit of high-PEC in platinum-sensitive recurrent ovarian cancer. So health-related quality of life and cost, all these trials have shown no additional adverse effects of high-PEC. They are similar to CRSs. Now this is the question of disparity in various organizations' recommendations. The Peritoneal Society recommendations say that what happened? Okay. Yeah, that's one more slide. So they say most of these recommendations now say that high-PEC can be taken up as an interval setting. They don't have evidence for primary or recurrent. same as NCCN. And I'll just say the final thoughts. Current consensus favors interval CRS HIPEC, followed by NACT, and level 1 evidence is also available for relapse cases. Well-trained team, infrastructure, and self-audit is important. Benefits of HIPEC cannot be overestimated, and a good HIPEC is not a substitute for bad CRS. So this is the last slide. Consensus is invoked in situations where we don't have the science, but now science has come for HIPEC, at least in recurrent settings and interval settings. So consensus is needed only for the primary setting. Thank you.
Thank you, Dr. Bapna, Dr. Ahuja. And I think in what cases you would like to consider HIPEC in advanced ovarian cancer? Stage 3 and interval surgical cytoreduction? And what about the recurrent setting with the present evidence?
I think my last slide, when I said the CHIPOR trial, it favors use of HIPEC in platinum-sensitive relapse. Those cases who are fulfilling the desktop criteria for a surgical cytoreduction, those cases after a complete cytoreduction, HIPEC could be considered.
Looking at the present evidence, I now request Dr. Aditi Bhatt to give her expert comments and the judge based on the practical
So
experience.
I think it was a very nice presentation by Dr. Ahuja. He covered all the aspects about HIPEC and about IP chemo. I would like to say one thing, that it is a misconception still amongst many people that HIPEC is one additional dose of chemotherapy. HIPEC is certainly not one additional dose of systemic chemotherapy. It's a surgical treatment. It's not just the dose of cisplatin, it is also the perfusion, the hypothermia that matters. In the interval setting, we definitely have level 1 evidence. Even if you consider all the criticism of the OVPEC-1 trial, it is still level 2 evidence and not less than that. So we are sort of obliged to offer it as a treatment to all our patients undergoing interval cytoreduction. You may not call it the standard of care, but it is certainly not an experimental therapy for after interval cytoreduction. And the 12-month survival benefit that you see in the OVPEC-1, you are seeing a similar benefit in the Korean HIPEC trial, 14 months. Though it's a small subgroup, it's a post-hoc analysis, and I don't think you see such a benefit in oncology nowadays. You know, all the trials that were presented in the morning, 2 months, 3 months, at max, there is a benefit of 6 months between the 2 arms. Here we are talking about, a survival benefit of 1 year. Of course, in the primary setting, it should be considered experimental, and we should not give NACT to perform HIPEC after interval CRS. For the recurrent setting, we are waiting for the full publication of the CHIPOR trial, but again, 10 months overall survival benefit. So where it works, it is working well.
Yeah, thank you so much for your expert comments. Thank you. I invite Dr. Jaideep Bhaumik to present on the controversies to consensus in sentinel lymph node mapping and sentinel lymph node biopsy versus lymphadenectomy in endometrial cancer. Dr. Bhaumik, please. I think we're required to stick to the time. Dr. Jaideep Bhaumik's presentation, please.
Good morning. We've been told that we are running very short of time, so I'll try and finish it as quickly as I can. I was given 10 minutes, so I'll try and finish it in 5 minutes. Let's see if we can.
Dr. Jaideep Bhaumik's presentation, please.
Yes, so, as clinicians, we have always been taught to be reasonable, to be reasonable, to be understanding about
Yeah, it's the same.
And that's what is expected from us, the clinicians, that we have to be reasonable. But if we stuck to that principle, maybe we would not be here talking about all the precision medicines, because sometimes we become unreasonable and do things out of the box so that things get better. So similar thing come to our understanding when we talk about the sentinel node biopsy in endometrial cancer. So in today's talk, I'm going to just outline the role of the lymph node dissection or assessment, whether it's necessary or not, the traditional way that's done, and I'll highlight the controversies and try to rethink when we come to the consensus about it. So the rationale of doing a lymphadenectomy in endometrial cancer, of course, it ensures correct staging. In case of lymph node metastasis, it is a predictor of survival, and also we can tailor our adjuvant treatment for this. But the problem is that, of course, it needs a longer operating time. You need additional training and skill to be able to perform lymph node assessment or dissection. And there are assumed risk of postoperative complications. There are delayed complications like lymphedema, lymphocyst that can happen. Now, when we look at the survival, how it matters to the patient, we look at the survival. And we know if we know the stage of the disease, it is clearly seen that the survival can be predicted. But if you look at the CR data, where it is unstaged, the stage is unknown, then the survival at 5 years is only 50%. So there's a lot to say about appropriate staging in endometrial cancer. And when we do appropriate staging in endometrial cancer, there are certain risk factors that we identify, and based on the risk factors, we impart adjuvant treatment. Now, I will just highlight the areas in the high-risk category. So if the lymph node is metastasis, irrespective of whichever way you classify, they need, the lymph node metastasis means they need adjuvant treatment. More importantly also is that non-endometrioid cancers of endometrium, they also need adjuvant treatment. So that is the consensus anyway. But question is, how does it matter to the patient? How does it improve the survival? Does it really do so? And does it change adjuvant treatment? Let us try and answer those questions. And of course, we will look at the shouting against the surgeons that we are doing too many morbid cases. So 2 randomized controlled trials, nearly 2,000 patients undergone randomized controlled trial, and there is no survival benefit in doing lymphadenectomy. So why should we do it? Yes, it does change the adjuvant treatment. Of course, we know we have recently all the PROTECT trials have come out, and adjuvant treatment, chemotherapy, radiotherapy, or a combination of it, it definitely improves survival. So unless we know the disease, unless we know the lymph nodes are involved or not, how can we do the treatment? Additional morbidity. Majority of the studies say that there is no increased morbidity. Our own center data is that the incidence is less than 2%. The lower limb lymphedema is a thing that is talked about a lot. The biggest series is from Australia, and what they have shown, there's an interesting point they have commented on, that nearly 70% of the patients actually had a lymphedema before starting treatment, and it increases to 75% when they undergo treatment. So when we are shouting about lymphedema after lymph node dissection, maybe this is a condition they were actually harboring before they had their treatment. So the consensus about lymph node dissection, as we stand now, is that it has got no advantage in low-risk patients. It of course is necessary in high risk. But how do you know it's low risk or high risk? Okay, so if looking at alternative solutions for a complete lymph node dissection, gene expression profiling, which is maybe at its infancy, I'm not going to talk about it much, but more importantly that we have sentinel lymph node assessment and biopsy. So when we do sentinel lymph node assessment and biopsy, we identify the first draining lymph node, and if that lymph node is involved, we can take it for granted that, yes, this is a high-risk disease and treat them accordingly. The pros of sentinel lymph node biopsy is that, of course, we are doing a complete lymph node dissection, even in high-risk patients. But important thing is that individual institutes should be validating their own data, because it's a technical skill that you have to acquire, and unless you have acquired that technical skill, you should not be doing lymph node assessment. You need to, every surgeon needs to do at least 30 cases, validate that, If it is appropriate, then you do the lymph node dissection without doing complete sentinel lymph node biopsy without doing the complete lymph node dissection. And of course, the chances of complication is very, very small. Of course, if, should you do it for low-risk cases? I'll come back to our own data a little later. There is a learning curve, as I just mentioned, and we will still need to do full lymph node dissection if the mapping fails. Mapping can fail in majority of, in certain number of cases. So this is our data. We have started doing sentinel node biopsy more than 5 years earlier. This is the first 100-odd cases that we published in JCO. That among the 107 patients, the negative predictive value was 98.3%. So it is a highly accurate way of identifying the risk category of this patient to impart adjuvant treatment. Now, most importantly, the disease was upstaged in 9 out of 107 patients. These patients were deemed low risk at the outset with imaging and histological assessment. But these patients were actually upstaged because of the sentinel node biopsy. That is something we should be very carefully considering. So the questions come in when we come to the controversies that, if the histology is high grade, if I'm thinking of the patient's perspective, if the histology is high grade, stage is early, do I still need to do? Because histology is high grade, I'll give them chemotherapy, radiotherapy anyway. What's the point of doing lymph node dissection? And if I have done lymph node dissection, lymph node metastasis is there, then if the lymph node is negative, can I still omit adjuvant treatment? I'll probably still give it. So what's the point of doing lymph node dissection? Okay, so this is the controversy that still exists, and we should be trying to answer that. So for the if the histology is high grade, all endometrial cancer, more than 50% myometrial invasion, they will need adjuvant treatment. One exception, of course, the pole mutated gene. We know for certain now that if the pole mutation, you're tested for pole mutation, even if it's a high grade, more than 50% myometrial invasion, pole mutated, we can withhold the adjuvant treatment. And of course, the dilemma will be for high grade cancer with less than 50% invasion. Plenty of evidence in the literature, low risk, no point doing lymph node dissection or lymph node assessment. But you have to have a reasonably good MRI to understand the myometrial invasion, size of the tumor, and decide on the extent of your surgery. We have been talking about Indian data. Of course, that is extremely important. I don't think that Indian data will be very different from the rest of the world, but still we need to have your own data to counsel our patients and tell us what we expect from them. So this is the data of the first 143 patients at Tata Medical Center. And interestingly, less than 50% myometrial invasion, no grade 1, grade 2 endometrial cancer. 5.5% of our patients, actually, these were all picked up by sentinel lymph node. 5.5% of patients had metastasis in the lymph nodes. Grade 3, of course, if the cervix is involved, 60 to 80% of our patients actually had lymph node metastasis. So it cannot be completely ignored in that way. So irrespective of the grade of endometrial tumor, of the total 110 patients, there are reasonable number of patients who actually had lymph node metastasis. Of the non-endometrioid cancers, again, a small number of patients, only 33. We did not have any patients with lymph node metastasis if there was no myometrial invasion. But if there was any myometrial invasion, it was nearly 30% of the lymph nodes were metastasized. Cervix involved, it's nearly 20%. So what I think about the future. What we need to do, we need to have our own data and with respect to the rest of the world. So ENDO3 trial is the one which we are hoping to participate in. We have been accredited for that. And the problem is the ethical approval. Because now the standard of care with us is sentinel lymph node assessment. Now in the ENDO3 trial, what they have proposed, the standard of care is no lymph node assessment. So we have to argue with the ethical committee to say that yes, lymph node assessment actually can be, because this 2 randomized trial has already shown no role of lymph node assessment. So what's the point of doing it? So that is why they have kept no lymph node dissection as the standard arm. So yes, we should participate in these trials and then come out with our own data so that all these controversies are ended. Thank you very much.
Thank you, Dr. Bhowmick. Before I think we get the final comments, I would like to ask you, based on your experience as well as the evidence today, which patients you are likely to choose for the sentinel lymph node biopsy in endometrial cancer?
At our center, we do sentinel node biopsy for everybody. we had a very big debate about, even for grade 1, stage 1A endometrioid cancers, whether you should dose sentinel lymph node or not. So what we do in those cases is that we do sentinel for everybody. If the mapping fails, then we would not go into do a full node dissection in stage 1A grade 1 cancer. But if it is stage 1B, we will still, if the mapping fails, we'll do full lymph node dissection.
Thank you.
So that is the consensus we have.
I'll request Dr. Ibrahim Pedigal to give his judgment based on the practice.
Great talk by Jaydeep, and he's really showed that, as surgeons, we need to be reasonable, we need to be thinking surgeons, we need to do surgery that spares function, we need to do surgery that reduces complications. And I think sentinel lymph node biopsy is one such strategy where complications are reduced. I mean, the controversies in sentinel lymph node biopsy are, one, in low risk, should we do it? And in high risk, is it enough? And the skeptics would do systematic lymph node dissection even for high risk cases. I think the important thing is that, like he said, we probably need to do a randomized control trial to see whether we can omit it in really low risk patients. And in high risk, I think there's enough evidence to show that it is sufficient. The important thing is that we need to standardize the protocol. It's how to do the sentinel lymph node biopsy. It's not just the biopsy, but a sentinel lymph node mapping. So it has to be done, even all enlarged nodes have to be removed, all the fluorescent nodes need to be removed, and the technique of using ICG rather than methylene blue or some other dye. And to do the lymphadenectomy if the mapping fails, that's also important. But he said in their center, very early stages, they might omit it. So I think you have done a great presentation. I think there's a lot of improved our understanding. Thank you.
Thank you all.
Thank you, speakers, chairpersons, and panelists for that wonderful gynecology-oncology session. For our next session on neuro-oncology, I call upon our chairpersons, Dr. Rana Patir sir. Sir is Chairman Neurosurgery, Fortis Gurgaon. Dr. Amal Roy Chowdhury sir, his Director, Radiation Oncology, Fortis Gurgaon. And Dr. Bowman Dhabar, Director, Medical Oncology, Fortis Mumbai. I welcome you, sir. For this session on multimodality management in brain metastasis, I would like to invite Dr. Dhirendra Prasad, Professor, Medical Director, Department of Radiation Oncology, Roosevelt Park Cancer Institute, USA. We welcome you, sir.
All right, thank you. I'm under the gun. We got to move fast through all this stuff. But thank you for inviting me. My task is pretty simple. I'm here from the Roosevelt Park Cancer Institute, the very first cancer institute anywhere in the world, and we do a lot of gamma knife radiosurgery. I head the gamma knife division. Fortis is about to acquire the first gamma knife Esprit in India, which will be, I think, a game changer because of the way your system is set up. We owe this to Lars Leksell, professor of neurosurgery in Stockholm. And I just want to show you that his evolution of the frame and the idea that you can focus multiple beams of radiation in one spot and treat small targets as small as fractions of millimeters is what revolutionized radiosurgery. And it's just one of the modalities that we will be talking about. The technique itself has evolved. You will have the absolutely latest device installed in just a couple of months. At its core, it's able to produce precise destruction of any target placed in its path. And you can use MRI, PET scan, dotatate scans, and other modalities of imaging to make your treatment plan. All SRS for brain mets works on the principle that because the dose is delivered in a single or a few sessions, it is highly destructive and it produces biological effects that overcome radioresistance and the classic reasons why certain tumors don't respond. We also are able to pack a very high dose in the center of many targets, which are often the hypoxic radioresistant parts of these tumors. And we can do it with great precision, almost mapped here, as you can see on a microscopic slide, that you can drop from critical doses to very safe doses within one high power field. There are many ways of doing radiosurgery out there. You have brain lab equipment, you have CyberKnife. The uniqueness of the Gamma Knife is the ability to control dose outside the target and really reduce exposure to the rest of the body and the rest of the brain. And it also is superior to other techniques in terms of ability to treat the complete target and create very sharp boundaries. This is an MD Anderson study that shows that it is superior to LINAC as well as protons. So when you think about what you're offering to your patients, you begin to understand that this is a unique machine and it'll complement the idea of precision therapy. In a more visual sense, if you look at a patient with 5 brain mets, you can see comparison plans between Gamma Knife and the so-called hyperarc. And the idea that the low dose spread is very, very tight means that you spare normal brain and you reduce dose to extra target structures. And it makes a lot of sense when you take 4 or 5 tumors, but we are now entering a phase in which we treat brain mets in large numbers in patients, many more than 5. So here you can compare the Gamma Knife plan, low dose being about 3 gray, to a LINAC plan where the 3 gray wash is covering the whole brain. But what if you treat 44 brain mets? You will still see that the spread of low dose does not cover the entire brain. The other thing that's very unique about radiosurgery performed with the Gamma Knife program is the fact that you can do everything in one day, which has a huge impact on the management of these patients, especially when you consider multimodality management where multiple people will be involved. LINAC and other techniques require planning in several days. How does that even matter? Well, for a Gamma Knife person, we make up the fact that this takes a longer delivery time by treating several patients in one day after the other, but everything gets completed from imaging to plan to delivery on the same day. And the reason that is important is that if you plan a patient based on imaging that is even a week old, you may see tumor growth in the interval, which means your plan becomes completely irrelevant by the time you deliver it. And we've seen this particularly in melanoma brain mets, where a 4% growth per day can take away any chance of full adequate coverage if you delay the treatment by a couple of weeks, which is not uncommon in a LINAC-based program, certainly not uncommon in the few centers that do proton-based radiosurgery. So we definitely feel that you have to act fast. If you look at our delivery curve, we treat many patients on the same day as the consultation, and we get almost everybody treated in about 8 to 10 days. And that is important to understand in terms of how the dynamics that works. When you look at options and the interaction and interoperability of various modalities, traditionally in the early era, there was only surgery or there was whole brain radiotherapy. And surgery had its advantages, especially when you had, and still does, when you have a single large lesion or a lesion that's producing neurological compromise, and decompression is the only way to save the patient. So obviously that becomes the choice to go. However, it became very clear that just operating on a tumor is not enough. You have to provide adjuvant radiation to prevent recurrences from occurring, which even after a clean resection will occur in as high as 50% of the patients. So in the beginning, it was surgery plus whole brain. Several studies since then have shown that you don't have to treat the whole brain even after a surgery. You can actually treat the surgical cavity purely with radiosurgery. High levels of evidence exist which shows that 85 to 90% control rates will occur, and you'll have about a 15 to 20% risk of radiation-induced damage and a small risk of leptomeningeal spread depending on technique and location of where the surgery was done. Clearly greater in the posterior fossa, clearly greater when you have to marsupialize the tumor rather than remove it en bloc. And all of this data exists. So the ISRS today gives a clear guideline that you don't have to use whole brain radiation. So our paradigm now switches a little bit. We can do surgery plus radiosurgery in the high-performing patients, and in patients who don't need surgery you can do just radiosurgery, and that's going to be the next thing. But before that, if there's in any situation poor performance, poor expected survival, or leptomeningeal disease, is still reasonable to treat using whole brain techniques. Now, if you look at just radiosurgery, which has basically been the case till about 4 or 5 years ago, or shall we say about 10 years ago, when targeted therapies made their turn. A lot of discussion happened about how many brain mets was too many, and people used to partition patients based on more than 4 brain mets and give them whole brain. That got slowly disproved. We showed it, other authors showed it, that it's the total disease burden and the systemic control that's going to govern outcome, not the number of brain mets. And so that has slowly gone away, and we have moved to understand that the number of brain mets really doesn't matter, which means that radiosurgery still remains a very important option for patients with any number of brain mets. When the volume starts to exceed 7, and in certain papers 12 to 15 gray, you will start seeing cumulative brain doses go up. But it also provides huge neurocognitive advantage. Eric Chan showed that from MD Anderson, clearly demonstrating that neurocognition will be much better if you do focused radiosurgery rather than doing whole brain radiotherapy. And that has been shown by Paul Brown from MD Anderson. Visually, this is what happens to the brain when you do whole brain radiotherapy. Over time, white matter changes appear and the patient's cognitive performance declines. By comparison, the bottom slide shows you a patient that has been treated more than 5 times for over 60 brain mets over a course of 3+ years. And in the first 2 years, you can see absolutely no flare change. The game changer was the appearances of targeted therapies. Clearly, 2 things happened. 1, the brain control rate started to pick up. 2, patient survivals improved, which means the pressure on the physician managing the brain mets changed completely from just controlling brain disease to controlling brain disease effectively without damaging the brain. The question then became, can we just throw radiosurgery into the trash can and just do targeted therapy? Well, unfortunately, SRS, immuno and targeted therapies alone were very limited. Firstly, if you look at it, driver mutations are found only in very small subsets of patients, so it's not going to be applicable to a large patient subset. You also heard that even at Fortis, the initial application of precision medicine will be to advanced stage patients. Till we get to screening every patient ab initio and start working with these patients up front, we will still have some limits. If you look at those patients, and this is from Manmeet Center, borrowed this from Rupesh Kotecha, showing in a big academic center, if you took all your brain mets patients, how many would have been eligible for the targeted therapy only trials? And it's a very small number based on the inclusion-exclusion criteria. And what are the control rates? So if you look at just targeted therapy alone for controlling brain mets, the highest you see is an EP-NIVO combination hitting about 50%. Most studies, however, will show a lower number. Why is that? Systemic disease is doing great, but the brain disease is not. And the reason is that not every brain met looks identical to its primary when it comes to its mutation and molecular profile. As many as 1 in 5 patients with PD-1 expression will not have the same expression in their brain met. So brain mets differ in a molecular level from the primary. And as a result, if you look at what happened to the early trials, trying to remove all of the modalities of managing brain mets and just using targeted therapy, the results were not good. There were failures, there was higher complication rates, and the only trials in the early days that documented all of this, where you see good control, is where some form of radiotherapy was introduced. The only trial that's an anomaly to this is the lapatinib plus capecitabine data, where just that agent was able to produce decent control in the brain. But trial after trial, I circled it in red. Rule of thumb I teach my residents is these targeted agents alone produce 30% response in 30% of patients, 30% volume reduction in 30% of patients. So by themselves, while they have definitely improved survival and changed the complete landscape of managing metastatic cancer, in brain mets, they are not alone. So together with radiosurgery becomes the next question. Should we bring it back out of the trash can and add it into the mix and see if together we get somewhere? And that makes a lot of sense. There is theoretical basis for it. When you add radiation to the mix, you change antigen presentation. You invoke all kinds of classes, MHCs, toll-like receptors, all of which potentiates the effects of your systemic targeted therapies. And you also increase the ancillary kill for these agents. And as a result, you induce what is called the abscopal effect. The abscopal effect will benefit not just the metastatic disease in the brain, it will also produce positive responses on immune-mediated therapies in areas outside the brain. So we see study after study that when radiosurgery is combined with immunotherapy, you begin to see better responses. Within the agents that are used, there are differences as well. For instance, anti-PD-1 therapies seem to have more of a synergistic effect than CTLA-4 agents. And then you get both improved local as well as distant control. And you can look at multiple papers showing you that when the synergy of radiosurgery, focused radiation, which is brain protective, is combined with targeted agents, you begin to see a similar effect. So today, the way we see the synergy of all these technologies working is that you will choose surgery when you need to, you'll follow it up with radiosurgery, and you'll use targeted agents to back it up. In patients who don't need surgery, it'll often be a radiosurgery combined with the total effect. And essentially, that comes study after study, we can show that this works very, very well. And the end result should look something like this. The key points to take home from this discussion are the following. Radiosurgery is the standard of care today for managing brain mets. Combining it with targeted therapies provides you a superb outcome, both in the brain and in the body. And it's also important to recognize that these treatments have to be sequenced in a certain way. Treating with targeted agents before you do radiosurgery often produces inferior results. Starting the radiosurgery up front and then following with targeted therapies will do better. That has also been demonstrated in literature amply. There are only a couple of agents where hemorrhage could be a complication, but we have shown that radionecrosis rates and complication rates within the brain do not go up by using the combination. So as most of our patients today will undergo an evaluation for surgery, but generally undergo radiosurgery for known brain mets and targeted therapy for their systemic cancer. So I conclude here, and I don't think we have time for questions because more important things need to happen, but thank you very much for the opportunity.
Thanks, Dhirendra. That was a very brief, concise, and I think it sent a good message that that we have to think about stereotactic radiosurgery in metastasis as a primary treatment in most patients, and that it should be done preceding any other newer therapies available. Thank you so much, Deep.
Yeah, and it doesn't interrupt treatment because it's done all in one day. It also does not complicate your patient more, so you don't have to worry about hemorrhage, etc. It really is a very safe adjunct and done best up front. So when you arm yourself with your gamma knife, you're really getting ready to serve this patient population the way they should be. Thank you.
I thank the chairpersons and the speaker for such an informative talk. Now let's begin with the inaugural function. Namaste. Welcome to the Indian subcontinent, a cultural melting pot. Myself, Dr. Spandana.
Myself, Dr. Prajwal.
Are very elated to welcome one and all to Namma Bengaluru, the capital city of Karnataka, a land of rich culture, heritage, and history.
There is a can in cancer, and that's because we can fight. There is a can in cancer, and that's because we can fight it. As Mahatma Gandhi aptly said, the future depends on what you do today. And in this regard, we at Fortis Healthcare Bengaluru have taken a small step, albeit, but we are sure that this is going to be a giant leap towards the future of oncological management.
India is the first country to have set foot on the south pole of the moon. In much as the same way, we, Fortis Healthcare Bengaluru, have pioneered in organizing such a colossal event that is the Fortis Cancer Summit.
Strength does not arise from physical strength. It does from an indomitable will. And in this regard, we are fortunate enough to have with us our beloved chairperson, Dr. Niti Krishna Raizada, the Senior Director. Yeah. we're fortunate to have ma'am with us, who's the Senior Director, Medical and Hemato-Oncology at Fortis, Bengaluru, who befits this court.
We come together today, not just for an event, but celebration of a human connection and in pursuit of a greater purpose. Let us all come together in drawing the chariot of the Fortis Cancer Summit towards a grand success.
Once again, we welcome you all to this Fortis Cancer Summit.
A warm welcome to all. I would now like to invite the dignitaries onto the stage. To begin with, the Honorable Health Minister of Karnataka, Shri Dinesh Gundu Rao sir, MD and CEO, Fortis Healthcare, Dr. Ashutosh Raghuvanshi sir, Group CEO, IHH Healthcare, Dr. Prem Kumar Nair, Group COO, Fortis Healthcare, Mr. Anil Vinayak, Group Head, MSOG, Fortis Healthcare, Dr. Bishnu Panigrahi, Business Head and VP, Fortis Hospitals, Bengaluru, Mr. Akshay Oleti, the Organizing Chairperson, Fortis Cancer Summit, Dr. Niti Krishna Raizada, Senior Director, Medical and Hemato-Oncologist, Fortis Hospitals, Bengaluru.
We'll now begin with the lighting of the lamp. Shubham karoti kalyanam, arogyam dhana sampadaha, shatru buddhi vinashaya, deepa jyoti namostute.
As we are to commence our event by lighting the lamp of knowledge and wisdom, this is a symbolic moment that signifies the dispelling of the darkness and igniting of the thought and enlightenment. It is our honor to invite our Honorable Health Minister and Family Welfare, Shri Dinesh Gundu Rao sir, Dr. Ashutosh Raghuvanshi sir, Dr. Prem Kumar Nair, Dr. Bishnu Panigrahi, Dr. Ritu Garg, Dr. Mohan Keshav Murthy sir, Dr. Rana Patir, Dr. Niti Raizada, Mr. Anil Vinayak, and Mr. Akshay Oleti to do the same. Thank you all. I would now like to invite the heart of the conference, the organizing chairperson, Dr. Niti Krishna Raizada, the Senior Director of Medical and Hemato-Oncology, Fortis Hospitals, Bengaluru, to introduce the session and to enlighten us about the journey ahead.
ladies and gentlemen, our esteemed guests and distinguished participants. Thanks so much for joining us today at the very first Fortis Cancer Summit at Bangalore. Today, we embark on a transformative journey in oncology, a journey that is not inclusive of medical advances, but also changing lives and shaping the future of cancer care in our country. Our CME, which is CME accredited, is designed with a crucial mission to enhance the services to cancer patients by educating and empowering cancer care providers in the realms of precision oncology. And hence, this year's theme is Practice-Changing Advances in Precision Oncology, reflecting our commitment to pushing boundaries of what is possible in fight against cancer. I'm sincerely and heartily thankful and really honored to announce that amongst us, our chief guest is the esteemed Honorable Health Minister of Karnataka, Shri Dinesh Gundurao, sir. His support here and today actually underlines the significance of our collective efforts in navigating the present and building a future in prevention in cancer and, of course, therapy. We are honored to have our CEO of our group, Dr. Ashutosh Raghuvanshi, here as well. And Dr. Prem Kumar Nayak, who is our group CEO of IHH, which is our parent company. In collaboration with CNBC 18, on our Health Leaders Summit, we'll bring together minds from industry leaders across the globe. We have international faculty and delegates from over 30 countries, including prominent clinicians representing the best institute in every continent. This diverse gathering has 250 faculty members covering various subspecialties in oncology, showcasing our holistic strength in cancer care. We have over 1,800 participants today, which will flow in through the day. Our summit covers an array of groundbreaking topics, including implications of actionable mutations, path-breaking research in 2023, and neurotherapy and theranostics, and the role of artificial intelligence, which has revolutionized cancer care, and therefore a new dimension in precision oncology decision-making. We delve into innovative areas like liquid biopsies, CAR T cell therapy, a technology we have recently acquired in our system as well, and of course, organ preservation, reflecting the cutting-edge landscape of modern oncology. Our aim is to create an environment for sharing experiences, sharing challenges and opportunities, in addition to discussing the latest developments. Fortis Cancer Summit is not just about the elite, it embraces the future leaders. It's also our endeavor to provide platform for young budding oncologists and oncology students here today by their research and finding in podium presentation and poster presentations, fostering growth of knowledge and innovation. Technological advances have been discussed here, including the newer technologies which we have in our systems, including the newer generation gamma knife radiosurgery, robotic surgery in 7 important branches in our country, proton therapy, and MR-Linac. As I mentioned, also CAR T cell therapy, and other latest technologies which we have to explore the benefit in cancer patients with minimal side effect. We discuss here challenges and opportunities in Tier 2, Tier 3, and Tier 4 cities as well, where we emphasize inclusiveness. Prominent clinicians from these areas share their insights, which transcends geographical boundaries. In essence, our summit today is not just a gathering. It's a convergence of ideas, expertise, and compassion. It aims to create, to influence, and to bring together key opinion leaders of various domains and facets in oncology. Our intent is to create a future of oncology collectively, leaving none untouched by the transformative power of knowledge, of collaboration, and innovation. I invite all of you to participate actively, engage, and contribute in our journey. Together, let us try to make a difference, because the little things we discussed today have the potential to be the path-breaking reality of tomorrow. Thanks so much for being here today and being a part of us. A very warm welcome to each one of you.
Thank you, ma'am, for this session. I now request Mr. Oleti to come and take over in introducing our chief guest for the today, Health Minister Shri Dinesh Gundurao, sir.
Thank you. Ladies and gentlemen, it is my honor and absolute privilege to introduce Shri Dinesh Gundurao, Minister of Health and Family Welfare, Government of Karnataka. Shri Dinesh was a studious young man who completed his early schooling from Bishop Cotton School from Namma, Bangalore. So, definitely what we want to say, obviously sir has asked me to keep the speech as brief as possible, but there is so much to talk about it, and even a brief speech would be long, so kindly bear with me. So what I would like to talk about is his actual work on the ground and how he has energized the society into a very, very dynamic program, and how he is galvanizing the entire state in terms of healthcare. So his energetic organization skills, unwavering political will, and selfless service to the people through the party came to the notice and very quickly. And after 6 years of active politics, Shri Dinesh Gundurao was asked to contest the assembly elections from Gandhinagar constituency. What actually worked well was his simplicity, straightforwardness, and genuine concern for the hardships faced by the poor, downtrodden, Dalits, and minorities, and this won people's hearts. Even when we went to Sir's office to invite him for the event, his only request is, what are all of you doing for the society? How will the summit contribute to the society as well? So this is something that is running through his mind all the time, and we really appreciate a leader who is driving cultural shift and a healthcare shift through the society. The goodwill he has created amongst the people of his constituency and the state has seen him win all the general elections since 1999. This I have to say, sir. He has consistently and decisively won the assembly elections 6 times in a row, thereby attracting the title of undefeated Sardar. Solillada Sardar. So, big round of applause for that. In the recently concluded 2023 Karnataka Assembly election, his party emerged victorious with a resounding mandate, and he has formed the government. Further, Shri Dinesh has been assigned with the responsibility of Health and Family Welfare Department. He is working tirelessly to ensure proper treatment and care reaches to the even most remote parts of the state of Karnataka. He is working with establishing an organized and smooth functioning of the state health system so that it is responsive, responsible, and transparent. Some of the initiatives that he has taken in the recent past is that he has introduced 262 new ambulances with modern medical facilities to 108 ambulance services. He has launched Anemia Mukta Paustika Karnataka to overcome anemia and malnutrition. He has launched the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana here. He has launched the social awareness campaign and Mother's Milk Bank under the theme No Pneumonia for Better Childhood. He has done development of 200 health centers through CSR grant of 100 crores, Health Department. He has given directions to install 800 single-use dialysis machines across the state using the PPP model. Something that is very relevant to the Cancer Summit also is that he is also actively eliminating cervical cancer through effective screening, vaccination, and early treatment. And he has arranged for screening of all women over 30 years of age, and also arranged for universal vaccination of girls aged between 9 and 14 years of age. We have tried to keep it brief, sir, and with this we would like to welcome you to this Fortis Cancer Summit 2024, and we request you to kindly say a few words for the success of the event. Thank you.
It gives me great pleasure to be here at the inauguration of the Fortis Cancer Summit. On the dais, we have the Group Chief Executive Officer of IHH Healthcare, Dr. Prem Kumar Nair, and the MD and CEO of Fortis Healthcare, Dr. Ashutosh Raghuvanshi, the organizing chairperson, Dr. Niti Krishna Raizada, and all the other respected dignitaries, and all the doctors and experts from various fields within the cancer, the subject of cancer, and all the dear friends. Fortis Cancer Summit, I think, is a wonderful initiative because it's trying to bring in all the various experts from across the country and even from across the world so that people can sit together and exchange all the latest developments that is taking place all over the world. What is the cutting edge research? What are the new technologies and how they can be deployed? And how are the best ways to treat? And because medicine is such an evolving field today. And we see that there's ongoing research happening all across the country and the globe every day. And new developments keep coming up. So what is the most effective way of doing things for people who are healthcare providers? What is the most effective way of treating cancer, and how we can improve the way we function? So I think that is one of the key reasons why this Cancer Summit is taking place over here. And of course, as a government, when we think of diseases, cancer is definitely the thing which is becoming more and more prominent today. We see that incidence of cancer is rising across populations, across age, and it is I think every family, if you go and meet them, there will be somebody, one person or the other, who has either succumbed to cancer or who has had cancer and either is recovering or is still being treated. So it's becoming very prevalent. And the reasons for prevalence is something I think needs to be, more researched. Of course, apart from it being a genetic, the genetic reason for getting cancer, there are issues concerning our lifestyle, issues concerning the way we the food we consume, the physical activity that we have, and all these things are interconnected. But the obvious thing is that cancer incidence is rising, and also younger people are also getting more and more afflicted with cancer. Even children are getting afflicted with cancer. So it is a subject of great importance to any government or any institution which is looking at public health. How do we tackle this? For us, of course, for us, what we need the most is how we can prevent it. How can we even prevent cancer from, infecting anyone? So that is something that a government is, as a government, because that is the best way of eradicating cancer. But if you cannot prevent it, how can we detect it early? How can we catch them at an early stage? And for us, that makes a huge, is of great importance to us, because in the rural populations and amongst the poorer sections, once someone gets cancer, the very word cancer itself, they get emotionally and psychologically affected, because how do we manage this? And if it's detected late, then the cost burden on the family, the financial, emotional, all kinds of things happen. And it really, is a huge setback to a family when someone gets affected by cancer. So our aim is to see that how we can help those people to be able to get through with their lives with the minimum disturbance. And for that, I think the key for us is to catch them early and to be able to screen them early, to find out early. So that's that is one of the focus areas for us as a government, that we're looking at how can we screen them. And that's where I think we need extra support from the private sector and from people who are coming out with new technologies, that what is the way of detecting cancer early. I can see a lot of discussion here going on about how we can treat cancer. Yes, that is very important. But what are the other methods, easy methods, which can cut across populations, people who are living in villages, people who are living in small towns? How can we access them, and how can we have a mechanism of finding it out earlier? Because people don't want to get themselves tested. We have camps, and when we have camps, nobody is willing to come and get themselves tested, because there's already a fear factor. So if you're checking for cervical cancer, if you're checking for breast cancer, if you're checking for oral cancers, which can be found out with simple tests, most people don't volunteer to come, because it's something that they don't want to know about. I think even you and me also will never volunteer ourselves for any test, because we're all worried and scared that we may be having something, or we don't want to, or we push it away. We don't want to confront the fact that yes, we need to check ourselves regularly, because we ultimately, as a human psychology, we tend to push it away. So the poor people living in villages, nobody wants to get themselves screened or scanned or whatever. So better technologies enable to detect early on stage of cancer. So that can really help governments, because for us, budgets are always a constraint, and there's always a pressure on where the money has to be spent. So the lesser money that we can spend and cure someone, that is the only way for us to be able to reach out at a mass scale. So that's something that I would urge all of you, especially people who are working on the research and people who are working on new technologies and on equipment and screening equipment, to be able to come out with new ideas on how we can detect cancer, various kinds of cancer at an early stage. And that is something that we are also working on. We are trying to use artificial intelligence. Like another thing that we have done now is we've tied up with AstraZeneca, and all the X-rays that we take across the Karnataka, so that will be scanned using artificial intelligence, and any X-ray for any purpose of the lungs, if that shows up for cancer also, for lung cancer also, it's being screened using AI. So that people come for various reasons to the hospital, and if they get a chest X-ray, automatically that goes in for an AI screen for lung cancer. That is something that we are doing now. And hopefully, if we can find out a few people, even if it's a small percentage, even saving one life becomes important for us, because every life is important. And that is something that we are working on. Similarly, of course, cervical cancer, there's a way forward. We have the HPV vaccine, which we are also urging the government of India to make HPV vaccine part of the vaccination package that we have when we give people vaccines for various other diseases, because HPV vaccine is something, cervical cancer is something that can be eradicated, if provided we vaccinate and we also detect it at an early stage. So these are the few ways forward that I am looking at. But there are so many other cancers which I think is beyond our scope, and that is something, if you people can throw light, it will be wonderful for us. And the cancer treatment that you're looking at, I think the technologies that are available today is really amazing. I've been seeing a lot of places where they're using new technologies, the LINAC machines, the proton beam therapies, and various other highly cutting edge and expensive treatments. I think for us as a government, it's unaffordable right now, but because it's right now at a very expensive stage. But I'm sure today's niche is tomorrow's norm. So maybe 5 years, 10 years down the line, this will become a much more cheaper way of treating people, and it can, we can use it across populations. I remember some 10, 15 years back, to go and get an MRI was really a very difficult task. And getting a CT scan was also very expensive and out of reach of most people. Today, getting an MRI and getting a CT has become most common. And in government today, we have taken another policy that we are opening up MRI and CT scans for all our people free of cost at our district hospitals. We are installing MRI machines in all our district hospitals, and so that anyone who's below poverty line can go there and get themselves scanned. So 10, 15 years back, it must have been very expensive and out of reach. Today, it is affordable. So any cutting edge technology has that evolution process of when it comes in, it's really for a niche or for a very few people, and then it starts spreading out, and then it becomes more prevalent and more becomes the norm. So there are so many things that you people are doing here, and I think cancer treatment is getting better and better. People are, more and more people are recovering, and the kind of precision work that we are seeing in being able to treat the person with cancer and not affecting them, physically and in terms of health and in terms of appearance, it's seen a tremendous growth. Because I'm myself a person who's seen how cancer can affect a person. Because my own father, he passed away. My father passed away of acute myeloid leukemia almost 30 years ago. So I saw that time these kind of treatments were not available. And today's treatments are far, far, far better. So it is something that I think it's wonderful that India is becoming a place, a destination for research, for new inventions, new discoveries, and also making it, I think, affordable also. Affordable in the sense what someone pays in the United States or in Europe, if they come to India and get that same treatment done, it's at a much lower cost. So it's affordable in terms of, for many people across the world to come to India and get themselves treated. So India is becoming actually a medical hub today because we have got the best of talent. The talent pool is there, the doctors are there, good technicians are there. There are various institutes today that are doing so much of work in research and in finding out, and we have such a huge population, so there's so much of data that is available, so much of research can be done in India because of the data also, the kind of vast numbers that are there. So I think India is now at a place where we are a knowledge hub, not only in medical, but in all other fields. India is becoming a knowledge hub. And that, I think, should be really used in the most effective manner. And for that, I think private initiatives like what Fortis is doing, and of course from government, whatever that we can do to support you, we are always there. We will always be by your side to see whatever assistance you need in this kind of work. We will definitely try to extend it to our utmost capacities. So saying these few words, I want to congratulate the Fortis Cancer group for having organized this summit, and I'm sure that this kind of events will encourage people to open up, to take in new ideas, to give out new ideas. The sharing of knowledge is what leads to, I think, greater and better output, and I think that is what this summit is all about. And I want to thank them once again, and I wish this summit all the very best, and I'm sure this will lead to better and greater and more efficient, more effective cancer treatments for all our people in India. Thank you very much.
Thank you, sir, for such wonderful and encouraging words. I now request Mr. Akshay Oleti to felicitate the inaugural. I request Dr. Ashutosh Raghuvanshi sir and Dr. Prem Kumar Nair to felicitate the guest of honor, Shri Dinesh Gundurao sir. I now request Dr. Ritu Gar, Chief Growth and Innovation Officer, Fortis Healthcare Institutions, to introduce the guests of honor.
It's indeed a big privilege for us to have with us the Group CEO of IHH Healthcare, Dr. Prem Kumar Nair, join us. He's flown from Singapore to be here with us today. Thank you very much, Dr. Nair. Dr. Prem Kumar Nair took over as the Group CEO of IHH in October last year, and he leads a team of more than 65,000 employees to realize IHH's vision to be the world's most trusted healthcare services network. Dr. Nair sets the strategic direction for the sustainable growth of IHH's global network, which today comprises more than 80 hospitals in 10 countries. Guided by its care for good aspiration, Dr. Nair continues to build on the IHH portfolio of strong and reputable brands across multiple countries, including Acibadem, Mount Elizabeth, Prince Court, Glen Eagles, Fortis Pantai, and Parkway, to touch lives and transform care globally. Dr. Nair is a physician and healthcare executive with over 3 decades of experience in both public and private healthcare sectors. He's been a recipient of multiple awards, including Public Service Medal, Public Service Star, and he's also a Justice of the Peace. Pleasure to have you with us, sir. Would request you to share some words. Thank you.
Thank you very much, Honorable Minister, colleagues, leadership, doctors from far and wide, I understand from both India as well as from overseas. It's indeed a great pleasure and honor to be here. When I first heard about the Fortis Cancer Summit and I was invited, I told my assistant that I would very much like to be here. It's the inaugural summit, and it was, the program was exceptionally cutting edge, I must say, and for this a lot of credit needs to go to the organizing team. They have put up a program that shows the best of cancer diagnostics and treatment. And of course, we are very, very grateful to have so many distinguished clinicians here with us, academicians, who will share all aspects of cancer diagnostics and treatment. I also want to say that since I'm in Karnataka and Bangalore, that I'm coming here after quite some time, and it's indeed great to see the developments here. From the moment I stepped into the new Terminal 2, I was thinking to myself, this is one of the best airports. I travel a lot, almost 60 to 70% of my time. And me and my colleagues who arrived last night were
just amazed at the efficiency, the beautiful terminal, of course, all right, and then the highways leading into the city. So I must also congratulate Karnataka for the developments, not just in medical science, which of course I'm very familiar with, all right, but also in developments in many other areas. So with that, I would like to congratulate the organizers. I wish all of you a very, very fruitful summit. Thank you very much.
I request Dr. Ashutosh Raghuvanshi sir and Dr. Niti Krishna Raizada to sorry for that, to respect the guest of honor, Dr. Prem Kumar Nair, with a token of appreciation. I request Dr. Ritu Garg to take over, please.
I would now like to introduce and invite a leader we look up to for our inspiration and without whom none of this and anything else would be possible. Dr. Ashutosh Raghuvanshi, Managing Director and CEO of Fortis Healthcare. Fortis is one of the largest healthcare providers in India with a network of 27 hospitals and over 400 diagnostic centers. A cardiac surgeon turned management leader, Dr. Raghuvanshi has over 35 years of healthcare experience with numerous national and international healthcare awards. He also represents industry in various forums, including CII, FICCI, and Nat Health. A globally recognized figure and a trustee for various charitable trusts and philanthropic foundations. Dr. Ashutosh Raghuvanshi. So we would request you to please.
Honorable Health Minister Shri Dinesh Gundu Ji, all distinguished clinicians and guests, ladies and gentlemen. I welcome everyone to this Fortis inaugural Cancer Summit. It's a landmark clinical conclave. The story of human existence and evolution is a narrative of successful conquest over seemingly overwhelming obstacles, and cancer seems to be one of those. But this conquest against the cancer is reaching a decisive stage, and as we witness today, the power of precision oncology. Along with the technological advances, our approach towards cancer treatment has become more holistic, and we are looking at several other aspects like integrative, palliative support, psychological support, and nutrition, etc. So the aim of Fortis Cancer Institutes is to provide a holistic care to our patients and reduce the pain, suffering, and improve the quality of life of the survivors. So we have together about 800 specialists here today, as we've been told, and the entire Fortis network has contributed to this program. I thank all those who have taken time off from your busy schedules and you're present here and you're sharing your clinical expertise and knowledge with us. Especially our guests from overseas, I want to thank them for making this effort. With this inaugural summit, we will be commencing a series of events dedicated to enhancing the innovative cancer treatments, and also we are going to be launching a Fortis cancer prevention program in which early diagnostic is going to be a crucial part of it. I am very excited to know that the kind of programs which have been launched in Karnataka for early diagnosis of cervical cancer and the vaccination program, we would like to participate and support those programs as an organization. We have also planned similar programs in the state of Haryana as well. I'm very, very excited to hear all the initiatives which are happening in Karnataka, and we are going to be a small part of it, but I think this is going to make a lot of difference to the suffering of people over here. I thank you, sir, for taking time off from your busy schedule and being here with us. It encourages us, and listening from you, the programs and the initiatives which the government is taking is very, very encouraging. Thank you so much.
Thank you, sir. I request Dr. Neeti Krishna Raizada and Mr. Akshay Oleti to present Dr. Raghuvanshi with a small token of respect. Thank you, sir. Thank you, ma'am. I now request Dr. Ankur Bell, Senior Director, Medical Oncology, Gurugram, to give the vote of thanks.
Yeah, Namaskar, Bengaluru. So, ladies and gentlemen, esteemed guest, guest of honor, Honorable Minister, and my dear fellow cancer fighters. So, it's a great opportunity. I express my gratitude of respect and thanking you all for being here. We are here to get wiser. I think every one of us will take a 1 point back to our home, 1 point back to our practice, and maybe our Monday morning practice changes a bit for the betterment of our patient, for betterment of our cancer patients. I want to thank Rajesh, Chief of Mice Ideas, for making this show absolutely flawless. I want all the organizing pharma companies for giving us generous contributions so that all these things can happen. Without them, it will be very difficult. So the summit has just started. It's still 2 days of summit. Let's get wiser. Let's train each other. Let me train myself. Let me train you. And so that my patients are better, their survival becomes better, and we have a ethic, fruitful oncology practice. Thank you so much. Over to organizers.
Well, it's indeed been a wonderful morning. We've had exemplaries from all over who've shared their amazing words and have been very thought-provoking as well. I would now like to request everyone to break for lunch, get some energy which is needed, of course, and imbibe for the sessions coming after. Thank you. The lunch will be served at 4th floor.
करना है ना अमित हम मैम को करना है समझिए
क्या लाना चाहते हो
सपोज कुछ मोमेंट और कुछ भी आप
check. Check. Check, check, check. 1, 2, 3. Check. Check. Check, check, check. check, check, 1, 2, 3, check, check. Check, check.
cannot use Microsoft Excel without watching this video.
फ्लाइट्स, होटल्स एंड मोर सब मिलेगा अगोड़ा पे।
अगोड़ा।
Good afternoon and welcome back. This was the hall that we were sitting before, and now there's a partition dividing the breast and the lung. Just like the chest wall that we have, you know, breast outside, lung inside. So sorry for the analogy, but I am a surgeon, and that is what the surgeon's role in thoracic has been limited to now. Anatomy, anatomy, anatomy. But what we are trying to do is collectively make our lung patients live longer. And somehow, luckily, thankfully, drugs, systemic therapy is helping us, and we are seeing that difference amongst our patients. To take this thing for the next 3 hours, we have a wonderfully curated thoracic oncology session. Obviously, it appears to be heavy on medical oncology, but that is how the practice is. Very, very fortunately, we have a group of speakers who are well nuanced with the latest which is happening in the field of molecular oncology, immunotherapy, and the flavor of the season, that is precision oncology. So to take it forward, I'll invite the chairpersons for the next session. If you all have your programs in front of you, there is a slight change, and we'll come to know a welcome change for us. I'll first invite the chairpersons for the lung session. The chairpersons for the first session are Dr. K. Govind Babu, eminent medical oncologist from Bangalore, Namma Bangalore itself. Dr. Sudarshan GT, again from Bangalore. And from north up, cold Delhi, Dr. Dinesh Singh. He's not a cold person otherwise, he's a very warm person.
So good afternoon. Let me start by thanking the Fortis Scientific Committee for asking us to chair this session. And the first talk is going to be by Dr. Prasad Narayan from Bangalore. He's a wonderful speaker and a good academician. He has another talk because of him being an academician. So he'll do this talk here and then go. Welcome, Prasad.
Thank you, sir. I thank the organizers for this opportunity. We heard that we have been divided now into 2 sessions, and it is a medical oncology loaded session. It happens so because only medical oncologists can keep you awake after lunch, actually. So that is the reason why these sessions are kept like that. No, there is a reason. So I will speak about adjuvant immunotherapy in early stage lung cancer. That was what I was given the topic. And now I realize that some of my slides will be eating up Nitesh's next talk actually, but it's okay. So when I started training in medical oncology, we never thought about even adjuvant chemotherapy in lung cancer. From there, we have come a long way. Adjuvant chemotherapy came, then the role of immunotherapy, the role of targeted therapy. So when we talk about non-small cell lung cancer treatment, it is recommended that we get a PD-L1 test done in the neoadjuvant, adjuvant, or advanced cancers. Definitely we are getting broad-based NGS testing, PD-L1 testing. Also with the present day role of getting anti-EGFR therapy in the adjuvant setting, we are getting those tests also done. Now we do this in all patients because there is a role of giving immunotherapy in neoadjuvant, adjuvant, and also in the advanced setting. So this is a slide to say the evolution of treatment. So we used to treat all lung cancers as the same, then NSCLC versus SCLC. I have even debated with Govind Babu sir once whether there should be a adenocarcinoma versus squamous cell carcinoma differential kind of therapy when the first trial came of gemcitabine versus the other line of therapy. So now we have moved a long way, and we have so many drugs which got approved in advanced NSCLC. So when you have these many drugs which are there in advanced stage, we should also expect that some of them will move towards the front lines, and that is what has happened. We had the data on the anti-EGFR therapy in the adjuvant setting, which is the standard of care now, and we will also look at the immunotherapy here. So let me start with the role of the topic here, in stage 1 to 3 NSCLC, what is the role of immunotherapy? This is the first trial which put this in perspective. So this is the famous specific trial, 2018 publication, and got approval for durvalumab based on this. Very good study, very well planned study, and they took they took an area where nobody else was getting into at that time. That is concurrent CTRT, and we were stuck with chemotherapy in this group of patients with radiation and different lines of chemotherapy being tried. Nothing was improving survival. So this is a landmark paper by all standards, where when you compare with placebo, when we combine immunotherapy with chemotherapy, there is definite improvement in 5-year survival. So this is the specific study which established the role of consolidation durvalumab. Now this has also moved forward. We also have a study now which is ongoing in our center is also taking part, where we are adding one more immunotherapy to durvalumab and see whether we can improve on this. Because even this, a 5-year survival of 40% in a curative setting, is not something which we can say that we have achieved everything. And there is a lot to improve in this group of patients. With this, let us see what are the data which we have now on immunotherapy in resectable NSCLC. So the data is there with the neoadjuvant setting, perioperative setting, of which I will not speak much because there is another talk. I will just show some slides on that, and adjuvant setting. So neoadjuvant is one of the most interesting designs for a medical oncologist, because we have a very easy, hard endpoint of pathological CR. I am sure that the surgeons won't be very interested in this, because most of the surgeons even feel that a neoadjuvant chemotherapy itself is not required in lung cancer. But we don't see many patients who are directly resectable. This is the community practice scenario. Even in advanced, in the referral hospitals, I don't think many patients are easily operable. So definitely if you have something in the neoadjuvant setting, that helps. So in this slide, if you see, the one with asterisks, these are all FDA approved treatments. So we have neoadjuvant approval for using nivolumab with chemotherapy. I will discuss the data. In the perioperative setting, all these trials have similar design. That is, you give chemotherapy plus immunotherapy, you follow up with immunotherapy maintenance. All the 4 drugs of immunotherapy which were approved in the advanced setting were tried in this sequence, and all of them showed good response, which is very interesting. And the adjuvant study. So adjuvant chemotherapy came, and now we have data on adjuvant immunotherapy. Both these trials have led to FDA approvals, and they are now accepted as NCCN standard of care for atezolizumab and pembrolizumab. So let us start with the nivolumab study, which is the neoadjuvant setting. Well-designed trial. All the patients who have resectable stage 1B to 3A NSCLC, they should not have any EGFR or ALK mutations with good performance status, got either 3 cycles of chemotherapy or the same with 3 cycles of nivolumab. So that's it. Very simple design, very clear endpoint of path CR and the EFS. So EFS, I'm sure that we will be discussing whether that is the endpoint which we want to see, but definitely the path CR being a hard endpoint helps to design this study. 179 patients in each arm. Patients underwent surgery within 6 weeks post the therapy. And exploratory endpoints were overall response rate, feasibility, peri and post-operative surgical related AEs, etc. So 24%. So 24% of the patients who got 3 cycles of immunotherapy with chemotherapy got pathological response. And this included patients from stage 1B to 3A. So this is incredible result actually. We never talked about pathological response. You see that the only chemotherapy and the pathological response is 2%. So that is definitely a positive study. Whether this will translate into overall survival improvement or not, it should actually. If you see the EFS curve, at 3 years follow-up, 43% of the patients who did not get immunotherapy versus 57% of them have no disease. So there is an improvement by 14% there. The EFS in months, if you see, it has not reached versus 21 months. So in this group of patients, definitely this makes a difference. And it is not like a treatment which has to be given for 1 year or 2 years like that. So 3 doses of immunotherapy. And another thing which should be looked at will be the data on giving a kind of low dose of immunotherapy. Whether this is the dose which we want to give is something which can be looked at in an Indian scenario with a cost perspective. So definitely it's a positive study. And these are the perioperative studies. This all can be clubbed in one slide because the design is almost same for all of them. You give patients 4 cycles of neoadjuvant therapy, either chemotherapy or chemotherapy with immunotherapy. All of them get surgery, then followed by immunotherapy for 12 to 16 cycles. So all the drugs, the pembrolizumab, durvalumab, nivolumab, and atezolizumab have been tried in this scenario. And let us see some of the keynote study. This led to the approval of pembrolizumab in this scenario. I'm sure that the next speaker will be speaking more about these studies because that topic is basically on the perioperative therapy. Here again, there was a PATH CR in 18%. So 18 to 20% of the patients get a PATH CR if you are adding immunotherapy to chemotherapy in the neoadjuvant setting. And definitely an improvement in event-free survival was seen. So in the subgroup analysis, PDL1 TPS score more than 1 was linked to better outcomes here. This is the overall survival curve at 48 months follow-up. So at 48 months, 2/3 of the patients who get immunotherapy in the perioperative settings are surviving, which is very, very significant in this group of patients. Similar results with durvalumab, PCR and EFS being the endpoints here. Almost same kind of results, same kind of EFS curve also. And if you see nivolumab in the resectable setting, PCR rates were slightly high here, 25%. So we can say roughly 20 to 25% is the PCR rates. And EFS also similar, all the curves are separating in a similar fashion. So that is about the perioperative setting. So now we talk about the adjuvant immunotherapy trial. So there are 2 trials which looked at adjuvant phase of immunotherapy. So to put this in perspective, all the patients who are having resectable lung cancer, which is defined from any stage from stage 1B, which is a tumor of more than or equal to 4 centimeters, stage 2 or stage 3A, after complete surgical resection, the present standard of care is to give them 4 cycles of platinum-based chemotherapy. And the chemotherapy protocols mostly followed in adenocarcinoma are usually pemetrexed and cisplatin. The approval is for pemetrexed, cisplatin, or gemcitabine, docetaxel, vinrelbine plus any platinum. And the IM-Power 010, the trial which looked at atezolizumab in this scenario, chemotherapy was mandatory. All the patients got chemotherapy. Primary endpoint was DFS by investigator. And in the PDL1 plus positive stage 2 to 3A group. And all the patients who were stage 2 to stage 3A. The keynote study, which is the pembrolizumab study, is even more interesting. Similar group of patients, stratification based on the PDL1 status here. And the patients were, it was not mandatory that they get chemotherapy. We can just give immunotherapy for 1 year versus placebo. Primary endpoint was DFS. So long-term follow-up will tell us the OS in this how significant it is. It is always, there is a limitation of comparing 2 trials on side by side, but definitely this is interesting to look at actually. So if you see the disease-free survival in the intent to treat population, there is a difference. In the best supportive care group, it was 37 months with in the IM-Power study versus 42 months in the keynote study. And it is not yet reached in the atezolizumab study. It is 53.6 months in the percentage in the keynote study. So these 2 trials are significant for their primary endpoint. And based on this, there is an approval for adjuvant therapy in patients with stage 2 to 3A non-small cell lung cancer who have PDL1 expression more than or equal to 1% for using atezolizumab. And also there is an FDA approval which came in Jan 2023 for based on the keynote study. And the keynote study, mind you, all the patients did not get chemotherapy. So if you see this by subgroup, with the IM-Power study, as the patients had higher PDL1 score, their survival was better. But it was not much different in the based on PDL1 in the keynote study. And most interesting point to take was that in the keynote trial, the patients who received adjuvant chemotherapy along with pembrolizumab, they benefited better than the ones who did not get chemotherapy. And all other stratification factors, I don't think that there was anything majorly significant. The trial was positive for most of the subgroups. So that when you see this slide, we saw the data on neoadjuvant immunotherapy, which I think scores because it's an easy to give and it is not very expensive and there is a hard endpoint. If you can give 3 cycles of immunotherapy along with chemo and we get a pathological CR, we can say that the patient doesn't need any adjuvant immunotherapy, because now with all the data which has come, adjuvant immunotherapy should be discussed with all the patients. So what is the advantage of neoadjuvant? Shorter treatment time, better compliance surely, because it is a short duration of treatment and the patient has not gone to the primary, the main treatment. So the patient's interest to come back for therapy also is higher in the neoadjuvant setting. And we get when you talk about hard endpoints, we get something to assess. We get a scan to see the response. We get a surgical pathology to see there is a pathological response. And suppose somebody doesn't get a pathological response, we can say that there is some escalation of treatment which is possible. So neoadjuvant is something very interesting there. Perioperative treatment is just like adding something to what we already know. So we know that we give chemotherapy to the patients, mostly in neoadjuvant setting. We follow that with surgery and adjuvant chemotherapy in some of the patients. So perioperative immunotherapy is just riding on the data which we already know about the role of chemotherapy here. Interestingly, all the 4 drugs which were approved in the metastatic setting were tried in similar design here, similar duration of treatment and similar results. So definitely perioperative immunotherapy is going to stay, and depending upon which group of patients we want to use a perioperative management, and there the multidisciplinary team comes in play, whether the patient receives any neoadjuvant therapy or a primary surgery is being done, and the adjuvant data. So when the lung cancer adjuvant chemotherapy data came, that was being debated in big time, whether the adjuvant results of what the small percentage of improvement in survival was significant. Just like the lung and breast sessions were divided here, we used to debate that for 4% improvement in survival, we give chemotherapy for all the patients in breast cancer. Why don't you give that to lung cancer? Are we ignoring the lung cancer patients? But it was not a big debate because many patients didn't come into the adjuvant setting. Like many patients, the number of patients who came after a resectable tumor was very less. But definitely these 2 trials, and especially the pembrolizumab one, which has given a survival improvement without chemotherapy, is really significant. Here, the surgeons cannot say that there is a surgical delay. You can't talk about perioperative risk due to preoperative therapy, and there is a complete pathological staging which happens. So, but the disadvantage here is the longer treatment time, which is almost 1 year. So that's the last slide. So in a nutshell, immunotherapy has come big way in early stage lung cancer. The role is established along with radiation in a curative scenario as a neoadjuvant therapy if surgery is being planned, or as perioperative therapy, and also now with the approvals in the adjuvant therapy. Thank you.
Thank you, Dr. Prasad. Very nicely it has been put in the perspective. And any questions or comments from the audience? Yeah.
Right.
In those patients, can they go for radiation?
Of course.
Medically not fit enough.
If the patient is not fit for surgery after neoadjuvant therapy, the patient will get a curative Indian treatment, which will be radiation, right?
Dr. Prasad, I would like to know any benefit in the OS in these studies, has it been seen?
These are all studies which did not look at, I think the OS data is immature, sir. That is why the approval has come only for few of the molecules in few of the scenarios. And the approval has been given based on PATH-CR in the neoadjuvant setup.
Okay. NDFS.
Right.
So, sir, can I just make a comment, or because sir is also here? I am a surgeon, I told you, so I look at myself getting, more and more redundant probably if the IO is going to make it, if it's going to improve PCR rates, and they are going to tell me that, you don't need to even operate because the PCR rates are going to be so high that we might as well leave it. So what is the possibility of giving radiation to that area when we are expecting PCR rates to be that high, and probably if the PCR rates are 60% and above, then the radiation oncologist might say that no, don't operate it. I might as well just boost it with radiation and let it be. I mean, is that a possibility, or is it still happening and we just don't know about it?
I think each organ is going to, if you, let's extrapolate from a Sano-O trial, right? We were trying to say that in esophagus, after NSCTRT, we'll wait and watch because our PCR was 60% plus. But what happens? The survival changed. A distant metastases number, so a local control fast with surgery is also important, right? And that will also determine your further treatments. So all these pre-op also, there were many of them like EGFR positive also, and they were not going across. So basically it is now all comers together. Definitely I can treat them, there is no doubt. The short-term pneumonitis is probably going to go up, but there are a lot of ifs and buts which are going to be there. And definitely there are some patients who are not going to complete the surgery because they run down, or the other itis becomes important, like rheumatoid and the chest and all those things becomes, we radiate. We have radiated quite a few, but we are always on a back foot. Two reasons on a back foot for us as a pure radiation oncology: what volume I should take it, especially in the nodal areas. That is really a challenge. And the second, the dose. Shall I maintain the same dose, or in a possible of a PCR, I reduce the dose to reduce my toxicity? So those are my challenges, but a time will come that automatically will refine those things, not a big deal.
Sir, like there were a lot of retrospective studies in which they have compared medically inoperable cases getting radiation versus surgery. I mean, like surgery. The results are almost similar, and if we do surgery in not so fit enough medically inoperable cases, post-operative deaths were very high, sir. Almost 90% of patients died after 1 month of post-medically marginalized patients, sir. So whenever the patient is not fit enough for surgery, the next best option is radiation, because we have a lot of system SRS treatments and good treatment techniques, sir.
Right. I think there is no doubt about that, yeah.
Sir is talking about that European trial, that there are more deaths in the right side and when you are doing pneumonectomies. Am I right? But they were very far and few, really, to speak 9% or less. But the overall total outcomes were same. Either you give with RT or without RT NSCTRT. So that was a different story altogether.
If it is operable, definitely go ahead with surgery, sir. But if it is not operable, marginalized cases, which are high-risk cases, when they have attempted surgery, the post-operative immediate 1 month deaths were almost 90%, sir.
Right.
So I wanted to say is that, how would you know it's a pathological CR unless you've
If you don't operate,
patient,
right.
So that would be the question. So I would be very skeptical in not doing the surgery, because what if there is microscopic disease?
I'm happy everybody is agreeing to do a surgery. I'm just drawing consensus.
Don't worry, you won't lose your job.
Thank you.
Yeah. One question, Dr. Prasad. Hi. I am a surgeon. So already with the present existing other therapies, the patients coming to the first to surgery is very less. So for a resectable cancer, how would you decide which patient will go for immunotherapy, which patient go for a combination of a neoadjuvant therapy?
So I think if a patient is primarily operable, I don't think that so many surgeons will be ready to give neoadjuvant therapy. But with this data which are coming up, we should see whether a PATH CR, PATH CR doesn't mean that there is no surgery, right? Whether that patient who gets a PATH CR by giving a neoadjuvant therapy gets a better outcome in terms of overall survival, we should discuss that with the patient. And 3 cycles is not a big thing. Yeah.
Yeah, Prasad, I think what you said is right. So I think we can draw analogy from breast cancer.
Right.
You know, today even operable breast cancer are getting neoadjuvant.
Right.
So I think that's the way we'll go. Yeah, the next talk is by Dr. Nitish, and he'll talk to us about perioperative immunotherapy in early lung cancer, a paradigm shift. Yes,
Thank you, sir.
Nitish.
And
Welcome
thank you,
to Bangalore.
Prasad, for the wonderful talk and actually for doing my talk as well. So, but before I start, I'd like to address that question which you asked. So, really the question is not about pathological CR. Pathological CR, as Prasad rightly put, was the marker that was used to decide if neoadjuvant therapy is useful at all or not. Because if it had not increased pathological CR, the probability that it will increase survival was negligible. So the trial design was primary outcome as pathological CR. But of course we all know, the question is long-term survival, and those graphs are very interesting. And I'll add a slightly different kind of put to that. So the topic is perioperative. I'll also cover a little bit of Prasad's slides since he covered mine. This is the simple chronological order. We all know this, but it is extremely interesting. If you see the extreme right, how busy this slide has got and is likely to get over time. And we can see how the bombardment has happened entirely because of targeted therapy and immunotherapy. So very important drugs which are changing the landscape of lung oncology, which, as my father put, when he was doing practice, lung cancer, he used to tell those patients to not go back to the hospital because the average survival was 2 months. But the background here, which I really want to bring forward as a concept, is about immunotherapy while the primary tumor and the lymph nodes are intact. I think this is the basis, this is the principle of neoadjuvant immunotherapy here. Because we do know already that the main interaction of the antigen with the T cell, which then become learned T cells and can fight cancer and improve EFS, is happening at the lymph node level. So in fact, it made a lot of sense, and I'll come to Artizo data in a while, but it made a lot of sense of doing this before surgery. In fact, there's a very interesting melanoma study from the ESMO 2022, which clearly shows that if you take the 17 cycles of adjuvant pembrolizumab in the adjuvant melanoma setting, and you divide that into 3 before surgery and the remaining 14 after surgery, there is a survival advantage. That study did not have any difference at all in anything else except 3 before and 14 after, and there was a survival difference. So we do know, and this is the first point to be made here, we do know that the tumor and lymph nodes presence as we start immunotherapy is important. The second point is here, and I think this answers, Dr. Dinesh, your question of overall survival advantage. Please remember, this is lung cancer. 45% patients or less are going to survive 5 years. All our lives so far, when the chemotherapy and everything came in, our average 2-year survival never crossed 50%. So if we never cross 50% as 2-year survival, changing that number itself is actually somewhat acceptable as a predictor of long-term survival. Whether it really changes OS or not, I guess we don't know, but it is an acceptable output. The third point is that 30 to 70, this is what I was trying to make, that the risk of recurrence is highest in the first 2 years. We are aware of that also. We know every lung cancer graph, which is not EGFR, ALK, and ROS anymore, drops in the first 2 years. We've always seen that steep drop in survival, and you can see that in the bar chart here. We know lay study as well as the neoadjuvant cause 5% advantage. We know, I think that's what we just discussed, that post-CTRT surgery pneumonectomies can be more harmful. So we know that there's a lot to cover, and we have to find therapies which are easier. Prasad very nicely alluded to the neoadjuvant and adjuvant. These were the ones that were tick marked, which have shown a positive trial and have been approved. But essentially, we'll go one by one again, just like Prasad did. And I'm going to add a slightly different take to that. So this was simple AGN, durvalumab, versus placebo. And they did do the combination followed by surgery, followed by durvalumab. So that's the first question Prashad was trying to raise, which is, should we be doing pre and post, or actually only pre? Now, I have circled this number 63, and it is absolutely surprising. It almost seems like only one company makes immunotherapy. Every time you give immunotherapy, in any setting, except one trial, that number at 2 years is between 60 and 65. It's almost surprising, and I'll show you every graph and see how that number is 60 to 65. Almost it feels that we have raised the bar of a 50% survival by 15% at 2 years, remembering that the majority of patients who recur at 50% patients recur at 2 years. That's a big number. And this study obviously showed that almost everybody benefits, some with less confidence interval, others with more, but almost everybody benefited. Do note that the performance status 0 patients, which is where immunotherapy works best, we already know that. Current smokers, please don't smoke, but current smokers benefited, and the entire TC less than 1 to 49, as well as more than 50 benefited. And this is, again, I think Dr. Govind Babu once commented on this also in ICC or something, I forgot, but this is very interesting how from a palliative setting to a non-palliative setting, we're seeing the loss of PD-L1 50% as a predictor. Why? Not entirely sure. Could it be that we're not really causing a reduction in volume? So we really don't need a response rate, which high PD-L1 causes, but we are trying to create a memory T cell which will finally fight the cancer and therefore improve outcomes. This was the pathological CR, a big 13% different, and even when centrally seen, in fact, the difference was higher. And the pathological CR again was seen most in never smokers, and the higher stage 3B did not have as much effect. It was a little bit more cost in the confidence interval, and that is to be expected. With this came in very interesting keynote 671. This, to my mind, was the key perioperative trial. Very interesting, their PD-L1 was divided in 2 groups, more than 50 and less than 50, and they were looking at EFS as per investigator and overall survival. And that number 62 comes again at 2 years. And this time, please note that the baseline, and I'm not doing a cross-trial comparison, but the baseline here at 2 years is 40%, while the baseline in the durvalumab was 50. But the survival at 2 years is still 62%. And when you look at overall survival, you can see the curves are matching till almost 2 years, and then they start separating out, re-emphasizing my question that does immunotherapy, unlike metastatic setting, is not really killing anything, but just creating an immune memory that helps fight this cancer for longer. This was the pathological CR, and this was again looking at the 2 years and the 3 years overall survival, which is clearly very good in the keynote 671. So I'm coming back to this slide because I was trying to put this across at a point that if we look back, our 5-year survival was 30 to 40%. And if we look at the overall survival curve as 671, and you can see at 5 years, we're still sitting from a 30-35% to a 50%. So that 15% gain seems to be clear. That's a very big number in oncology, 15% gain. For 3% gain, we have changed guidelines. So for a 15% gain, that's a very big number because this is high risk cancer by definition. So obviously the changes will be large as well. So with this we come to checkmate 816, which is nivo chemo versus placebo again. And again in the EFS, if you notice, you're sitting at a 64% at 2 years when you give nivo chemo versus a 45% when you don't give chemo. So they're sticking to 65%. I think I'm trying to emphasize here that it doesn't matter what you're using, you are improving outcomes in the perioperative setting, especially by giving it in the neoadjuvant setting so far. That's what we're discussing. I think the adjuvant was a bit of a surprise to me, so I will come to that in a minute. The last is Checkmate 771, which was stage 2B, perioperative nivo, and then they gave nivo afterwards. And this is very interesting because we have a nivo data of 3 cycles in the preoperative only setting. So any logical mind would say you would expect the perioperative to be more, i.e. if it is not more, then there is a good question, especially for Indian setup, where cost is a constraint. Do we need post-operative immunotherapy? And this is 70% at 18 months, and I've drawn a circle at 2 years. The number is not there, but it will be sitting somewhere at 63, 64%. So what I'm trying to say here is, when we gave immuno alone with chemotherapy, nothing post-operative, we're sitting at 2 years, and 2 years is important, at about 60 to 65%. When we gave immunochemo followed by immuno alone, we are sitting at 60 to 65%. Now, this is my hypothesis, so you cannot use that as therapy. If I had to, I would still give my entire treatment for a year to these patients. But it's a good question. If somebody can't afford, can I give only neoadjuvant immunochemotherapy to improve survival? And back to your question, sir, I would give it to an operable patient also. Not because of the pathological CR, but because of these curves, which are clearly 15% gone up, and after a long while, we've seen something like that. Again, pathological CR, and that opens the question of adjuvant therapy. This was Empower 010, extremely important study. And this study surprised me because for a long time, I have had a belief that the lymph node and the tumor is important. And there was no logic to why this number was sitting at 71%. And if you notice, at 2 years, it's sitting at 71, which is higher than everything we have shown in the perioperative setting, raising the question, and coming back to your question, should we actually just operate straight, not give immunochemotherapy? So now that I have entirely confused everybody in the hall and accepted that I'm confused myself, how did I solve this? So I wrote this to few of my colleagues across the world, and I said, as compared to other studies, whether it was melanoma or whether it was breast, why is that the adjuvant numbers? And if you notice that the baseline is higher, 63%, the gain is still about a little less, 7%. So could it be just that the baseline is less? But then one of them pointed out lung is a unique cancer because you do not do a complete axillary lymph node dissection like you do in breast. You do not remove all lymph nodes in the lung as you do in breast. There is lymph nodes above and below which maintain the interaction, and so it could be that your theory fails here. But interestingly, this was again the only study where the TC more than 50 mattered. So it's a complete turnaround from how we're looking at metastatic setting. So the study confused us, and please note that in the Keynote 091, which is again the adjuvant pembrolizumab trial, there has been some debate. It was not positive for PD-L1 selected patients. So some debate on these curves matching. Look at the, sorry, I think, I have to go back. So this was the atezolizumab curve, which seems to be slightly joining and then separating. At least it's open-ended, and this is the pembrolizumab curve, which is joining in the end. So we will and should wait for this adjuvant, but given the choice in the adjuvant setting, it seems somewhere the preoperative setting is still more logical. What to do? First question to ask, side-by-side comparison between Keynote and AGN, and you can see how the curves are separating right in the beginning for pathological CR. Second question, with the advent of perioperative IO in early cancer, a new question comes, will these early result in OS survival? And I do think it will. Please look at both the curves, but look at, more important, the curve of the overall survival of 2022, which is interim analysis showing a nice separation sitting at 5.5 years. And so will this result in OS survival? I agree with Prashad that this is likely to be, because a 5 years OS of 42% is certainly more than the 30-35% we were looking to. Again, that about 10 to 15%, and a PS of 33% is been already reported. Third question, stage 3 encompassed diverse range of disease. Where are we really sitting? How do you determine the resectability of stage 3? And I hand it back to surgeons, and I'll ask you this question in the end. But to my mind, that should not really be changed. Should I be picking up an incidental stage 1 tumor and not operating, giving an immuno? No. And should I be picking up a stage 3B tumor and saying this has suddenly become operable because there's multi-station node? The answer is still no. We do have CTRT followed by immuno. But keeping your standard surgical guidelines in mind, I would push more for neoadjuvant immunotherapy. Which patient stage 3C may be considered? I think this is a redundant of what I just said. These are the ASCO guidelines for selected patient, even with T4, for example, they talk about resection first. Fourth question, neoadjuvant versus adjuvant. I think we have already kind of accepted that me as the speaker am confused, so it's a very difficult question. But just to read this out, neoadjuvant provides early opportunity to eradicate micrometastasis. We know this as a principle. Increased treatment initiation rate and compliance. We know that patients tend not to run away. Pathological complete responses may, it's not yet sure, but may provide early indicators of response. I mean, of course, it provides early indicator of response, but it may respond survival benefit and can potentially eliminate live tumor cell release in circulation during surgery. And this is a concept which we didn't believe for a long time, but recently with Tata's breast data, I think we are questioning whether surgery does increase circulation of tumor or not, has been raised again. Adjuvant, however, does allow for the fastest time to surgery, which remains the most curative option as we know today. No risk of pre-surgery complication of systemic therapy. I think that was put forward very well, that there will be always those 2 to 3% patients which will end up with immunotherapy toxicity, and it will be difficult to treat them. And in that case, the adjuvant immunotherapy has an advantage. We're seeing separation of curves which are maintaining at 3 and 4 years. You would consider that, wouldn't you? Enables longer treatment duration for systemic control, which is the biggest problem in lung cancer. The 2-year mark seems to be tough, and more flexible timing post-surgery provides more recovery time for these patients. And last is the future perspective, and this is in my mind going to happen in our very near future. So I don't know whether it will happen by the next Cancer Summit, which is in 2 years' time from Fortis, but it will certainly happen in the next to next Cancer Summit, which is in 4 years' time, where we will be doing ctDNA. And interestingly, we may be doing it even pre-operatively. I'll just show that graph in a second, but we will be certainly doing it post-operative. We do know that Empower 010 data on adjuvant ctDNA and immunotherapy is awaited, and it will be very interesting to see what happened to that. Was, like Galaxy, clearance of ctDNA seen or not? And if, like Galaxy in colorectal cancer, it was, it will make a very compelling argument to consider immunotherapy, at least in the adjuvant setting. But this was the Asian study data, and this slide really is very interesting, because what they did was, if you look at the graph on the right, you look at the pathological complete response and looked at the ctDNA. And basically what this graph is showing is that the pathological complete response was significantly correlated with abolishing of ctDNA in the blood. So if you give a treatment and your ctDNA was going away, your chances of pathological CR was much higher. And I guess if they do the same thing in even the post-operative phase, and when they present that survival data, you will see some very interesting numbers. So has it been recommended? Yes, for sure. For eligible patients with resectable medical stage 2 and 3C, without EGFR and ALK, neoadjuvant platinum-based chemotherapy with immunotherapy is preferred over adjuvant according to them, but I've given you a compelling argument for both. I guess a lot of our patients do not come to the tumor board first, where these discussions are best taken. So adjuvant is clearly an option, and we should not ignore that. My quick conclusions: perioperative immunotherapy is promising approach. I am very certain that I am actually using it. I would certainly use more in the future, but I'm already using it. It has the potential to improve outcomes and reduce risk of recurrences. The landscape of perioperative ICIs and lung cancer evolving rapidly with recent reported and some trials which are reported. With that, I will still say that please do not be over enthusiastic about the smallest lung cancer tumor. We very rarely see that, but don't be over enthusiastic. And please don't try to convert a patient of 3B multi-station big N2 to a surgical case just because we have something which can cause a pathological CR in 20% patients, which is 1 in 5, and a further very good response in another 20% patients. But that should not be an indication. These are the two kind of warnings, as I say, that perioperative immunotherapy and chemotherapy is here to say. Thank you. Questions?
Thank you, Dr. Nitish, for a crisp and clear presentation. I think it's much clear that neoadjuvant is a preferred mode even for early stage lung cancer. For a stage 1 or maybe early stage 2 disease, are there any subset of patients after neoadjuvant who don't receive surgery or delay the surgery because of complications of neoadjuvant?
So I think this question was being raised. I would very, very strongly put my foot down and say, when you are planning neoadjuvant therapy, you are planning surgery first. So plan your surgery first when you're planning neoadjuvant therapy. You can't decide midway that this patient's tumor has disappeared. So no, I think that's under-treating them. If a patient has had a bad reaction, ends up with an infection, autoimmune, something happening, and you can't operate on the patient, that's a caveat. We live with that. We live with that in almost entire medicine world anyway. But if there is a radiological complete response, what would I do? I would certainly operate this patient. This is the best patient to operate because the last tumor cell left in this patient is likely to be resistant to everything, you know. So I would certainly operate on that patient.
Yeah, that's right, Nitish. The other thing that you mentioned is a ctDNA.
Yeah.
So that and the CTCs will become a part of the biomarker studies.
Absolutely.
And that also can
absolutely.
Actually.
And I think you're absolutely right. In a few years' time, we will be using that to decide not only in lung cancer, but in a lot of cancers, what to do and what not to do with people. We are reaching the stage where it will be diagnostic, right? We are reaching a stage where I think there was a recent breakthrough designation from Datar where they were diagnosing a brain tumor. This is the first time in the world. So we're reaching a stage where we'll be doing that. Of course, we'll be reaching a stage where we will be deciding our lung cancer paradigm, but we are not there yet. Until that point, I would do what we've already learned, which is perioperative
In fact,
therapy.
there's just one study which has actually shown that 7 nanograms of DNA cut off, showing better versus worse.
So in fact, there's interestingly more than that. The studies are fairly high now, suggesting ctDNA can be used. But we're still talking about short-term follow-up.
Yeah,
we
yeah,
don't
exactly.
know. We really don't know what happens to the EFS there.
Yeah.
So if a patient is operated, I would offer adjuvant IO, yes. If a patient needs surgery, would I offer neoadjuvant? Yes. If a patient can't afford, but can afford 3 cycles, the answer is yes. And of course, smokers tend to do slightly better, and squamous tend to do better. And so on and on. And please avoid EGFR ALK. I think you must test for EGFR ALK ROS before you give any neoadjuvant therapy to anyone.
Correct. Yes, JP.
So please.
What is the ideal time for surgery after neoadjuvant? Compare with
So
chemo.
that's related to chemo actually. It has nothing to do with immuno.
Right.
So the time to surgery from chemo is also mainly related to the healing of the tissue, because we do know we lose flexibility of the healing of the tissue after chemotherapy for up to 4 weeks. Now, your question is, will immunotherapy impact surgical ability? To best of my knowledge, not.
Time for a pathological CR is different for chemo. Is it different for chemo versus?
Okay, so that's an interesting question, because you are asking, for example, in rectal cancer, we wait 6 weeks if we wait 4, right? And I'm sure that if we wait a bit longer, there'll be more pathological CR. But I re-emphasize what I said. I am not influenced by the pathological CR for my patients to give neoadjuvant therapy. I am saying the reason pathological CR was used was because that was the only indicator to bring this into forefront of therapy. The key indicator is the fact that the curves at 2 years are already 15% better and still separating at 3 years, 4 years, and 5 years.
So at some point of time, you will be doing a maintenance consolidation.
Which is already the case. 1 year is that, yeah.
So to operate early is not a smart idea when you are giving neoadjuvant IOs. That's what I'm trying to come.
Sir, sir,
And in an intact nodal station, what you are saying, and that's what I said it. For me, neoadjuvant IO is not a smart thing because I need to generate more antigens. So I need to come first, then the IO should come. You know, like a brain metastasis. I should give radiation first, and then the IO should come in for a better outcome. So we need an intact immune system to throw off more antigens. That's what I'm trying to come.
So in one way, you are right because you're talking about antigen release. But then there are certainly two understood factors, which is antigen interaction and antigen memory. And I'm guessing there are about 200 ill-understood factors, which the statistical value is demonstrated is more powerful than the biology I can throw. Sorry, Dr.
I
Dinesh.
think, yeah, I will add on to what Dr. JP said, that as we are giving more hypofractionated and radiation, it itself also acts as an immunogenic effect. So adding radiation, high doses, smaller fractions before immuno, it may be worth trying and it may be complementary.
Absolutely, sir. So but the question there is for which patient? So if a patient is inoperable, it's CTRT followed by immuno, no question. If a patient is operable, the question on the table is, should we be giving chemotherapy or chemoimmunotherapy? It's chemoimmunotherapy. And if a patient has come after surgery by any chance, immunotherapy, atezolizumab is clearly showing the benefit.
I think future studies are going to give more of these answers.
Okay.
Thanks,
Thank
Dr.
you,
Nitesh, and we thank the organizers for giving us the opportunity and a very beautiful conference. Thanks a lot.
Thank you, sir. Thank you. So just to add on the timing for surgery, Dr. Agarwal, sir, most of the trials, they took the time period between 6 to 12 weeks, unlike for the chemotherapy where we have 3-week interval before surgery, and just rightly what Dr. Nitesh mentioned, that it is more to do with the tissue healing rather than response assessment for, yes, so it's more of the side effects of immunotherapy. We'll move on to a surgical topic, and we have none other than Dr. Jagannath Dikshit, sir, from Bangalore to chair the session, along with Dr. Vijay Agarwal, sir, if he's there. Wonderful. And Dr. Shoaib Zaidi, I have not seen him actually, but if he's around, is Dr. Sudarshan also, can I ask you to join also, sir, because this is a surgical session. And I'll request Dr. Jagannath, sir, to please invite the next speaker.
I think with the continuation of topics, very interesting discussions are happening. So the first talk will be on adjuvant to post CTRT and post surgery. Again, Dr. Prasad Narayan. Oh, okay, fine. Okay, minimal access surgery, which is my favorite subject. Dr. Darlong from Delhi will speak on that. Thank you, sir.
Good afternoon, everybody. First of all, I'd like to thank the organizing committee, Dr. Niti Raizada, and everybody for having me here. So I can see in the audience, we are mainly a mix of medical oncology, radiation oncologists, and I think a few surgeons. So my topic is minimal access surgery in So greetings to you from Rajiv Gandhi Cancer Institute. The talk is on minimal access surgery for thorax using both the VATS and RATS. VATS is video-assisted thoracic surgery for those not initiated in this, and RATS is basically robotic-assisted thoracic surgery. So to make it more interesting and to go, with our audience mix, I would like to cover it as what it is, an overview, what is the advantage of it, any evidence for thoracic oncology in terms of minimal access, and see about what is the advantage of VATS and RATS-assisted surgery, limitation, and then end with the conclusion. What is it, an overview? So if I say thoracotomy, it's something like a chemotherapy for a medical oncologist. It's something like to achieve a target, you basically just bombard it. We are bombarding here in the case by opening a big wound just to access its site. It's invasive procedure. To put our instruments for vision, basically we get a big incision. So it's like a chemotherapy if we compare it medical immunology. Then VATS is something like immunotherapy or target therapy. Not everybody can undergo a VATS or robotic-assisted surgery. It's only a select group of patients that we are basically going to offer them because of the patient factor as well as the cost factor. So we are now basically using vision of the endoscope and instruments which are put through small hole in the chest. And so in minimal access, it's basically, again, it's invasive, like an open case. Access is small, and video camera is with the assistant. This is one of the drawbacks of a VATS, where the camera is with the surgeon. So these are some of the nomenclatures you'll hear about VATS. It can be a multiport, it can be dual port, it can be uniportal, it can come from below the xiphoid, called subxiphoid, or it can even be done from the transcervical, basically from the neck. Robotics or RATS is, again, it's a surgeon-controlled robotic arms and camera. The surgeon has full control of the camera as well as the robotic arms. There's a 3D vision. The difference with VATS, it's got a 3D vision, and it increases the precision. Basically, it's like precision surgery, just like precision medicine we call it, so it's precision surgery, and its potential for remote surgery. This is a Da Vinci system which has been there for a long time from Intuitive. It's very, very costly, and definitely it's one of the landmark things. It's something, if you use it, you get used to it, it's so comfortable. And definitely not lagging behind is a made-in-India robot. That's the SSI Mantra, which is making waves now, and they're being used in a lot of cases now in oncology too. Advantage, if we see, based on the incision, you can see that obviously the pain is reduced in all VATS or minimal access cases. Recovery is quicker, and because of the small wound, there is less chance of infection. And our oncologists love it because there is no delay in adjuvant treatment because of wound complications or other reasons. In terms of the oncological outcome, this is something which still do not have any great evidence of RCT. So to look at the evidence for VATS or minimal access in lung cancer, this is one of the criteria for ISLC for completeness of lung resection. We all know we need a microscopic R0 resection, minimum of 3 N2 nodal stations, including level 7, N1 station from 10 and 11, and the yield harvest should be at least 10 to 16 nodes, no ECE, and highest node should be negative. This is the criteria we have to fulfill whether you're doing a VATS, you're doing a robotic, or you're doing open surgery. And this is a review of published in 2023. The uncomfortable truth regarding open thoracotomy versus minimally invasive surgery, which is a review and meta-analysis. If we see the ACCP guidelines, it clearly says for stage 1, MIS is preferred over a thoracotomy. If you see ESMO, they again say it depends on expertise of the surgeon, standard operation or VATS, and VATS should be the approach for choice at least for stage 1 cancers. And NICE guidelines again says both is possible, but again they always emphasize on VATS for basically early lung cancers. And again, if you see the NCCN guidelines, it again favors VATS lobectomy in selected cases. It adds a caveat that RATS seem to be more expensive than conventional VATS. So none of them are giving a clear message, but they all emphasize that for early stage 1 lung cancer, which is a small tumor, it is definitely more beneficial. This is a 2023 review article of comparison of VATS with RATS, minimally invasive surgery, non-small lung cancer. Where do we stand? So presently, these are the various meta-analyses and randomized CT trials, most of them meta-analyses. They all have found one thing important is that the RATS has improved lymph node yield. The lymph node dissection yield, amount of lymph node and upstaging has definitely increased with robotic-assisted thoracic surgery compared to VATS. That's because basically the precision surgery we can be doing robots. So the key message is that they all give that minimally invasive is the preferred modality. Just like for staging the mediastinum, we say that EBUS is the preferred modality because it is less invasive compared to a mediastinoscopy. So for early lung cancer, it is preferred, but there should be no compromise on the oncologic outcome. So we'll now be going to VATS or RATS. This is a diagnostic VATS. You can see the size of incision. It's basically just one finger size. So the pain generated to access, to see inside is definitely much, much less. It is more acceptable to patients. And we are using a wound expander, not a metal-like, and it's about 2-3 fingers. This is the inside view of the lung, upper lobe, middle lobe, lower lobe. You can see it's very clear. The vision is so superb that you can basically see everything inside, what's there, any pleural deposit. You can put your finger in when you're doing VATS also and take out that part of the lung outside and do a manual palpation, which is not possible when you do robotic surgery because we don't have the sensation of touch. This is again RATS, robotic surgery. In this case, we basically put multiple ports. You can see there are multiple ports. Unlike VATS, in RATS, you put more holes. That's basically 8 millimeter in size. So it is more, see, this is the image. If you see the posterior mediastinum, you can really see that you are basically like walking inside. It's something like you're doing a replica in open surgery with your eyes right inside the chest cavity. You can see all the nerves, the beating vessels, and you can see here this is the posterior anatomy. You can see the trachea, this SVC, esophagus. Everything is so well visualized. And this is how the vision helps the surgical to be more precise. Again, if you go to the left side of the thorax, you can again see the glistening pleura. You can basically make out virtually any abnormal nodule lung which are missed on a CT scan. And you can see here the phrenic nerve, the vagus nerve, which will turn to form the recurrent laryngeal, the black lymph nodes in the epi window. All these are clearly visible on a thoracoscopy with high definition. That's the power of vision, because this is how you can see these areas which are not seen on open surgery, because you cannot put your head inside the chest and go and see the apex. So this is one of the very, very big advantage. And sometimes when you go inside with a thoracoscope, you see these deposits there, which are missed on a CT scan or a PET scan. And these are cases wherein basically you avoid a futile surgery, either a thoracoscopy or a thoracotomy or a RATS is avoided in metastatic setting. So in lung cancer surgery, again, one of the critical part which is usually missed is mediastinal nodal clearance. And this is very critical in terms of completion of surgery as well as for pathological final staging. So with VATS, these are area in the apex, as I've said, so it's easily can see those areas. These are the pre-2R, 4R, 10R area. This is the inferior palmar ligament, then comes your subcranial space. So all these areas are visible very, very well to the surgeon. And when you can see things clearly, you can remove them also very well. And the vision is 10 times magnified in VATS. This is the subcranial node packet which has been removed, and that's the level 2R and 4R, and that's a 10R area where the lymph nodes has been removed as a packet. Same way on the left side, you can see here, that's the phrenic nerve. You can see the recurrent, the vagus, that's the subcranial space area. So this is more difficult on the left side, but with the vision that you have, you can basically go and clear all those nodes. So once you've removed the lymph node packets, you can basically bear off all those areas, exposing the nerves, the esophagus. You can see behind, it's a subcranial packet. So this makes the surgery very, very precise and good hands with training in. So again, this also comes at a cost. Just like immunotherapy and target therapy, the cost is there. So instruments is also in cost in VATS. We have got specially designed instruments that are different from coaxial. So this is something, a VATS instrument. From the Scanline, if you go to buy it, it costs about 5 lakhs rupees. So the investment is quite high initially. And that's one of the limitations of instrumentation. And these are the robotic instruments. They are 8 millimeter size instruments, very precise, and they go into 8 millimeter ports. So you can see that instrumentation is definitely one of the costs. If we go into Da Vinci, that's the robotic one, the 3D vision I'm talking about, it has got two visions, 0 degree and 30 degree. 0 degree is basically forward viewing, 30 degree is like looking down, and 30 degree up is also like looking up. It can be compared with driving a car. I'm using a 0 degree camera. It's like driving a car. I'm seeing what is in front of me. And I can turn my 30 degree scope looking down. It's like me reading a book. Or I can even lie down and put my book up. It's like reading a book upwards. It's basically 30 degree up. So the greatest advantage of this technology that we can use in esophagus, you can see in the esophagus that the tumor is not always, esophagus is not always on the midline. In the upper side, you can see it's in the midline here, but it goes down. You can see it's going more towards the left side. It's getting buried under the aorta. So in such setting, when you change the setting of a camera from 0 to 30 degree, you can basically go and approach that area. So we're starting with a 30 degree down. That's basically like reading a book. You can see here, I'm basically looking down. It's like I'm sitting and reading a book. So we start from downside. That's how we have mobilized the inferior palmar ligament. We're opening the space between the pericardium and lifting off the esophagus. So we come up, then this is basically this here, this is the fast forward. This is azygous area. We have the thoracic duct around this area. So you can see the hand movement. We have made it fast, but still, because of the precision, it can basically go very fast. That's the bronchial artery, which you don't usually see, but you can very well clearly see. There's a subcarinal space. You can see the layers here. These are post-CT artery. They are like what you call bubble. That's like a bubble, because that's the vision, because that's the power vision. And so when you go down, you have to use a 0 degree scope because it's now going more towards the left side. I need to see straight now, like driving a car and seeing in front. So you can see here, now I can basically go in deep and see forward. So there's a subcarinal space, and you can see very well the fatty tissue here, and that's the aorta now. I'm basically below the aorta. So with this vision, I can basically go inside and basically just work under the aorta on the left side. And if you see here, you can basically now see the lung on the other side across the pleura. It's very basically a thin layer. And you can see it basically just glistening. The pink lung on the left side, you can basically see how well you can basically visualize that. So that's one of the beauty of robotic surgery, especially with the 3D vision that the surgeon has. So that's how you basically are able to do a complex surgery in a very feasible way and increase the lymphatic yields. So now we'll come to other indications, which are basically based on patient-centric. We don't have any RCT to say that this is the best way. So this is a case of mesothelioma, which is localized. In this case, we are basically combining thoracotomy with a video assistance. You can see here, I can basically remove the parietal pleura away from the chest wall. You can see here, there's a parietal pleura here. Following this, I'll be doing a visceral pleurectomy. I think this is something which we can compare something like open surgery with TKIs or IO. It's something a combination of chemotherapy used at IO with TKIs, which is rare in lung cancer. So it's basically a combination of jugglery of all the technology that we have. And again, schwannoma, this is in the left apex. There is no way that we are going to have randomized trial to say, okay, robotic is the best, VAT's the best. These are small-sized tumor. You can see the locational tumor is in the D2 level. This is somewhere very high up. This is just so easily, you just go inside, take it out, pick it up, put in the bag, and come out. That's the level of precision and speed that you can do with robotics when applied in the correct patients. Coming to the limitations of VATS, limitations are basically access about it, availability, expertise, and obviously training facilities also much required, especially in thoracic VATS, because this is an area we very much lack. And but nowadays, there are very big centers like in Shanghai, in Pulmonary Hospital, they do about 100 cases per day. And that's where most of the people go now. And obviously, patient selection is also very important, like how you select chemotherapy, target therapy, IO for your cases. The same way in robotics also. Coming to robotics or RATs, the cost is very prohibitive. The intuitive costs about more than 10, 12 crores. We have the Mantra system, which is costing about 1/4 of it, and that's an Indian system. It's making news. Obviously, patient training, selection training is important, and definitely the time to set up initially is more higher when you're doing robotic surgery. But once the team sets in, that gets into correction when you're using it for the right indications. So coming to the practical limitations, what we surgeons face in VATS, it's basically, it's a vision. Because it is operator dependent, unlike in robotics where you are holding the vision. So in VATS, your assistant is very, very important. For large size mass, it is basically good to go and have a look with the VATS instruments, but you cannot really complete it. Oncologically, it is not really sound. And one of the limitations of robotic is that for large tumors or when you're suspecting other things, you don't have tactile sensation. So this is one of the limitations. And so to conclude, I would say that when you're using minimal access surgery, the aim is to treat cancer and improve survival. This is the first and foremost aim. Minimal access is here to stay. It's something like a combination of thoracotomy with VATS or RATs, and they all are complementary, like you have chemotherapy with IO or TKIs, they all are complementary. And thoracotomy will obviously always be there, just like chemotherapy, always you fall back when everything fails. And presently, stage 1 cancer and stage 2 cases of non-small cell cancer are the present indication, and patient-centric approach is the key to it. Thank you very much.
Dr. Darlang, very beautiful presentation. In your series, do you have any cases where VATS you have compared with the robotics in the longest follow-up duration?
There are meta-analyses now going on, but they have not really, in oncology, they have not really found out the maturity still. Most of the meta-analysis, basically.
Yeah, one important message I just want to give it to everyone, that, RCTs has not proven any benefit of the VATS versus the RATs. I think probably the only important entity is that conversion rates have come down whenever we use the robots. And the patient getting the atrial fibrillation results are very less.
Yes.
We do RATs robotic, but with the usage of sure form of staple, where the angulation is beautiful and you can take all the vessels completely.
Yeah.
That is one greatest advantages which is happening. And as you said, the haptic feedback is a major issue in robotic, but unless in VATS. But to tell you, this VATS has innovated basically with a non-oncological surgery initially.
With pulmonologist.
Yeah, then it took up to this one. I think uniportal and multiportal is a very well defined in China. China has got a highest.
Yeah, Shanghai Pulmonary Hospital has got highest volume, about 100 cases per day. So, sir, coming to that, robotic one, there are centers like Serfolio, Deliski, they had compared their results. And what they found was that for N2 disease, there was some, better improvement in survival, they say. And there was increase in upgrading of nodal station.
I think it is time for us to come out with some data from the Indian statistics telling that what is the lymph node yield and the local recurrence rate, and has the robotic surgery has made any improvement in survival. I think we don't even have 2-year data as of now. Of course, the Da Vinci is available, but SSI, we are yet to start because that is one machine where, we are not able to start off.
Yeah. I think, sir, robotics in lung cancer, the problem is the cost is quite prohibitive, the staplers and all that. You can do the same thing with a very, very speed, or faster with VATS, I would say. And in terms of hospital stay, it's almost similar. There is no difference. So I think because of the cost factor, I think robotics is still, because of the stapler use, it is mainly in esophagus and mediastinal tumor where you don't use much staplers that we're able to
But what my suggestion is that when you use more stapler in robotic, the cost will be less. Unlike in VATS where, each cartridges cost about, say, 18 to 20,000. But each cartridges in robotic cost about 6,000. So up to 12 times you can use the more cartridges.
I think you must be having a good agreement with the supplier.
Probably. No, but I think we at some point, when we are offering immunotherapy, so much of chemotherapy, I think cost of the surgery, we should keep it aside. When medical oncologists are using a lot of expensive drug, why can't a surgeon go for a better version of...
Surgeons put it cash down.
Can I disagree on the cost?
Medicologist is EMI.
All immunotherapy now are pretty much capped at 10 lakhs a year. Okay, so immunotherapy is no longer ridiculously expensive.
But surgery is the very least among all, I can tell you. I think we have to go to the era where, every patient wants to go home early. That is the major dictum now. They don't want to stay longer time, less of antibiotics, less of blood loss, less of transfusion, and pain-free. So this is what the patient demands. The cost is immaterial for them. I think we need to try to go ahead with the eras where, patient comes and stay for 2 days and gets discharged. But I'm very much, your volume is so good. I think you have done a beautiful, videos are showing a lot of, I think all the lymph node clearance are excellent. I think it is time for us to prove the, statistics of each individual center And so that will help us probably 2 years from now when we do the next summit, probably we'll be having the statistics on that.
Yes.
Yeah, thank you for an excellent presentation. I think we all agree that minimal access surgery is here to stay. Thoracotomy is gone way behind. And VATS, it's now discussion between the VATS versus RATS. I think robotic is definitely now with the Indian robot SSI Mantra is there, the cost is definitely going to come down. And as Dr. Dixit rightly said, the staple cost, which was a major hindrance in the Da Vinci XI, or maybe in SSI Mantra and combined together, the staple cost itself will come down. We should definitely in the near future should come out with the Indian data about comparison between the VATS and the RATS. And what we have seen in the RATS is the patient do complain of much lesser pain compared to the VATS. And of course, the lymphatic yield is much higher in robotic assisted surgeries. So going forward, more and more patients will opt for a robotic assisted now that the word has gone out. And of course, we have to be skilled and we have to be...
Yeah. So thoracotomy is still like chemotherapy. When everything fails, you have to basically go back to it. And RATS and VATS, we are going to basically ask about it every time. Because any patient comes to you, he's going to ask about immunotherapy, target therapy. He doesn't ask about chemotherapy.
I came here personally to thank Darlong. He is my classmate and I'm really honored to have him today doing an excellent work in a very niche domain. Thanks so much.
Thanks, Niti.
Any questions from the audience? Can take.
So, minimal access surgeries in cervical cancer, ovarian cancer, when compared to regular surgeries, the overall survivals and results were inferior. Do we have any such data in this lung cancer regarding minimal access surgery versus regular surgeries?
So presently in minimal access, we don't have the OS data presently. We have the Violet trial, which was basically followed up just about 1 year, where they found similar in terms of oncologic outcome. So we don't have the long-term data yet.
I can answer. See, basically, it's a multidisciplinary, especially within the lung surgery, it is the interdepartmental workup of pulmonologist and anesthetist, and going for a single lung ventilation or, double, lung ventilation, and probably beautiful magnification and 3D. These points have taken up. Accessibility is important, magnification is important, and maneuver of your instruments. So all these things we can get it, as Darlan said, Dr. Dar. So the instruments are modified according to the needs now, especially when we do the VATS, all the instruments are curved and it can reach the target area. I think if you look at the minimal access surgery in some other malignancies, except endometrial cancers, I don't think anything has taken up a huge leap, especially cervical cancer or ovarian cancer. It is still the open surgeries. But endometrial cancer is the only gynec cancer where it has got a huge role to play. I think the lung comes, the one of the priority to go for a minimal invasive surgery. Thank you. I think thanks. I think we have done. I think. Thanks, sir. Thank you.
Thank you.
After that wonderful talk about minimal access surgery, we'll move on to the next session where we talk about systemic therapy beyond TKIs and TKIs. I'd like to request our chairperson, Dr. Bowman Dabar, who's the director of medical oncology at Fortis Hospital in Mulund. And I would also request Dr. Vijay Agarwal if he can, Dr. Vijay Agarwal, if he can continue to chair the next session, unless you have a... Okay, all right. So Dr. Bowman Dabar. So I would like to invite our next speaker, Dr. Vineet Govinda Gupta, talking about improving outcomes in advanced EGFR mutated NSCLC beyond TKIs.
Yeah, so thank you very much for the very kind invitation. So after very exciting and interesting session on adjuvant and neoadjuvant therapy, we go to systemic therapy in the advanced setting. But we are going to a, one area of lung oncology which has really expanded very fast in the recent past, and almost I think so many times a year we see some new advancement. So I'm going to go on a slightly different track. So just for disclosure, this session is supported by AstraZeneca. So we won't get into a lot of details with all this, that non-small cell lung cancer is not a single disease. We all know that when we diagnose advanced non-small cell lung cancer, the right way to move forward is to start with genomic sequencing and try to treat it in a precision manner so that you can give the patient a therapy which is likely to give the best outcome with the least side effects. So we know this, I think all of us know this quite clearly. But what is more interesting is, suppose you treat a patient who is getting a particular targeted therapy or maybe a non-targeted therapy, what is the rationale for repeat precision testing when the patient has disease progression? Should we do the genomic testing to determine the kind of therapy you want to give in the second or third line? So what the guidelines are moving towards, at least in EGFR, I think there is an emerging consensus that you should test, one thing is that you have to test for T790M for patients who have not received osimertinib. But patients even who have failed, suppose the osimertinib, there is an emerging consensus that you should test them because the resistance mechanism, many of them are targetable with the alternative targeted therapies, and it will help you in choosing a more optimal therapy. So the consensus is shifting in that direction. So but important to note that other than, if you look at the two studies which have shown OS benefit in the front line, that is the Archer 1050 and Flora, the PFS needle is still plenty of room to go. We are at 1.5 years in terms of PFS. There is a long way to go to improve the outcome of these patients. So today, the main goal of the talk is to talk about combinations, whether for patients who have got EGFR mutant NSCLC, whether you can offer them a better outcome by combining the EGFR TKI with some kind of therapy, whether you can use a second kind of anti-EGFR therapy, whether you can use chemotherapy or you can use VEGF inhibition. So we'll get right into it. So I think one of the most robust data is with the combination of EGFR TKI and chemotherapy. So we'll go over the studies right now, but probably one of the few studies that have shown survival benefit and robust improvement in long-term outcome. And the rationale is clear that, patients are eventually going to acquire resistance to the EGFR TKI you're giving. And the reason for that is there are subclones of cells which emerge and which are resistant to the therapy you're giving. So when you combine with chemotherapy, you're trying to target and kill those cells. So thereby delaying resistance in the overall tumor. And there's a theoretical implication that on the other side, the oral TKI, by decreasing TS levels, it also improves the effect of anti-metabolite chemotherapy. So this is the study which was done at TMH by Norona et al. And it is the, I think it is the important practice-changing study for our country, where patients who were aged 18 or older with EGFR mutant NSCLC were randomized to geftinib with pemetrexed and carboplatin for 4 cycles, followed by pemetrexed maintenance with geftinib versus geftinib alone, and the primary endpoint of PFS and secondary endpoint of OS and other parameters. So very, very satisfying and broad separation of curves seen in this study, both in terms of PFS and OS, hazard ratio of almost, so more than 50% improvement in overall survival and 0.51 hazard ratio of PFS. Very, very impressive results in this study, and definitely practice changing without a doubt for our country. And you can see that all these subgroups benefited from addition of chemotherapy, making it, it's an Indian population, Indian center, making it a standard of care for our country. And similarly, there's the NEJ 009 study, which is almost the same study design but done outside. And in this study also there's a PFS and OS benefit, but the OS benefit did not reach statistical significance, so p-value did not reach there, and the PFS benefit seemed to be little bit more modest compared to the Indian study, which I think many people attribute that maybe patient in our country, the access to second-line osimertinib was less compared to patients outside, so maybe that has made the control arm worse than what you would compare in the international setting. So if you look at the NEG study, you can again see that most of the subgroup are benefiting from this therapy. So importantly, this combination is also now part of guidelines. So if you look at the ASCO or ESMO guidelines, in setting where osimertinib is not available, it is considered one of the preferred regimens. So very, very important therapy to consider for our patients. And I think it is still underused to some degree. So there are two more interesting studies which have looked at combination of chemo with EGFR TKI combination. So one is this interesting idea called the again study. Idea is that you run in with TKI, then you give a pause on the TKI, expose the patient to chemotherapy to kill the cells which are resistant to TKI, and then reinitiate the TKI and continue it till progression. So you can see here that patient gets 56 days of TKI. Originally it was Jeftinib, later it was changed to Osimertinib when FLORA results were published. They get 3 cycles of PEMSIS followed by reinitiation of the TKI. But unfortunately, this study did not show a good PFS or OS significant improvement. So again, just an interesting thought and worth a consideration. So the first phase 2 study which looked at Osimertinib with chemo was the OPAL study. And in this study, you can see that PFS and OS results seem to be much more impressive compared to what you have seen in the FLORA. So you can see that 24 months PFS of 53.2% and 86.8% respectively. So very, very impressive results and leading into the FLORA 2 study. So FLORA 2 study is a randomized controlled trial looking at frontline chemotherapy with Osimertinib versus Osimertinib alone for newly diagnosed patients with EGFR mutant exon 19 and 21 NSCLC. So it is very similar in the study design to the TMS study that you have taken the patients aged more than 18 who have got confirmed advanced NSCLC exon 19-21 mutant without any prior systemic therapy. Importantly, stable CNS meds were allowed in this study. And they were randomized 1:1 to Osimertinib versus Osi plus chemo. So chemo they have given PEM carbo or PEMSIS as per discretion and Osimertinib 80 mg OD. After 4 cycles, patient continues Osimertinib and pemetrexed maintenance. So again, what we saw in the study, in the initial analysis, which has also been published now in NEGM, is the PFS improvement. So hazard ratio is 0.62, so around 38% improvement in PFS. And right from, you can see that around 3 months, the curve starts separating and the difference in PFS at 2 years is around 16% in absolute terms, which is good, quite an impressive amount. And if you look by BICR again, you have got a 15% improvement in PFS at 2 years. The OS data is not yet mature for this study. And specifically, you can see that all the subgroups have benefited from this therapy. And one special thing you might want to note is the CNS. So actually in this study, patients who have got CNS meds, they have done better relatively compared to patients who don't have CNS meds. You can see it pictorially here that PFS improvement is hazard ratio is 0.47 with CNS meds compared to 0.75 without CNS meds. So we know that platinum agents are active to some extent in the CNS and probably by many of these patients will die because of CNS progression. We know that especially EGFR positive tumors, they have got a tendency to go to the CNS. So probably the patients who are at high risk of CNS progression, it improves the outcome further because you add a better control in the CNS. You can see here that in terms of response rate, the CR rate is much higher with chemo Osimertinib compared to Osimertinib alone. So you can see a lower risk of CNS recurrence, which you mentioned. So when we talk about the adverse events, so you can see that typically what you would expect with chemotherapy, they are the main adverse events. If you focus on the darker orange lines, you can see that main hematological toxicity is there. Neutropenia, thrombocytopenia, and anemia, they are more common with the chemotherapy with Osimertinib, in addition to other side effects like diarrhea. Most of the other side effects are, you can see they are manageable and mostly grade 1 and grade 2. But myelosuppression, which you would expect with chemo TKI, that is more common with chemo TKI. So definitely a major study in this field. I think a lot of us will wait for OS benefit before implementing it kind of routinely, but consider it more for younger or high-risk patients. So I think many of us will be waiting for the longer follow-up of this study. So second is the TKI and VEGF inhibitor combination. So actually there is crosstalk between the EGFR and VEGF pathways, and this was the initial rationale for combination of anti-VEGF therapies and anti-EGFR TKI. We know that various VEGF inhibitors are active in EGFR mutant disease, and these are the main studies of TKI and VEGF inhibitors. So if you look at the phase 3 trials, that is NEJ026, which is erlotinib with BEV, Artemis, which is erlotinib with BEV, and Relay, which is erlotinib with Cyramza. All of these studies have realized a very satisfying PFS improvement, although none of these studies have shown a significant OS benefit so far. And there is one interesting study that osimertinib with Bev actually did not do that great. So it was a bit of a surprise to many people, including me, that why osimertinib Bev has not done that great. So it did not really improve the PFS, move the needle over the osimertinib alone. So if you look at these three studies, all of them, you can see that good PFS hazard ratio of 0.5 to 0.6, but so far no OS benefit in these studies. So next, just last, I think we have 4 or 5 minutes to go. So EGFR and EGFR antibody and EGFR TKI combination. So here we want to talk about two new drugs. One is amivantamab, which is a EGFR and MET co-inhibitor, which is a dual function antibody. And one is lazertinib, which is a oral targeted therapy, which has higher selectivity and brain penetration, and it is, you can consider it as a osimertinib competitor. So in the Mariposa trial, they have taken newly diagnosed patients with EGFR positive metastatic NSCLC, and they are randomized to one of three arms: amivantamab, lazertinib, osimertinib, and lazertinib alone. So it is quite an important study because you can directly compare osimertinib and lazertinib also, as well as look at the combination of EGFR TKI and EGFR antibody. So very interesting, you can see that actually osimertinib and lazertinib do almost the same. You can see in terms of PFS, the curves are almost overlapping, while amivantamab plus lazertinib is superior to both of these. And you can see that all the subgroups are benefiting with amivantamab and lazertinib, and median PFS pushed to the 23.7 months level, which is quite impressive. Although the question to ask is, by exposing the TKI now, TKI plus antibody now, are you really, pushing the needle, or are you just using a drug which will work just as well in the second line? You are using it first line and exposing the patient to more cost and more side effects. So that question will need to be answered with longer follow-up. So you can see here, even the CNS mets, they benefit roughly the same when you give them amivantamab lazertinib versus osimertinib alone. And toxicity wise, obviously you get more of anti-EGFR kind of side effects when you use the combination, although you can see that drug discontinuation rates are higher, but mortality related to AEs is approximately the same in both the arms. You can see that typical EGFR side effects like paronychia, rash, dermatitis, diarrhea, they are more common with the TKI and antibody combination. So how would you sum it up? So if you look at, one more study which is not discussed is the Mariposa 2, which is now published also. And this is the study of patients who have completed osimertinib, and then they are randomized to chemo versus chemo amivantamab versus chemo amivantamab lazertinib. And the initial result, again the OS data is not there, the initial result says that the benefit of chemo amivantamab or chemo amivantamab lazertinib is, both of them is superior to chemotherapy alone, but the difference between chemo ami lazertinib versus chemo amivantamab, that is not that significantly different. So you have the option of using these drugs in a variety of settings and a variety of combinations. Very importantly, that amivantamab is a relatively non-toxic drug which is easy to combine with chemotherapy. So you have, at the current time, you have a lot of options. If we take only the protocol which have shown OS benefit as kind of a standard kind of protocol, you have the option of giving first line osimertinib, and when osimertinib fail, you can go for chemo followed by ami laser, or you can go for chemo plus amivantamab, or chemo plus amivantamab lazertinib as in Mariposa 2, or you can, now that we have the result with frontline amivantamab lazertinib, you also have the option of starting with amivantamab lazertinib and going to carboplatin and pemetrexed as the second line. So a lot of options are there, but I think many of these to become embedded in practice, we will need to see the long-term result in the survival data. But for now, you have many more options for these patients, and you need to pick the option which is cost-effective, less toxic, good quality of life, and controls the disease the best. So as of now, the NCCN guidelines still prefer osimertinib as the preferred kind of frontline regimen, but give you the option of using any of the other drugs, and as well as your drug combinations. You have the option of, they have given the FLORA2 regimen. NCCN still, it has not listed the erlotinib plus chemo regimen, but I think erlotinib plus chemo is very, very important regimen, especially for our country, and should be our category 1 kind of regimen. So just to summarize, newer TKI with chemotherapy is an important alternative for patient with EGFR mutant NSCLC, and you now have the option of using erlotinib chemo, geftinib chemo, or osimertinib chemo. Both options you have these But importantly, you have to select the right patient and try to match the efficacy, toxicity, and the cost implication to give the best outcome to the patient. So thank you. I'll end with that. Thank you.
Any questions? So when there is a resistance to osimertinib, we do agree that molecular profiling to be done. But are we now in an era where we can identify this, that 797, can we identify that? And nowadays they say that once you identify that, you have to see whether there is a cis or a trans. If it is a cis, then older generation TKI will also work with the newer ones.
Absolutely.
So are we geared up for all those molecular testing or not? That's again a big question that I have.
So there are a number of mechanisms when osimertinib fails.
Yeah.
So
and
I think
one of them, as you rightly said, is amivantamab. And the Mariposa 2 trial, the lazertinib arm had a lot of toxicity.
Absolutely, sir.
So that's why the lazertinib arm, they have kept it on the hold. And they say, as you said, to sequence it rather than starting upfront.
Absolutely.
So upfront, now we have available amivantamab. So we can use amivantamab with pemetrexed carbo, which is a very, I would think that as a standard protocol, if we do not have access to all this molecular profiling.
Absolutely. So what I would say, sir, to that is that, so the difference between amivantamab, lazertinib, chemo, and chemo amivantamab is very small. So I think most people will not give the, so I was lucky to have this trial at my center. And even we faced a lot of problems when we tried to give chemo, ami, laser, lot of anti-EGFR toxicity, and almost every patient had to cut the dose of lazertinib. So a lot of problems in that setting.
Amivantamab is well tolerated with chemo, but I have no experience with lazertinib. But what I read was that.
Absolutely.
And secondly, of course, another thing is that MET pathway will pick up. So people do use some anti-MET drugs also. There are trials with that also. So it is to identify what is the mechanism of resistance. There is a HER2 also. There is a HER2. So there are trials of HER2. So there are many other things which are there. But the right profiling is so important. I don't know whether we have access to that or not.
So yes, I think ideally we should do the profiling. If we get a good target, suppose we get a good, strong MET amplification.
Like C797, then
absolutely,
we can think of some older generation also, which we have access to.
Absolutely, sir. And if many patients you don't get a target, then it's good to still have other options in those cases. Sir.
Progressing or not tolerating chemotherapy, do the other tests to see other any targetable drug can be given, because this test has to be done repeatedly in a government center initially, and then when the patient progresses again do biopsy and again testing would be a difficult.
Sir, you are asking in second line specifically, right? So I agree, sir. So I think one more important thing is patient should actually be able to access or afford the drug. So suppose patient cannot afford a MET inhibitor, it may not make that much sense to do testing to look for MET inhibitors. So I think what we would do normally, sir, is start chemotherapy, and as per affordability, we look into the NGS options.
And those, just one comment, that first line what you said, when we use chemotherapy with TKI, it will delay the recurrence. It may delay the resistance to the TKI that we are using. And those were all pre-osimertinib era. So now with osimertinib we do not know, but of course being the cost of osimertinib, it is one of the good options that we can use some VEGF inhibitors with TKI. And my take would be that L855, where the TKI don't work so well, what we see resistance in 9 months, 10 months. In those patients, we should consider this as a thing, where you can use oral TKI with a VEGF inhibitor. Any comments from?
Yeah, so if you look at the relay trial, sir, the data suggests that it does especially well in L858R. So these patients don't do that great with first generation TKIs. So it is worth considering for these patients.
Any other question? Then we go on to the next speaker, Dr. Vijay Shet. He will be there. He's from Bangalore, medical oncologist from Bangalore. Welcome. Sorry, Dr. Vijay Shetty.
So, greetings from the coastal town of Mangalore, and I'd like to thank the organizers for having me here. So, I've been given the task of discussing adjuvant alectinib. So, without wasting much time, driving straight into the topic, we'll go into the ALINA trial. This was a randomized phase 3 trial of adjuvant alectinib versus chemotherapy in patients with stage 1B to 3A, ALK positive NSCLC. This was presented in ESMO this year by Dr. Ben Solomon. Coming to the background of this study, we all know from advanced non-small cell lung cancer setting that the incidence of ALK positivity is in the range of 3 to 5%, but probably it's higher as we are seeing a lot more patients now, younger patients presenting with this malignancy. Current standard of choice, even now, remains standard chemotherapy in stage 1B to 3A, ALK positive non-small cell lung cancer. And we also know that alectinib has significantly improved PFS versus crizotinib with the ALEX trial, JALEX and ALICIA trial. And it has also shown better CNS activity in comparison to crizotinib. And we also know that long term, this medicine is well tolerated and the safety and side effect profile is easily manageable. So, going on to the study design of this trial, it was an international randomized open label phase 3 trial. Stage 1B to 3A patients were taken in this trial. Bulk of the Asian patients were from mainland China and Korea, and those were not priorly exposed to any of the ALK inhibitor were taken. And all the patients were screened in the baseline for CNS mets with MRI, and every 3 months they were screened for the first 2 years, and thereafter every 6 months for the 5 years, and thereafter annually these patients were screened for development of brain metastasis. The primary endpoint was disease-free survival, and the secondary endpoint was overall survival, CNS DFS, and safety. So this was randomized in 1:1 fashion. There were around 130 patients in each arm, alectinib in the standard dose of 600 milligram twice daily for a period of 2 years versus platinum-based chemotherapy 3 weekly for 4 cycles and further treatment was based on investigator's choice. As we can see, both the arms were well balanced. There were a lot more patients, female patients in the alectinib arm numerically compared to the chemotherapy arm. And a thing to note here is most of the patients had N2 disease, they were stage 3. And interesting I would like to bring your attention to the squamous histology. There are 5 patients who had ALK mutation in the squamous histology and 2 in the chemotherapy arm. So there is something food for thought for all of us where we do not routinely screen for these mutations. So I think it's a good idea to do NGS and screen for mutations in this setting. So the 2-year DFS in stage 1B, 2 and 3A was quite significant. It was 92%, 95% and 92.7% respectively with a significant hazard ratio of 0.21, 0.24 and 0.25. And DFS benefit with alectinib versus chemotherapy was observed across all subgroups, including the age, race, baseline ECOG performance status, irrespective of the tobacco use and tumor stage, lymph node status. So this is the graph picturizing the same thing, representing the same thing. The stage 1B graph is not that impressive, maybe because of the lesser number of patients in this arm. And stage 2 and 3A, the DFS were quite impressive. And if you see the intent to treat population, the median DFS is not reached, and the hazard ratio is pretty significant at 0.24. Now, it's very important when we talk about ALK positive disease, we do expect CNS relapse at some point of time. So in these patients also, there were 4 recurrences in the brain in the alectinib arm, and there were 14 in the chemotherapy arm. We don't have a OS data yet. It was immature at the time of interim analysis. And the CNS DFS is also pretty significant with a hazard ratio of 0.24. As you can see here, this benefit was seen across all subgroups of patients. And the subsequent line of therapy for the alectinib arm was chemotherapy predominantly. And the chemotherapy arm, most of them got ALK inhibitors. So coming to safety, it was well tolerated. If you see, both the arms had grade 3, grade 4 adverse event of around 30%, but the adverse event leading to discontinuation was much lesser in the alectinib arm, and they did see increased CPK and LFT abnormalities in the alectinib arm, and chemotherapy, the expected nausea, decreased appetite, vomiting was seen. No grade 5 adverse events were seen in either arms, and at data cutoff, 20.3% of patients in alectinib arm remained on treatment. So the investigator concluded that ALINA represents a very positive phase 3 trial in stage 1B to 3A setting, and the DFS and CNS DFS were pretty significant, and adjuvant alectinib was well tolerable, and no unexpected safety signals were observed, and this probably might change practice in future. Again, whether our patients will be able to take this medicine for a longer period of two years, and whether another ALK inhibitor will do a better job in this setting, that answer we do not have now. And also there are a lot of interesting key trials happening in this space. They are trying perioperative alectinib, and also taking the Pacific head-on, trying to compare it with durvalumab. So in the durvalumab study, there were few patients who were ALK positive, so I think they're trying to take it head-on. So thank you.
Thank you very much, Dr. Vijay Shetty. Sorry for the confusion.
No, that's fine.
If there are any questions?
Are there any questions from the audience?
I would just make a comment that doing such a study is a big task to get ALK positive patients, and the number of drugs that go on changing from crizotinib, then we have so many newer drugs coming. So to constantly do a study is also a big challenge in an H1 setup when the results come so late. So we must congratulate those guys who have done this study for persistence of doing it with alectinib. If they had done with crizotinib, we would have said, why not with alectinib? A newer drug, once it comes, we'll be asking, why not with that? Govind, do you have any suggestion?
So difficult to do a study like this, so I must congratulate the team for putting it together, especially ALK. As it is less than 5%, and to get that in a adjuvant setting is even more difficult. Yeah.
That is why I think so neoadjuvant will also not come out.
Absolutely.
When will it come out, we don't know results.
That's right.
By the time newer drug will come.
And it was interesting to see that squamous also had ALK. So I
Squamous
think
was
it
also
is, we need to test.
Thank you, Dr. Vijay.
So we move on to our next session, which is looking at optimal sequencing of TKIs in ALK positive metastatic NSCLC. I would request Dr. Bomandabar to continue to be the chair for this session, and I also request Dr. Amit Verma, consultant medical oncology at Gurgaon, to chair the session. The moderator for this session is Dr. K. Govind Babu, sir. He doesn't need any introduction. He's an eminent oncologist in Bangalore, and the speaker is Dr. Suman Karant.
Are you going to invite the panelists?
Pardon?
Talk,
I'm
okay,
going to give
fair
a talk first. I just want to check, how much time do I actually have?
Are
you giving me more time?
I'll give you 15 minutes.
Thanks.
So moderator.
Yeah, so 15 minutes. Dr. Uma, 15 minutes? Yeah, 15 minutes is fine. Yeah. Good afternoon, everybody. Thank you for inviting me for this talk. I'm going to be discussing the role of Alecensa in the first line ALK-positive non-small cell lung CA patients. I'm going to discuss in detail about the ALEX study and Alicia study. So the disclaimer, these slides have been provided to me by Roche. So the incidence of ALK-positive non-small cell lung CA in India is, it can vary from between 2.7% to almost 13.2%. So I'm going to straight away go down to the topic. We're going to look at the approved ALK inhibitors in non-small cell lung CA. We've got a lot of drugs now today. These are the current approved first-line treatments for advanced ALK-positive non-small cell lung CA. So we started off with the crizotinib with the median PFS of 10.9 months. We have ceritinib at 16.6 months. We've got alectinib, which we've got a PFS of 34.8 months from the ALEX study and 41.6 months from the Alicia study. We've got brigatinib at 29.4 months. And lorlatinib, as of now, we don't have the PFS yet. So the crizotinib was first studied against chemotherapy in the Profile 1014 study. Though there was an improvement in the median PFS of 10.9 months versus 7 months, you can see that the confidence interval did cross over when it came to OS. So this was not a significant OS benefit, though there was a significant PFS benefit with this drug. With crizotinib, we know that the side effects are visual disorders, diarrhea, nausea, edema, vomiting, and constipation. Now, each of these ALK inhibitors have a different side effect profile, and as we go through the slides, we'll see that. Ceritinib, like crizotinib, again, studied in Profile 1014, demonstrated a significant PFS benefit as compared to chemotherapy in the Ascend 4 study. 16.6 months versus 8.1 months, hazard ratio of 0.55. The side effects, again, ceritinib is a little different. It has more GI side effects with the diarrhea, nausea, and vomiting. So different drugs having different side effects. The problem with crizotinib and ceritinib is that they do not cross the blood-brain barrier effectively, and hence we tend to see a lot of CNS metastasis. Next drug that we have is the brigatinib from the ALTA-1 trial in the ALTA first-line setting. The PFS was about 24 months versus 11 months with a hazard ratio of 0.49. Lorlatinib is the newest ALK inhibitor which has been approved now in the first-line setting based on the CROWN data. The CROWN data showed an impressive 63.5% PFS survival at the end of 3 years. The median PFS is not recordable at the moment, and the hazard ratio is 0.19. Lorlatinib is a difficult drug to give. It has a different side effect profile as compared to the other TKIs. There's a lot of CNS side effects, and a lot of it comes because of the fact that a lot of drug is delivered to the CNS. So we see cognitive disturbances, mood and speech disturbances. So this is not a very easy drug to give. And along with that, we have hypercholesterolemia and hypertriglyceridemia, which we also see more in this particular drug. So coming to the drug which I would be discussing in detail is Alecensa in the ALK-positive small cell lung CA. I want to highlight that we have the maximum data for Alecensa and we've got 3 consistent phase 3 trials. So among all the ALK inhibitors, I think this is the drug that has the most amount of data, and this is the drug that has the OS data as well. So we'll start off with the ALEX phase 3 study. This was a study done in the stage 3B and 4 non-small cell lung CA patients who are ALK positive and treatment naive. CNS metastasis at baseline was allowed, and they were stratified based on that. They were stratified to 2 arms. Alectinib was 600 mg twice a day versus crizotinib, 250 twice a day. Just to highlight, there were 38 patients with CNS metastasis in the crizotinib arm versus 42 in the alectinib arm. This is the PFS at the end. So you can see that the separation of curves actually start really early on. The median PFS of about 34.8 months versus 10.9 in the crizotinib arm with a hazard ratio of 0.43. The final PFS analysis of ALEX actually demonstrated that this is almost 3 times the benefit of what you could get from crizotinib. So nearly 3 years, you're free from actually getting a disease. You're free from disease recurrence. when they looked at the subset analysis, they found that, irrespective of whether you had CNS metastasis or not, there was an improvement with giving alectinib. And especially, I would like to highlight on the CNS, the PFS, especially in patients who have baseline CNS metastasis. You can see that in pre-existing CNS metastasis, you have a PFS of almost 25.4 months. That is, you are free of disease for almost 2 years when you're on alectinib, versus 7.4 months for crizotinib. People who did not have CNS metastasis had a median PFS of about 38.6 months versus 14.8 in a crizotinib arm. So the protection lasts for many years, irrespective of whether you had a CNS metastasis or not. The final PFS, you can see at the end of 4 years, 38% were actually free from disease as compared to the people who did not have the drug, alectinib. The cumulative incidence of CNS progression, this is a very important slide. There was almost 84% reduction as compared to crizotinib. 41% of the people did not have any CNS metastasis at the end of 1 year, and you can see that the curve actually plateaus. So there's a lot of protection. This is very important to note that there's almost 84% reduction in the rate of getting a CNS progressive event. The duration of response is sustained, as you can see in this graph. This is, again, a very important point. The CNS progression without prior systemic progressive disease. 68% of the population had it in the crizotinib arm, but you can see it is only 18% in the alectinib arm. So there is a significant reduction in the risk of a CNS progressive event when you give alectinib. And 6 out of 10 patients are alive at the end of 5 years. This is the overall survival data. This is the only TKI that has such a strong overall survival. More than 60% of the OS rates at the end of 5 years, the highest which is for any ALK treatment. And this is at the end of follow-up of about 48 months. This is, again, still, we are still yet to see responses. So there's a plateauing curve, and we would see probably better responses. 5-year survival rates is about 62.5%. So 3-year longer treatment, with a 3-year longer treatment with alectinib as compared to crizotinib, because more patients were on alectinib for a longer period, they actually found that the side effects were still lesser in the alectinib arm as compared to crizotinib. So this is a well-tolerated drug with a good overall survival. So the safety profile, I think, continues to be very manageable. This is the preferred first line as per the NCCN guidelines, and of course the ESMO guidelines as well. So it's demonstrated a significant PFS benefit. We'll talk about Alicia after this. There is a significant CNS protection, good duration of response, delayed time to CNS metastasis with the alectinib. Now, Alicia was a phase 3 study, and this was done in the Asian population. Similar study design. The median follow-up was about 61 months with alectinib. Median duration of survival was 61 months with alectinib versus 51 months with crizotinib. You can see, again, there's a very early separation of curves. 41.6 months median PFS with alectinib, even higher than what you saw in ALEX. And it was 11.1 months with crizotinib. The hazard ratio was 0.33. When we look at CNS metastasis, again, this is what we're really worried about in non-small cell lung CA. Hazard ratio of 0.17. That means this was almost an 83% reduction in the risk of developing CNS metastasis. And these are just shows how effective this drug is for the brain metastasis. And this is particularly in the Asian population. There was a clinical meaningful 5-year survival with the global, as observed with the global ALEX study. Alectinib was 62.5% versus 45.5% with crizotinib. Again, so we have 2 trials showing a significant OS data with an ALK inhibitor. The OS, according to the CNS brain metastasis status, also showed that alectinib did well. Alectinib, the 5-year overall survival rate was 63 months versus 39 months with crizotinib. And those who did not have brain metastasis, it was 67.8 months versus 64 months. Time to CNS progression, again, in this study, the hazard ratio was 0.16. There was an 84% reduction in the risk of CNS progression. You can see the curves, they're going on, they're plateaued actually after 60 months. These are very impressive curves, this is very impressive survival data. And this is what ultimately this is what we're worried about. We're worried about a CNS progression, and we're able to delay that by giving alectinib. So in summary, the 5-year update so we've got a 5-year overall survival data as well. So we've got enough time to actually look at this drug, deliberate, and we know that this is going to work. The median PFS is 41.6 months for alectinib versus 11.1 months for crizotinib. It delayed the time to CNS progression. Whether you had CNS mets or not, you would get benefit. And there is a clinical meaningful 5-year survival rate, as 66.4% people alive at the end of 5 years. So, and the safety profile, want to highlight again, there's a longer treatment. You're putting patients on alectinib for a longer time, but yet your patients are doing better. Yeah, thank you.
So I request Dr. Govind Babu sir to please moderate the session.
So good afternoon. I think I've heard enough about alectinib. So let's put this into perspective. Let me call my panelists, Dr. Suman, Dr. Nitin Yashas, Dr. Mangesh Kamath. I don't see Mangesh. Yeah, he's there. Dr. Mohammad Nasir. Okay, so let's start off. There's a disclaimer. So this is just to tell you that the taxonomy of metastatic non-small cell lung cancer has evolved dramatically. This slide actually shows you how we today look at non-small cell lung cancer. Essentially, first we see whether it is non-squamous or squamous, and then whether you could use immunotherapy in them, and then all the targetable mutations that we have. And today we are talking about ALK here. So as you heard, that we have a host of ALK inhibitors today, and the first one was crizotinib, then came enceritinib, then alectinib, then brigatinib, and the recent one being lorlatinib. This is again just to show you the treatment landscape in ALK positive non-small cell lung cancer. We understood about ALK way back in 2007, but we started targeting only in 2011. And this is showing you the milestones in the US and EU. Now, the ALK positive patients have an outstanding OS, as you saw with the studies with alectinib. And this is the French extended access program, and which showed that this is a data from 318 patients with an overall survival of 7.5 years. So this is essentially showing you that those patients who got crizotinib and a next generation ALK inhibitor survived for almost 90 months, whereas those who got crizotinib and followed by chemotherapy about 30 months, and those with best supportive care only about 20 months. So the treatment, is it a sprint or a relay? We will end by trying to answer this question towards the end of the discussion. So this is data from the Flateron database showing you that ALK positive disease can be treated with multiple lines of therapy. And this is data of 63,677 patients, of which 739 were ALK positive. And as you can see here, these patients received up to 11 lines of treatment, several lines of ALK inhibitors and platinum-based chemotherapy at some point of time. So we know that these patients can do well and receive multiple lines of therapy. So with that, let's start with a case. This is a 50-year-old Indian woman, non-smoker, presents with back pain, breathlessness, cough of 3 months duration. HRCT shows solitary tumor in the left lower lobe and moderate ipsilateral pleural effusion. Histopathology reveals moderately differentiated adenocarcinoma, EGFR negative, ALK positive by IHC. PET-CT shows lung carcinoma with pleural effusion and spinal mets. So this is a stage 4 ALK positive non-small cell lung cancer. So this question is for Sumant. What are the other key factors you consider when selecting first-line treatment for patients with advanced ALK positive non-small cell? One, of course, is the ALK positivity, but beyond that.
apart from ALK being positive, I mean, I will look at whether there are brain mets or not.
Right.
That's number one. I will look at the other comorbidities that the patient has, because each of the ALK inhibitor has a different safety profile. So that is something that I would look at.
Right.
I would look at the age of the patient. I would look at the, probably.
Why would you look at the age of the patient?
Whether they would be able to tolerate. Again, it's something related to the side effects.
Any of the panelists differ on, would you look at the age as a factor for deciding ALK inhibitor?
Not age per se, performance status will be important. I wouldn't look at age per se, but performance status, and most importantly, would be the metabolic profile.
Even performance status.
Yeah, so for example, sir, if you have a patient with spinal mets, and in case the patient has developed, a cord compression causing paraparesis, I would probably rely on chemotherapy for quicker responses. And
Really?
Yes?
Really?
Yes, sir.
Okay.
Okay. And I would introduce ALK inhibitors. It is possible for us to introduce ALK inhibitors together.
There's an interesting thing that came up, so let's discuss.
Yes. And apart from that, I will also look at the metabolic profile. I would also look at so somebody who's got a lot of dyslipidemia, I would not prefer one drug. Hypertension, especially those.
I must remind you, this is a Roche symposium. Okay, Nitin, what are your thoughts on this?
I would try to differ here a little bit because I think after my experience as a resident, and when I see that patient PS3, GCS8 taking alectinib through Ryle's tube and now surviving beyond 5 years, it has convinced me that rapidity of response, like we even talk about the CDK4/6 inhibitors.
We'll come to that as well. Yeah.
It's probably much more with ALK inhibitors. And even recently I had a patient with massive pleural effusion, poorly differentiated carcinoma, which came ALK positive. In 2 weeks, the X-ray showed complete expansion of the lung.
You didn't tap the pleural effusion? You did tap the pleural effusion?
No, didn't tap the pleural effusion because he was maintaining saturation on it. Gave him ALK and with just gave him alectinib only, and within 1.5 to 2 weeks, the X-ray showed complete resolution of the effusion.
Yeah.
So I'm beyond more convinced that when it's ALK, I think performance status, like I said, goes out of the window, and even rapidity of response. I think just because there is a driver pathway, we target it.
Mohammed, your thoughts?
Yeah, I kind of agree with Dr. Nitin, and performance status should not be a major concern.
Yeah.
So we can consider alectinib.
So I think the dictum in non-small cell lung cancer goes that if you have a driver mutation, target that driver first. I think that's what we always do. Okay, so these are some things that I've just put up, and as Suman said, because we are lost for the choice that we have with so many drugs, we would look at the toxicity profile most of the times to decide which drug we're going to give this patient. Okay, so this patient had brain mets at baseline. So Nitin, what will be your first line treatment? I think you already mentioned, but that was pleural effusion.
I think, like Dr. Mangesh said, I would also look at the metabolic profile of this patient. And just given the year, I mean, sort of more experience and exposure we have had, I would choose alectinib.
I thought we had more experience with crizotinib because that came in first.
But with brain mets, you know that the penetration of...
No, when you said experience, I thought about...
So I was talking of alectinib versus the other second generation.
Fair enough. So this is the data for second generation ALK inhibitor therapy. This is the for ceritinib, the ASCENT-4 study, alectinib, Alex, which you already heard about, and brigatinib. So this data has actually made the second generation ALK inhibitors as the standard of care today. So we no more talk about using first generation TKIs, although we have a lot of generics which are available today. So this is Alex data, which you already saw, the 5-year overall survival. And this is for Alex and GLX, showing you the advantage of alectinib. These graphs also you already saw in the Asian patients and the Japanese patients from the GLX. Crown study, Mangesh, would you like to just talk a little bit about what the study was?
So I'm not well versed with the names. If you can tell me the, yeah.
Okay.
So we have the Asian subset wherein we look at,
So essentially this study was looking at lorlatinib versus crizotinib.
Yeah.
Because this is the most recent one, I thought we'll take this into context as to how this compares with alectinib, and that's why I got up the study.
Correct. So basically you had the Asian subgroup and the overall population in this study, and then we found that lorlatinib in the overall population had a very good hazard ratio around 0.28 or something, and in the Asian subgroup the hazard ratio was 0.43. So even lorlatinib is also a drug which has got a very good CNS penetration. I think they've had stratification into those with brain metastasis and those without brain metastasis.
Right.
And they found that across both of the subsets, there were good responses with respect to CNS responses, as well as the fact that their PFS was statistically significant.
Yeah. So this is the OS curve at 2 years, 3 years, with a hazard ratio of 0.72. But the complete overall survival data is still mature at this point. So if you look at
I just wanted to make one point.
Go ahead.
In the Asian subset, in the crown versus alectinib, Alicia, in fact, they were similar. In fact, alectinib did better in the Asian population, slightly better.
Yeah. We are in India, so we must talk about Indian patients. And this Asian subset did not have a lot of Indian patients.
Yeah.
But that is the data that we have. We have to take that.
Yeah.
So this is the data for alectinib, brigatinib, and lorlatinib, looking at the efficacy. And this is looking at the hazard ratio for PFS, 0.50 for alectinib, 0.48 for brigatinib, and 0.27 for lorlatinib. And patients with brain mets at baseline, and those without brain mets, you can see the hazard ratio. The best one is for lorlatinib, of course, from this data that we have. So a word about discovery of ALK. Dr. Mohammed, would you like to say something about discovery? I already told you it was discovered in 2007.
Yeah, I'm not. In 2007, it was actually discovered with inversion seen in chromosome 2, which results in the fusion of EML4, leading to a translocation domain with the kinase of ALK. ALK4. So EML and ALK4 translocation is the one which is responsible for it, and it is an RNA-based study by which we detect, and this is the region which is targeted in these patients.
So the first ALK fusion that was described was in 2007 in Nature, and this was the variant 1 that was described. That was the first one. So this slide is to just show you that you have so many different variants. In the EML4 and ALK translocation itself, you have so many variants from V1 to V7, in fact V8 as well, V8A and V8B. And the lower ones show you the other translocations that are there. But clinically significant for us is V1, V2, and V3. So, Suman, again, does the type of ALK variant impact your decision?
So as the variant 3 does the worst, as compared to all the other variants. But I think as of today, I would not change my decision based on the variant. The ALK approvals are all irrespective of the this profiling. So it wouldn't impact my decision, but probably I would be able to expect the outcome based on the variant if I had the variant information.
Yeah, so this is a study published by Dr. Ullas from RGCI, and this is data of 91 patients. And you can see that the various ones that they described are, the most common one was V1, 35%, V3 in 25%, V2 in 15%, and V5A was seen in 2%. And as you mentioned, they did not see any great difference, but they found that V2 seemed to be prognostically better than V1. Again, the numbers are small, so you really can't conclude confidently on these numbers. So this is Alex trial data showing that the activity of alectinib is consistent across all ALK variants. So you're right in saying that you don't look at variants because they act against all variants. So Nitin, do you biopsy all your ALK patients at progression?
Depends on the type of progression and what was the ALK that I used. So if I was using crizotinib and if there were brain mets, I wouldn't choose to do. But however, if I was using a second generation ALK TK and there was...
Let's say there's a progression in a place where you can biopsy, eminently biopsyable site.
We would sort of still in our center gone towards liquid biopsy. because of the fact that there is some data to say that the resistance and the compound mutations, you can pick it up on a liquid biopsy more rather than the solid biopsy.
Okay. But I think in ALK, it's really not still a standard because of the labs that we have. Because every few labs that are actually looking at the resistance pathways for ALK, but still there are a few that are doing in Bangalore itself. So I think we'll look at that. This is just to show you the mechanisms of resistance after crizotinib. This is after the second generation TKI, and this is after, this is about the variant 3 after crizotinib versus second generation, that the variant 3 is more with the second generation than with the first generation. Again, this is a sort of a summary slide that I put in to say that based on what ALK inhibitor you're using, the resistance mechanisms are different, and this is why we need to look at what the resistance mechanism is at progression. So Mangesh, this is for you. How relevant is the safety profile of the TKI that you use? You look at efficacy plus safety or efficacy at the cost of safety?
So efficacy plus safety is obviously our goal. I look at efficacy first because when the patient has come to us as a metastatic disease, I would look at whether we can control the disease as much as possible. And thankfully till now, at least most of the second generation that we use, if we are able to do regular profiling with basic investigations like CBC, LFTs, lipid profile, we should be able to pick up if there are any warning signals for adverse events to occur. But we always want to look at efficacy plus safety. So can I go for that biopsy and
yeah, go ahead.
thing? Yeah, so if it is biopsiable, I would prefer to do a biopsy on that because of the fact that there could be also a histological transformation. And another aspect is they found that a particular variant, the G1202R, is possibly picked much better in a biopsy.
I'll show you some data on the liquid biopsy as
so,
also.
And that's where you could offer a particular
but
drug.
again, as the dictum goes, if you have a site where you can biopsy easily without problems, do that. If you really believe in liquid biopsy, what is advised is you do both of them simultaneously. You might pick up more with a liquid biopsy, of course, but when you have a tissue, you try and do that, especially because of the change in histology that can occur. Yeah. So importance of assessing CNS and extra CNS disease. Dr. Mohammed, what are your thoughts on this?
Yeah, definitely. We would like to see CNS involvement when I start the treatment because both alectinib and lorlatinib, they have better CNS penetration. But I have relatively more patients on alectinib and the safety profile is also relatively better. So if the patient is having CNS metastasis, I would consider alectinib and over lorlatinib. And I also consider the additional comorbidities the patient has because lorlatinib, like the speaker told, it is relatively a difficult drug with respect to managing hypertriglyceridemia, cholesteremia, CNS manifestation. I have one patient who suddenly put on weight over a period of 3 months and she almost gained almost 7 to 8 kgs. So she had this syndrome X kind of features. Whenever there is CNS mets, I would consider alectinib over lorlatinib.
So can I just make out by a raise of hand how many medical oncologists are in the audience? Okay, good. Why I asked this question was, Bowman will remember the days when we started medical oncology, we wouldn't even look for screening for brain mets in lung because we had nothing to offer, so we were not doing. But today it's a norm. At baseline, you have to assess if there is CNS disease
we had
or
only
not.
mitomycin, vinblastine and cisplatin when I started.
Correct.
That was the protocol we were using.
Exactly.
And if the patient was above 60, you would say, you will not tolerate this 3, please go home.
Exactly.
And sir, if the patient has a limited number of brain mets, and no symptoms, you can also get away with radiation initially.
Yeah, we don't give radiation at all. No.
Yes, yes. So
you remember we had such heated discussions in the tumor board.
Yes.
Yeah. So this is one small thing that I picked up, that owing to poor penetration of crizotinib, the CNS penetrant drugs given after crizotinib may have prediction of having higher efficacy in the CNS than extra CNS disease. And the CNS lesions may behave as treatment-naive disease. But hardly anyway, we don't use crizotinib today, but this is an interesting fact that I picked up. So this is looking at the cranial overall response rates. For brigatinib, it's 56%. Ceritinib 33 to 58%, alectinib 46 to 50%, and lorlatinib 73%. So this is for Suman. Are you bothered about assessing the depth of target lesion shrinkage?
In routine practice or in the trials? In the routine practice.
Routine practice, not a clinical trial.
Definitely, I mean, the greater the depth of tumor shrinkage, the better is the response, and we saw it in alectinib. I mean, I actually hid the slide because of time constraints.
So this generally we talk about in hematologic malignancies, but it's rapidly picking up in solid tumors.
It's picking up in solid as well, and alectinib did show a remarkably higher depth in tumor shrinkage. Definitely makes an impact on the PFS and the OS both.
Right. So this was considered some time back as an exploratory analysis, and they found that those patients who had a target lesion shrinkage by assessment, they achieved, even though they have not achieved confirmed PR, had numerical longer PFS and OS than patients without tumor shrinkage. And this is, of course, from the crizotinib era. There's a multivariate analysis of about 305 patients, and they found that the OS increase at the quartile of depth of target lesion response increased. And this is for adjusted overall survival hazard ratio. And if you see here, if the shrinkage was 1 to 25%, the HR was 0.94, 26 to 50%, 0.56, 51 to 75%, 0.28, 76 to 100%, 0.05. So this is one study which has actually really in depth looked at this shrinkage and looked at overall survival. So Nitin, lorlatinib has a distinct side effect profile. I think Suman actually showed this. Have you used lorlatinib?
Yes, so I had a very bad experience recently.
So I caught the right guy to talk about it.
Paradoxically enough, though the brain penetration is more, it has also been shown that the CNS side effects are more when there is baseline brain mets.
And as Subhan said, it's because the concentration is higher in the CNS.
And the patient actually started seeing people jump out of TV, sitting on fan, asking her 40-year-old son why you're not doing homework. And when we stop it, the disease went up very rapidly. Though this was, of course, in the ROS mutation, but lorlatinib side effect, and another in 2 patients with ALK, the triglycerides and the lipid profile just shot up. So managing the side effect profile in lorlatinib will always be a challenge and would need more monitoring from us as compared to alectinib.
Right. So this slide you already saw from Suman's talk. Again, the same slide talking about the side effects, comparing lorlatinib and crizotinib. So these are the things that we look at. Speech dysarthria, slow speech, speech disorder, irritability, anxiety, depression. And in the cognitive, we have memory impairment, cognitive disorder, and amnesia. Yes, Bowman, you have something to say? Since you finish. Okay. And this is, again, this is as reported by the patients here, cognitive, mood, and speech. And these are the hypertriglyceridemia, which you already heard about. Increased weight. I have a patient who's a lady who's put on weight suddenly. And this is an important thing that we must keep in mind. Peripheral neuropathy as well. In the gastrointestinal, it is constipation. This is from the TMH 34 patient data, and the estimated PFS in this study was 9.6 months. Of course, they had used lorlatinib at several lines, after several lines of therapy, and they in fact showed that it had excellent efficacy in later lines as well. It's not that the best response is in the first line. So this is the summary of time of first onset duration of CNS, which was seen in about 35 patients, and the onset varied from 1 to 3.5 months. This is talking about intervention for these side effects, and it had to be rapid. And as Nitin mentioned, you have to be aware of this and really look at the side effects. And what has come out from the real world data is that the CNS toxicity is much higher than the trial data. This is from the MGH cohort versus the trial cohort. And as you can see, the neurological effect described is close to 60% here as compared to about 45% in the trial. Of course, we have high response rates, even in resistant ALK mutations. And once there is resistance to lorlatinib, it's difficult to treat because the bypass tracts appear earlier and are difficult to address in lorlatinib if it is used up front. And
So just
this is
just this thing in the
Yeah.
slide which you showed. Just like we have the C797 mutation,
You
some
can-
of these mutations make them sensitive to crizotinib also.
Exactly. That is also there. I'll show you in the sequencing part. So you are talking about tumor and liquid biopsy, and this is to actually look at the spectrum compared with ctDNA and tumor tissue. And again, these are unique mutations that occur in those patients who get lorlatinib. So the complex resistance mutations after lorlatinib are relatively frequent and resistant to many therapies that we have today. So this is sort of a sequencing that we can do. So back to our patient, she was started on alectinib, and there's the response that you have. After 32 months of alectinib, she showed progression. Mangesh, what would you do now?
So if I have a biopsyable lesion, then I would go for biopsy, check whether it's just histological transformation or
Right.
secondary mutations.
Okay.
And based on secondary mutations, I'm going to profile them and try and see which of the TKIs that I have at my disposal to be used for the patient.
Right. So these are two small studies, the ASCEND-9, which looked at ceritinib alpha after alectinib and brigatinib after alectinib. And yeah, Nitin, again, progression with lorlatinib.
So same thing, we sort of have to look at the mutation profile. And of course, in this setting, I would do a solid biopsy if feasible, because again, to look at any histological
Right.
transformation, and also to look at, are there any off-ALK pathways developing in the MET or
Right.
the EGFR pathways?
So I think first line experience we already heard from the panelists. So sequencing matters. This is sort of an algorithm that has been put forth. So this is when we had crizotinib as first line. But if the first line is the second generation ALK inhibitors, then for the second line you have lorlatinib, encertinib, and brigatinib. And at some point of time, they would get platinum-based chemotherapy. And fourth line maybe immunotherapy. And based on the mutation, maybe you can reintroduce the ceritinib. This is the ESMO guidelines that has been published recently. And these are the guidelines. So should we optimally sequence these 4 active agents? So it's like a long distance relay, not a sprint. And this is the ideal sequencing probably today. I'll just take your attention to the last one. Next gen upfront, alectinib, PFS of approximately 3.48 months, then lorlatinib 5.5 months, and chemotherapy 2 months, about 40 months. So this is an average PFS that you're looking at for your patients with ALK positivity. So any last thoughts by the panelists? If there are none, I think we have short of
I'll
time.
just ask
Thank you
one-
very much.
I'll
Yeah,
just-
go ahead.
Just ask you one question, Govind. If this was not a Roche symposium, with CNS metastasis upfront, what would you do? Alectinib or lorlatinib?
Because the best activity is for lorlatinib, I would use that. But again, as everybody mentioned here, with close monitoring for the development of side effects.
Sir,
Thank you.
Just a point. Now
Yeah.
we know that the mutation profile affects the, the efficacy of many of these drugs, and they have different. For example, brigatinib is considered like a broad spectrum ALK inhibitor compared
Yeah.
to most of the others. And then we know that lorlatinib acts on certain very difficult mutations such as G1202R. So we are a lot of times diagnosing patients with ALK, with IHC. So do we recommend, or is there should we move on to NGS only, or are we still okay with the IHC based ALK? Is something that I have been asking, and do we have
That's
any
right.
answers to that?
You know, with the cost of NGS coming down and the information that you're going to get from NGS is much better than what you've been doing as just for a lung panel so far, I think it's better to do a NGS now.
Should we put aside IHC with ALK, or should we? Is
I
there
think,
any extra?
again, you need
advantage?
to personalize based on the therapy that you're going to give your patient, based on what your patient can get done. But in the ideal world, you have to do the NGS. And you know, earlier for EGFR itself, we were not looking at the different mutations, but we are now looking at it. So I think it will happen. So thank you very much. Thanks, my panelists.
Thank you very much for a wonderful panel discussion. And really, we love the sprint and the relay kind of a discussion. And we have the next speaker with us, Dr. Prasad, and Prasad Narayan from Bangalore. And he's going to talk on the moving the needle for metastatic non-small cell lung cancer management, focusing on the PD-L1 negatives.
Good evening. I thank the organizers for this opportunity. So I had a talk before when we were talking about early lung cancer and the role of immunotherapy there. So I think we are reaching a
backwards. This patient has diabetes, this patient had restricted lung disease. Would you take the risk of adding chemoimmunotherapy and maybe putting him at risk? I think you put that forward. Is there any patient who you would not give in case patient is not operated later? So any of you, Amit?
See, we've definitely seen, and they say that PDL1 less than 49%.
I'm talking about comorbidity here actually. I'm saying somebody with a restrictive lung disease, fiber consolidative disease, are you happy with immunotherapy?
I'm not happy with adding immunotherapy to this patient
Okay.
with restrictive lung disease because invariably you do get non-infective inflammatory pneumonitis,
Okay.
which may
Okay.
complicate
Okay.
issues later on.
And
this
doc-
could be lethal.
Dr. Satish, first you, and then maybe I'll bring this to a surgical colleague of mine. This patient, is he actually a surgical candidate in the first place?
Yeah, this I'll definitely agree with Dr. Amit. It is a first MDT discussion with a
Yes.
surgeon, and main important is pulmonologist's role is there. Here.
And how bad is the
Yes,
pulmonary
yeah,
function
really
test and all?
I don't think pulmonary function is good to go for surgery here. Like if at all, I'll go with a radiation and we have to think about another molecular test like only like NGSS come as a KRAS and PD-L1 positive.
That's correct.
Yeah, that's what. Like definitely go for a radiation, but he's not fit for even a CTRT also. If we
He's
have to go
not.
for sequentially, you have to go. That we have to decide after the MDT discussion.
And if he's not fit for CTRT, is not fit for surgery.
Sequential therapy. That's what chemo, radiation. Then after that, yeah. Those
Okay.
things
So will we treat him as stage 4 then?
not like stage 4, but definitely consolidation therapy is the radiation part.
Okay.
But it's
Shub-
not fit for a surgery. That's what.
Shubham, what's your view? This gentleman has a restrictive lung disease. We don't have a pulmonologist in the house yet. Can we have a mic, please? Who will tell us how bad it is? But
Yeah.
he is PS1.
No, but see, if I were to optimize a patient by giving him some medicine, the systemic therapy, I would look at probably the disease being large enough which is causing the lung to be compromised. So the disease does not appear to be large enough. This is a parenchymal disease. Restrictive lung disease is a parenchymal disease which is not going to improve with time. He's already 75, he's not going to get younger. So I think that's a collective decision, and that is what Dr. Satish mentioned about the MDT
Absolutely.
and getting the part of it, and
The
we
most
pull
critical
out,
point.
and we pull out and we say that go
Yeah.
ahead.
Okay. So what I'm hearing, and I'll end this discussion here, that if a patient has restrictive lung disease and got a disease like this, we would try to optimize him. We would try to get obviously MDT inside, but he may not tolerate chemoradiation either. So it may be worthwhile trying back to question of chemoimmunotherapy or chemotherapy at least. If he improves, he may be a surgical candidate. Amit, last
Just
word on that.
one information that I need. What is the ECOG performance score?
1.
1.
He's PS.
See, many years ago we've been discussing, there had been forums on only ECOG performance scores in lung, that if you have a poor ECOG performance score, invariably the outcome is poor.
So that's a given, because almost nothing that we've discussed all day today had a PS of 2 and 3 in it. So I think if you're doing anything, it is very valid to say, do this in only people who are 0 and 1 and nobody. And there won't be 0 lung cancer, because lung cancer can't be 0. So it's
That
1.
That means with a patient who's having a restrictive lung disease with a PS of 1, I expect a good lung function.
Yeah, you're conjecturing. We'll move on. Okay. So this was EMPOWER stage 3, which basically completely resected stage 1, stage 3 a disease. What we didn't discuss was that this person was optimized and operated, and this post-chemotherapy, post-surgery, post-chemotherapy, these patients were randomized to immunotherapy or not. And I think it was a very interesting study, as I said in my initial discussion, because at 2 years, your numbers were sitting at a EFS of 74% versus 61. The background 61 was higher. What I was not discussing in my initial talk was that this clearly showed that this group was a better lung cancer group than the usual group that we see. They possibly were better performance status, better staging, less nodal disease. So 61% at 2 years is not a bad number for a lung cancer, but immunotherapy improved that number by almost 13%, and that's a big gain to gain. The OS by biomarkers was again very interesting. Of course, the TC less than 1 was slightly more towards the right, but TC between 1 to 49 in the middle, TC more than 50 extreme to the left, but TC more than 1, which was maybe driven by TC 50, was towards the left as well. When we excluded EGFR ALK, which we will in practice, and I think that's important, almost the entire 50 and 1 to 49 also went up. Any comments on that? Maybe I can, Ravi, answer this, and then Srinivas, I'll ask you the next question. So what I'm trying to say, in practice, we're going to exclude EGFR ALK for all of these patients. So do you think that you will take a cutoff of more than 1, or based on the fact that in the overall group that doesn't seem to fit in?
Yes, sir. In our practice, I think we have seen that without giving any adjuvant maintenance, probably this 60% is not what we are looking at. So if PD-L1 is above 1%, we'll be happy to add in that.
Okay, so if PD-L1 more than 1%, we will take this patient because that's the overall survival curve. Do remember that. For stage 2, stage 3, of course, the all patient group showed benefit towards the left. This was the neoadjuvant perioperative with Prashad and I discussed in the morning, and we were going on, I was at least going on and on about the 65% versus 75. So this patient did have adjuvant Tecentriq, he completed it. To be fair, we started before the approval came in, but patient is clinically well and with no signs of recurrence, although he's sitting almost at 13, 14 months, so we'll have to wait and see. But he is sitting more than almost 18 to 19 months from surgery, so that's a gain. The first we were talking about was adjuvant Tecentriq or atezolizumab. The second big question for me is atezolizumab in metastatic non-small cell lung cancer with poor performance status. Let me go to Dr. Srinivas. Dr. Srinivas, when you, and I'll define this for you actually before we go any further. So this was the clinical poor group, and very busy slide. I'll read it out. In the Ipsos study, where majority of patients had respiratory thoracic mediastinal disorders or vascular disorders or metabolism nutritional disorders, that is diabetes, which is half of India, or cardiac disorders or musculoskeletal disorders or gastrointestinal disorders or nervous system disorders, that's all of India, renal and urinary disorders, psychiatric disorders, all of India, blood and lymphatic system disorders, reproductive system disorders. So this is your majority of poor risk goes in Ipsos. How many population that comes to your clinic fits into this criteria of Ipsos?
Majority of them, they will fit into, especially diabetes and cardiac, because most of them will be smoking history always will be there in SLC. So we'll have more of almost 70 to 80% will have diabetes and cardiac dysfunction.
Yeah. And you're spot on right. When you look at this list, it's everyone. But really what this list was trying to tell me when I read it was that for that patient where when he comes in and I'm nervous because his diabetes is poorly controlled, he has started with proteinuria slightly, he is actually chronic smoker, and I'm wondering whether he'll have a ejection fraction which will go away with cisplatin and hydration. I do have another regime which is available. So, Amit, why don't I give the case to you? This is an 80-year-old female who presented with cough, breathlessness, difficulty in walking for the last 1 month. Comorbidity is diabetes, mild proteinuria, GFR 48. You know what I'm trying to show here? This is a common patient because when you start checking your diabetics, you get this. A PS has gone to 2 recently, which is most likely because of the disease, and a PET scan basically shows that she has a locally advanced disease, and this is an adenocarcinoma. Comprehensive, this is, let's say, stage 4 disease. Let's forget the 3B. It's stage 4 disease, and PD-L1 is 54, KRAS is mutated, P53 is mutated. What would you do here?
no choice in this panel, only one letter, atezolizumab.
Actually, that is the crux of the matter here. We do not really have a study in poor risk patients, surprisingly, because it was never studied. And we have a study which looked at this population with all those, and that is a lot of our patients. It's just that because of that one patient of ours, or maybe not one, many patients of ours, who had such a fantastic response to pembrolizumab and chemotherapy, we are ignoring that a lot of our patients are poor risk in our population. We're just so influenced by that patient who turned around, went from a PS maybe 2 to PS 0, we forget, but there are comorbidities. Yes, please.
I'll agree with the studies that are like a poor PS we can give that atezolizumab. We are happy that because this patient is symptomatic breathlessness, are you convinced with giving only single agent atezolizumab here? No, I'll agree. No, I'm telling symptomatic breathlessness is there. See, I know that comorbid is there. Are you try to do atezolizumab with some additional cytotoxic drug like weekly nab-paclitaxel? You want to bring down the symptoms.
So I think I think you have a very valid point. You have a very valid point, because what we have learned so far, and rightfully so, is if your patient has come with symptomatic disease and the performance status has dipped because of the disease, do not start with chemotherapy. That's the baseline. I don't think we are ever wrong in doing that. But here you have a different problem in hand.
When a high volume disease, we try to incline to combination of chemo immunotherapy will give. In this case, can have a modification weekly schedule chemo with the combination of atezolizumab.
Absolutely fine. But now you have a problem in hand. Your problem is that in the first pembrolizumab registration trial data, almost 2 versus 6% patients, creatinine went up. So while you are right in looking at those graphs and your experience and doing that, will you genuinely be able to treat this patient like the one without diabetes, without nephropathy? That's the question. I'm not questioning the role of chemotherapy here, and possibly in practice you will do a little bit of this, a little bit of that. Now what I'm saying is this is not the patient where you will manage 4 cycles of cisplatin and pemetrexate, or you will not. So if you're not going to be managing that, are you really applying the data and the experience from the past, or you're just feeling reassured that I'll somehow manage? Because this patient has a probability, we don't know, has a probability that halfway through, at 3 months, you're neither here nor there.
Yes,
while you could have started with atezolizumab.
We used to exclude because the performance status is poor, like that we used to exclude. Immunotherapy is not going to work in a poor performance status. That was the previous thought. Now
agreed. But I'm saying with the symptom, with the fact that the PS has gone down, also is a fact that the patient has a nephropathy and is diabetic. And I don't think we can ignore that. We do ignore that in the clinic because you're so influenced by the cancer.
And see, other thing is, why I ruled out chemotherapy absolutely in this patient is, one is age is 81, the other is PS is 2, but diabetic nephropathy, which is second year. So,
good point. Age is very important here as well.
Majorly, I think so. I first made patients were not suitable for chemo.
Absolutely, sir. Absolutely. And what I was trying to say in my first chart is that majority of patients have those symptoms, but they are still suitable for chemotherapy. In Ipsos, patients were not suitable, but I'm arguing, and I've seen in my own experience by myself, I'm not saying others, when a patient comes, in my mind, I try to make them suitable for chemotherapy. I was like, maybe I can do this, maybe I can do that. And when I look back at those patients, they have fallen off the curve after a while. Now when I think about it, and that's why I said the 4 reasons of atezolizumab, which I'm putting up, are the ones which I think about practice, really, I'm thinking, why don't I use this when there is a separation of curves there?
I have one patient recently we are treating. The PD-L1 is less than 10%. So with carboplatin and immunotherapy, and he's doing, he's showing symptoms of, signs of improvement actually. So I think.
So I'm absolutely not denying that, and I am saying that we will have to use our judgment. But yeah, we shouldn't be dismissing the fact that we have data there. So this was Empower 110, obviously. Where atezo was compared for TC3, IC3, we saw that it did meet its subgroup analysis. I will skip a little bit of that. So this is the first line atezo monotherapy versus single agent chemotherapy, non-small cell lung cancer. And this was the Ipsos study we are talking about. And this was the overall survival. And of course, it's quite dismal, 2 years, 24%. But this group is the one where, if you see, the baseline is sitting at almost 10%. So there's still a jump in your worst group patients who are not chemo able. And that's the only point I'm trying to make. Not chemo able, or maybe not chemo able, or maybe you'll throw them off the cusp. You do have a treatment which works and raises the bar. Right. So what I'll do is we gave anyway. So given the high PD-L1 poor performance status, we did give atezo monotherapy. The patient had the partial response at 3 months with no major side effects and has not progressed at 11 months. And I do want you to look at that actually, PFS for that reason. Do how the lines cling onto each other in the first 6 months. So we are really looking at lack of progression rather than some major responses followed by failure because your therapy stopped in between. Third point, I am running short of time, is atezo in second line. So these are patients who, although a lot of patients today would have first-line immunotherapy, but still there are patients who will have first-line chemotherapy because of affordability or whatever the other reason, and will come to you second line. Now, we have a patient here. We have, and maybe we can ask Dr. Nasir to take this. So he presented in 17 with interstitial lung disease and some pneumonic consolidation. We had a tumor cell on biopsy which was BERV4 focally positive with napsin A. Occasionally TTF1, 2. PET CT scan showed pleural-based mass in the basal segment, which was big. He underwent a VATS lobectomy. Histopathology was node positive, CK719 negative, napsin and TTF1 positive. So first line, he had adjuvant PEM and platinum, 4 cycles, which resulted in his creatinine going from 0.8 to 1.5. So we rendered him nephropathic because of chemotherapy. And then he had radiotherapy, which completed in August or July of 2018. But in 21, which is 3 years later, he had a recurrence. And the pleural biopsy showed, again, it was poorly differentiated adenocarcinoma. So we sent for a Foundation 1 CDX, and we started him on some chemotherapy. The Foundation 1 tissue showed PD-L1 was less than 1%. And this is what I want to discuss today. Second line therapy, this was not strictly, he was 3 years out, but you have patients who are coming within 1 year. Second line therapy and PD-L1 less than 1%, which I think is a unique group. It's not rare, but we don't know what to do about them.
Yeah, this is, like you said, the third patient. It's a specific indication where atezolizumab fits in, less than 1%. PD-L1 expression and second line setting. This group of patient I would consider immunotherapy atezolizumab with another chemotherapy regimen, the one which has not been
Not
used
nivolumab. There's data on nivolumab second line too.
There is nivolumab. There is data for double immunotherapy also. So, but I would consider for the stage 4 disease with extensive disease burden, combination of chemotherapy plus immunotherapy would be a better option.
Okay. So this was essentially OAK3, which was compared dosi with Tecentriq, and it did meet its co-primary endpoint of OS and intention to treat, very effective, which was basically seen in all groups, but of course TC3, IC3 always do better in this group. There's a fair amount of representation from both in squam and in adenocarcinoma. So, and again, these are things we have seen in most studies. When you do the efficacy check comparison cross trial, that was useful in both. But what I want you to bring about is a very interesting this analysis, which was the PD-L1 less than 1% group, which is Nasir what you possibly were suggesting to, where in checkmate 057 in Nivo versus Dosi, in the subgroup less than 1%, we saw that the median OS had changed from 10.5 to 10.1% cross trial. But in the TC0-IC0 group, we saw actually a gain of almost 4 months and a hazard ratio of 0.75. So, Dr. Satish CT, do you feel that this is compelling enough that you have two choices? Would you use atezolizumab, or you feel actually I have good experience with nivolumab, why change?
Yeah, at current situation, I'll definitely go with the atezolizumab because of the data is impressive in that even though it is cross.
Not because this is Roche sponsored, forget that.
Like Roche,
yeah.
Because practical in our India is like a cost factor, PAP, that is the one most important
okay.
actually.
Fair enough.
What is struggling with even BMS molecule. Like definitely that it is not like one day treatment, it's like definitely patient has to go for years together. That's why like we are definitely practical, both the drugs are approved, we can give it. But both the choice are there, data is favoring towards atezolizumab.
Excellent, good point.
I'll try to favor atezolizumab.
Affordability and the data together. Right, okay.
Can I go some off-label here?
Pardon me?
Can I go somewhere?
You can go wherever you want to go.
The point is you showed the Foundation 1 report. Though he doesn't have a classical BRAF, there is a BRAF mutation and a CDK anti-loss.
So
can we address that?
Amit, so let me go back to that. So we did address that, and he was not sensitive to BRAF inhibitor, first of all. And second of all, for me to go off-label, I actually need to tell me that his other options are poor. I would not use an off-label therapy in a patient who actually has another option. I would use off-label in this patient provided he has failed the next line of therapy. And in that respect, he did fail the next line of therapy. We did give him, started with pemetrexed again because creatinine 1.6 with a dose reduction, but it climbed up very sharply, changed to very low dose carboplatin and nab-paclitaxel with atezo. He had a good response. Post-response, we managed only on nab and atezo for a while, which he again managed for a while, but then progressed. Then we sent Foundation 1 and changed to gem and atezo, developed some hemoptysis. The BEV had to be stopped. And when we sent Foundation 1, you do know that the second Foundation 1 is free of cost when you're using a Roche product. So we had to send this Foundation 1 liquid. Oh, sorry, I'm sure it's free of cost. So we sent it, and this was very interesting. This is not off-label, this is on-label. This patient had a MET amplification, yeah.
Yeah.
You're saying something, yeah, please.
Like, yeah, I'll agree. The extensive treatment, what approved drug has to go, chemo, cytotoxic has gone. But currently, even if it's a BRAF mutation, is not a classical.
And
we don't have an option for that. Other than you may go chemo or bevacizumab combination will go.
And this helped in this patient doing what was by guideline helped, because by the time he managed a few years on what we should have done, he actually gained MET. And we have reported this in BTalk. We have reported that MET can be an escape mechanism even if you're not using targeted therapy. And when we reported that, we realized that that is the case. And I think Amit would have seen some of these where we haven't targeted, we haven't blocked anything. We were using chemo, but the escape mechanism of cancer was still a MET, and he did very well with MET inhibitor for a while. I am losing time, so I'm going to go fourth state, ABCP. Maybe I can get Dr. Ravi, who has not been speaking. Dr. Ravi, ABCP, your views. This is 54-year-old female presented with basically a metastatic EGFR mutated deletion 19. We gave osimertinib for a while, but failed in 13 months, possibly because there was a P53 sitting there. Genomic profiling showed 19 with EGFR amplification, which we know is a resistance mechanism to osimertinib and a PIK3 inhibitor. Your views on ABCP in this setting? Dr. Ravi.
Yes, sir. We have seen, now I think for EGFR amplification also we can target, but whenever they progress on, say, one targeted inhibitor, say EGFR, especially osimertinib, and when we don't have much options, I think combining BEV with atezo with chemotherapy is a...
Have you had a good experience with ABCP so far?
Pardon, sir?
Have you had a good experience with ABCP so far?
Because the setting what we are using, we don't expect great results because they're all resistant cases. But at least some 6-7 months of PFS is what we are looking. And now we have similar case of EGFR amplification, and we have used NR2 also.
Yeah, this was OS, but can I ask maybe someone else, Dr. Srinivas, have you had a reasonable kind of experience with ABCP, and has that been good?
Yeah, in EGFR mutation we are not used, but in separate like patients with pleural effusion, those settings definitely we have.
The bevacizumab has. Nasir, what about you, Dr. Nasir?
I've used it in 2 patients, exon 20, post-progression on amivantamab. It was a trial patient whom I had included.
We will discuss exon 20 in the next session.
Post-exon 20 progression, I had used ABCP regimen, and the patient had a very good PFS.
Amit, what's your view on this? This patient had EGFR amplification. This is not uncommon, I'm sure. What's your view on the combination of a VEGF inhibitor with a immunotherapy, with chemotherapy? Do you find that it logically fits?
It makes sense, particularly in this case. If we talk about the EGFR and the PIK3C alteration, what we are seeing.
Yeah.
So PIK3C alteration is the mechanism for resistance to the TKI and also the chemotherapy per se. Here the VEGF is independently acting, and VEGF is going to give a good role here. On top of it, immunotherapy are supposed to not act that great if you have a PIK3C alteration.
That's true.
So combining all the things and taking benefit small bit, you may get some good answers. So ABCP seems to be a better approach, especially in this context.
Excellent, excellent. I will move on. This patient had a partial response and managed PFS of 9 months, which I think was quite good for this group. And with that, I thank you. The fantastic panel, very vocal, very useful. Thank you.
So thank you very much, Dr. Nitesh. And yeah,
I have one more after this.
After this?
Yeah.
Okay, so.
So the perioperative was erroneously written. That's already been covered, and I have the, okay, but we are changing the chairpersons. I don't know. Is Dr. Anurag Mehta there? He's not.
Anurag Mehta?
Dr. Istavan? He's also not there. Can I request Dr. Bowman and Amit to remain as the chairs for this session also?
Please continue.
Okay. Coffee? Okay. So we are almost right on time. Can I have the next one and request people to go and get the coffee in the room? No, this is missing. Should I use my slide? Yeah. Got it. I think this is very interesting. It's not showing yet, but I'll blank it out. But this is, should we wait for others to come in or should I start? Okay, I'll start. So I think this is very interesting because I think this exon, this EGFR 20 insertion story is getting to haunt me, predominantly because of how poor these patients usually do. So generally speaking, lung cancers we know have poor prognosis, and precision medicine is really changing because in targeted patients, and this is the conundrum of the whole thing, in targeted patients, onco-addiction is well known, which basically means is there is so much addiction to the driver that if you don't treat the driver, then patients don't get better, they only get worse. And if you don't have a treatment for the driver, you're stuck. So you have an onco-addiction, you need to treat the driver, but you can't treat the driver because of the addiction. And that's why the story of exon 20 insertion is extremely important, because it is, as a signal pathway, increasing homeostasis, decreasing homeostasis, and is pro-tumor signaling, which making the cancer get worse in terms of survival and in terms of inflammatory cascade and so on, and growth and migration. Now, we know exon EGFR 20 is possibly around 40-45% our part of the world, and in exon 20 makes about 9% in this data set of 28%, and we have some Indian data I will just show. But important is the insertion is within the tyrosine kinase domain, and most of our EGFR TKIs therefore do not work because it's in the tyrosine kinase, within the tyrosine kinase domain. It's a transmembrane. The 20 insertion mutation biology is important, as I said, because most EGFR TKIs do not work here, except, and please do not forget, the 763 and 764, 763, 760. Why? Because they are sensitive to our standard EGFR TKI, but not the rest, because they reduce TKI binding because of the configuration that exon 20 insertion causes. Oncogenic addiction without treatment, as I said, is a problem. We've seen about 2 to 5% patients. This is the same kind of number we see with ROS, which we're very happy to treat. And platinum-based chemotherapy really doesn't do very well here. Only 6.6% average PFS with a 17 months OS. And when you even add immunotherapy, it adds extremely little to this group. So onco addiction, we don't have a treatment, chemo doesn't work, immuno doesn't add. So we are stuck because the median PFS of these patients is only 5 to 7 months. Now, let me quickly show how poor prognostic these patients are. You see the curves of the red are completely down as compared to the common EGFR mutation on a year-to-year basis, starting right from beginning. So your patients will not do well even as you initially treat them. And the real-world PFS is even worse. And the molecular testing is difficult because your standard RT-PCR does not pick up these testing. The NGS can, but your NGS has to be good panel. It has to be a hotspot which is capable of picking it up, because if it's not designed in the hotspot, you will miss it. And a lot of commercial PCR kits do not pick up exon 20 mutation. And that's why a lot of expert guidelines do talk about comprehensive genomic profiling using NGS with a good validation, because you do not want to miss something and then treat incorrectly, thinking the prognosis is going to be good while it may not be. This is Indian data from Sahu to to Vanita Noora to Navneet Singh, all of which have said that the range varies somewhere between 4 to 8%. My guess is between 5 to 6% would be a good estimate to have. So we do know our population has EGFR 20 insertion in around 5% patient, not a small number, and not to be forgotten, ignored, to be tested properly. Vanita's paper, for example, does say that they have dismal OS of only 5 months, and therefore this patient group does clearly need a better treatment, which is amivantamab in this case. What is amivantamab? Very interesting molecule. I think we'll see a lot more of it because we will be using this more and more in post-EGFR TKI progression, which data has just come out. But really, it's a bispecific antibody against EGFR and MET, and therefore works well with exon 20 insertions as well. It has a direct effect of inhibition of ligand binding, but also has a receptor degradation as well as immune cell directed activity. But extremely important, and for everybody who's sitting and listening here, don't forget this has a very interesting schedule and a lot of infusion reaction, so it should only be done in a hospital setup in careful supervision with anti-allergics. The week 1 dose is split. You do it today and tomorrow, which is day 1, day 2. The week 2 and 3 and 4 and 5 and 6 go as it is, and then you actually go on to 2 weekly scheduling for rest of the patient while till progression. The whole data from amivantamab came out of Chrysalis study where the patient who had the recommended phase 2 dose were then gone on to cohort D. And finally, you got 2 doses, one for patients under 80 kilos, which is predominantly our patient group, and one over 80, which was 1,050 and 1,400. And as I said, there's a schedule there to be followed. And it was generally effective. We'll come to that. It was generally well tolerated in the majority of population. who had platinum chemotherapy in every one of them, immunotherapy in half of them, and EGFR TKI in 25% of them. The toxicity put together was 98%, but grade 3 was only 16%, and there was no AEs leading to death. So well tolerated drug, but has to be given in a certain way, and you have to manage its allergic reactions well. The safety summary, treatment-related grade 3, as I said, was seen about 16%. I think I've already covered that. And the previous immunotherapy also I have discussed, when given, made matters worse, basically because these patients had 2 lines and therefore obviously they were worse. We know they don't respond to any of these. This was very interesting. This is the real world kind of delayed data, and we are seeing 47% patients remained on the at the data cutoff. 63% had response more than 6 months, and the median OS was 22 months. And remember, we were discussing this is about 12 to 14, up to 17 months for patients. So there is clearly some kind of cross-trial comparison gain. Good responses in the majority of patients. I think this is the wrong slide. Can I have just 1 second? This is previous. I'm just going to escape this. Important to huh? So I think because you're taking all the precautions, obviously. Huh? So because you're taking all the precautions, you're not seeing it, because I'm sure you're giving them anti-allergic and you're splitting the dose into first 2 days dose is split.
First time you're all very excited, and I was really worried. Should I put the patient in ICU?
No, yeah, I see what you're saying. No, this is not. Why is this coming back? So, okay, I think there's some confusion. I possibly haven't overridden, my fault. So there's a Pavilion study which basically is comparing the second line, first line chemo with amivantamab, and the curves are fantastic. You're clearly seeing a big separation right from day one, very effective. So the way I'm looking at is in conclusion that this is a drug which should be used first line with chemotherapy, amivantamab. I don't know if they have approval yet or not. And then second line, after failure of chemotherapy, if a patient already had. I don't think I would be wanting to use immunotherapy for this group in the first place. Pardon me? I agree, and we were in that era in between where we were saying use afatinib, use this. I don't think any of that works. So I think chemotherapy, amivantamab, that's possible. Yeah. So, agreed. Any other comments from people at large in the audience? Any questions, any comments? Amit, can you answer that? Amit is asking, why is it difficult to find exon 20 insertions in the regular testing method? You know, I have, obviously PCR is a difficult question, but I have an NGS report of a patient on 2 different testing, and one of them says EGFR mutation, and it doesn't mention where. And of course, if it doesn't mention where, I will test in another lab, and it was 20. So you can imagine, and this person got it done. He was in, I think, somewhere in Punjab. And you can imagine that this would have really jeopardized the care in that center.
So the technology which was used earlier was ARMS PCR, and now with the NGS technology, there is no more a challenge. It's very straight away clear.
So when you put a hotspot NGS, if you're not looking for 20, you'll still pick it up?
So hotspot includes 20 these days. So
all hotspots?
Yeah. So there is now a norm. It does pick up actually.
Okay.
But the question I wanted to ask you, very basic question. The the alteration is sitting in the kinase domain. And we're using a map which is the extracellular domain antibody activity. So what is the scientific basis to the whole response what you're talking about?
So to whatever extent I could understand is that it resets the configuration of the EGFR molecule and renders it unable to use its regular cytokine pathway for growth. So it's I'm not saying it's equivalent of fulvestrant for an ER receptor because not degrading it directly, but to some level the three mechanisms it is clearly doing is it is binding on it quite strongly. By binding on it, it is not inhibiting like osimertinib would do with EGFR, but it is causing a degradation and it is causing a effect on the bystander effect. And my guess is that is the main mechanism.
Can we, because this drug is quite costly, can we extrapolate this information with cetuximab?
So, truthfully, I wouldn't know the answer to that. I think you'll be better equipped to saying that. But to my best understanding, cetuximab in lung cancer would only work when there is a very significant EGFR amplification rather than this mutation. And there also, the studies were all over the place. You know, there was early phase studies done for cetuximab in lung cancer with EGFR amplification on IHC alone. Yes, that too, and they were all over the place.
And is there any role of amivantamab outside exon 20 insertion, let us say other alterations?
So this is exactly what we are saying, that its bigger use will come. This bigger use will come when we start seeing osimertinib failure with amivantamab with chemotherapy in second line, which is recently. Yeah.
There is one more. You can correct me, exon 20 with HER2, where amivantamab may not be useful so much. So in that we have to use HER2-directed therapies.
Absolutely. Thank you very much for your lovely audience. Thank you.
Thank you, Nitish. We're done for the session, and it's a tea break now. Or we have another session. So, yeah. Sorry, I think. So now, you can take it over now, please.
May we have Dr. Sai Vivek for lorlatinib in the management of ALK-rearranged non-small cell lung carcinoma.
Yeah, good evening, everyone. So today we'll be discussing a little bit about lorlatinib, but when we come to lung cancer, I think ALK inhibitors are the biggest success story of lung cancer. At this point, if we do have to treat a metastatic CA lung, I think it has come to a time where all of us are wishing that the patient picks up an ALK mutation. And what we are going to see in the CROWN trial, I think it's astounding, and the hazard ratios are just unbelievable. So quickly, this will be the overview, and I won't take much time. So all of us know lung cancer is the leading cause of cancer-related death in 2020, and it is the cause of cancer in 1 amongst 10 patients and 1 amongst 5 cancer-related deaths. And coming to India, lung cancer is the 4th most common cancer detected in India. And what is more alarming, if we just have to pick up one thing from this slide, this is 2020 and this is 2040 on the middle and the right sides. So 2040, we are almost looking at doubling of the number of cases in lung cancer. So there comes a need for all of us to know everything about lung cancer. So in 2020 Globocon data, they found that it is almost 7.8% of all cancer-related deaths in India, and it is the 3rd or 4th most common cancer amongst both the sexes in India. So lung cancer, I think, has seen a drastic change in terms of precision medicine and molecular oncology. It's like the poster boy. We started off with non-small cell, small cell, then we went to adenosquamous, then we went to the common mutations of EGFR, ALK, CROSS, and now I think there are almost 12 to 13 targetable mutations which all of us test for in the upfront setting. So today, ALK forms around 5%, though it says 1.6 to 11.7%. Realistically, I think all of us would agree that it is around 5% amongst all the NSCLC adenocarcinomas. So typically, patients with an ALK mutations have these characteristic findings of being non-smokers, obviously adenocarcinoma histology, younger patients, predominantly female patients, and EMR, ALK fusion, and EGFR mutations are mutually exclusive. So that is one thing we have to know about. So it is an inversion mutation. So basically what happens, there is a chromosome which is cut at 2 points, and that cut, the resultant of that cut at 2 ends just inverts itself and fuses to the chromosome. So hence, it is an inversion mutation happening in chromosome 2 of our DNA. And a small number of NSCLC patients do get this to the tune of around 5%. And here, as we see, depending on the break point there, we can have different variants of our EML4 ALK. And the best way to test it nowadays is NGS, but if you actually want me to talk about the CROWN trial, they used IHC. IHC was what was used in the CROWN trial to test for the ALK fusions. So that it requires a companion diagnostic that has to be approved, the ALK IHC by the Ventana. I think the platform is Ventana, but that is what they have used. So ALK positivity, again, just to reiterate, 5%. But the most important thing to remember in ALK positive metastatic lung cancer is CNS metastasis. So at this point, the guidelines clearly say at the diagnosis of adenocarcinoma itself, even in earlier stages, do an MRI to rule out the sitting CNS metastasis, but in a metastatic setting, it becomes imperative because 30 to 40% of them either have present with brain metastasis or while on treatment tend to progress in the CNS. So, and the penetration of the first generation and second generation ALK inhibitors in the brain is quite less compared to the third generation one that we'll be talking about now. So this is it. This is the summary of almost 30 to 40% of them having cumulative incidence of brain metastasis once they have ALK positivity, even while compared to ROS, or even if you are comparing it to, I think, yeah, so even if you're comparing it to ROS or if you're comparing it to the other mutations, we see that the ALK scores #1 in terms of incidence of brain metastasis. So this is where we stood. ALK positivity, patients come with brain metastasis or progress to have brain metastasis. At the time of initiation of the CROWN trial, which was almost 2017, we had crizotinib, we had ceritinib, and the median PFS was around 9 to 11 months, overall survival going up to 24, 26 months, and people with brain metastasis much lower than that. So that was where we started in 2017 and 18. So that caused us to have 2-3 questions in our head. So we need a better agent with better efficacy, better overall survival, with significant CNS activity, not just CNS activity, with significant CNS activity. And of course, response rates are what our patients come to us for. So we need to alleviate their pain and suffering, so good response rates. So that brings us to lorlatinib. So lorlatinib is a selective ATP competitive, highly potent third generation ALK TKI. So which has excellent brain penetration, almost up to 75%, to address the present brain metastasis or to prevent development of brain metastasis. So improved clinical outcomes with overall and intracranial activity in patients with previously untreated ALK positive NSCLC. So the upfront treatment can completely suppress or at least significantly delay on-target resistance, leading to more durable clinical benefit. So this is a comparison of lorlatinib versus the previously existing crizotinib, and what we see here is because of the structure, it has effective CNS penetration and retention in the CNS, and it binds with high affinity to almost all ALK-resistant mutations. So when a particular TKI is given, the cell has an escape by developing another mutation which forms the resistant mutation. But here, lorlatinib has action against almost all known resistant mutations of ALK. So the phase 3 trial was the CROWN trial, which was initially published in 2020 and then updated in 2022. So the key eligibility here was stage 4 NSCLC, no prior systemic treatment, ALK positive, of course. And one thing to note, very few trials in medical oncology take asymptomatic treated or untreated. Untreated is the word. So very few drugs accept patients with untreated CNS metastasis. So if somebody is doing a trials, they should be really confident with their phase 1, phase 2 or preclinical data that it has significant activity in the CNS. And of course, more than one extracranial measurable targetable lesion. So here patients were randomized in a 1:1 fashion. So 149 in each group. Lorlatinib was 100 mg OD versus crizotinib, which was a standard of care at that point at 250 milligrams twice a day. The primary endpoint was PFS. And if you see the distribution of patients in the two arms, what we see here is they're well distributed. Almost 45% of them were of the Asian background, and most of them were in stage 4, 95% adenocarcinoma, and 30% of them had brain metastasis at baseline. 1 in 3 had brain metastasis. And then we are going to look at the results with this information in mind. So this is a 18 months follow-up data, and then the 36 months. What we see here is an amazing separation of curves and early separation of curves. Almost at 2 months to 3 months duration, we see a brilliant separation of curves. And at 18 months, the median PFS was not reached with a hazard ratio of 0.28. I think, probably list the number of trials with a hazard ratio of 0.28. And at 36 months, still the PFS, median PFS is not reached, and the hazard ratio has actually come down to 0.27. No, not very significant, but still, it is still less than 0.3, but that is something which is amazing. So this is some data which we hardly get to see in medical oncology. So in the forest plot, in the subgroup analysis, what we see here is literally all the subgroups benefited. There is not one subgroup which really didn't benefit from lorlatinib. Now coming to the unmet need of those 30 to 40% patients who had CNS metastasis or who usually develop CNS metastasis, if you see on the left-hand side, patients with baseline brain metastasis, the response rates and the PFS are almost quite different from what we see in crizotinib. So with brain metastasis, still the median PFS has not been reached as per 2022-23 with a hazard ratio of 0.21. It gets better because crizotinib didn't perform that well. So, and without brain metastasis, again, it is staying at 0.29. So that is 70% less risk for progression even with brain metastasis, or 80% rather, even with brain metastasis. That is quite commendable. So time to intracranial progression. So this is one thing, again, I have never seen. If you see the lorlatinib arm, it is almost a straight line. So if the patient is on lorlatinib in the first line setting, hardly less than 10% have a progression in the CNS. And what is this number ideally supposed to be? Somewhere around 20 to 30%, going by history. So again, this is the blinded independent committee review. The data holds good, and almost 99% do not have a progression, so 1%. So that is something which is quite well appreciated by this population. So coming to the comparison, though cross-trial comparison cannot be done, this is just for us to discuss. So CROWN, ALTA, and ALEX, intracranial time to progression, what we clearly see in patients with brain metastasis or without brain metastasis, lorlatinib significantly scores over the others, including brigatinib. So the summary of overall intracranial response, again, there is no doubt it has a great penetration, hence a great response. So the subgroup analysis, so the plasma and tumor genomic analysis, this is something which is going to be, I think, we are going to look into more and more as we go along. The ctDNA or the CTCs, especially the cell-free DNA, the clearance of cell-free DNA has been demonstrated without doubt to have a good prognostic significance in patients with targetable mutations. So how fast that mutation is being cleared from the peripheral blood definitely has a PFS advantage if it's cleared fast. So what they really found in this subgroup analysis, whatever the variant of EML4 and ALK fusion was, whether it was variant 1, 2, or 3, lorlatinib scored over crizotinib significantly. So the variant 1 versus variant 3 is what they showed here. So this was lorlatinib, alectinib, and brigatinib. What we see here is lorlatinib still scores over whatever the variant of EML4 ALK fusion is. So this is in the Asian subgroup. Again, the hazard ratio is 0.4 compared to the 0.28 with intention to treat population. Even the good 45% of Asian population did benefit from lorlatinib compared to crizotinib. And even the patients without intracranial progression, again, in the Asian subgroup is almost above 95, again, holding good for patients of Asian background. So the best way when we can't compare cross-trial is a network meta-analysis which compares all the available drugs, and the network analysis, meta-analysis here clearly shows the superiority of lorlatinib compared to the others in the group like brigatinib, ceritinib, crizotinib. So the comparison of all the three, lorlatinib, alectinib, and brigatinib, here we see that in terms of PFS, the results indicated that lorlatinib was the best treatment choice for patients with ALK inhibitor naive or untreated ALK positive advanced NSCLC. So head-to-head trials, I don't think they're going to come. This is the best, and we have to take our summary from this. So again, a network meta-analysis clearly shows that lorlatinib is superior in terms of PFS. So this was the conclusion of the network meta-analysis. As we just said, better PFS compared to the other ones. So what are the general resistance patterns after ALK TKIs? So if you see here, when we are using the first generation drug like crizotinib, you can have multiple resistant mutations developing over a year. So whether you use first generation or second generation, there are resistant mutations. And if you see in this one table, lorlatinib really covers all the common resistant mutations, especially the G1202R, which is the most common resistant mutation seen in patients with ALK mutations. So what is the rationale for upfront use? Again, we have a very interesting paper here. Lorlatinib suppresses the emergence of single ALK-resistant mutations, and upfront lorlatinib could significantly delay or suppress the on-target resistance. Next, moving on to the why this is very important to give the patient lorlatinib advantage in the first-line setting. We have evidence from the phase 2 data of lorlatinib, where we had around 28 patients treated with one second-generation ALK TKI with or without chemotherapy. That cohort of around 28 patients and 32 patients were treated with crizotinib, and only 30 patients in the phase 2 out of 228 were treatment naive. So what we see here is patients who were treated with another ALK inhibitor prior to going on lorlatinib definitely had an inferior PFS compared to upfront lorlatinib, probably because of emergence of newer and newer resistant mutations. That brings us to the summary that, if available, lorlatinib in the first-line setting could suppress the occurrence of resistant mutations and give us the longest PFS. So the most important thing with any TKI, which again I'm telling you that people will be taking this for 2 to 3 years or more, is the long-term safety. So coming to the long-term safety data of lorlatinib, the most common side effects which all of us see in clinical practice are hypercholesterolemia, hypertriglyceridemia, edema, weight gain, and neurocognitive side effects. So neurocognitive, I haven't seen amongst the 4 or 5 patients that I have treated, but definitely we have to watch out for hypertriglyceridemia and hypercholesterolemia. Patients do come back quickly if they have weight gain. Initially, they'll be happy that cancer, weight gain, but very soon, especially female patients, will come back and say, I am gaining weight quite rapidly. So those are the common side effects that we see in clinical practice, and that is what they saw in the clinical trial too. And how do you manage the hypertriglyceridemia? This is the guideline. So whenever the cholesterol is more than upper limit of normal to 300 or triglyceride 150 to 300, that is when we use the lipid-lowering therapy. One thing to note here, the drug which is recommended here in India, what is easily available is our rosuvastatin. So Others that can be used are the pitavastatin or the pravastatin. So atorvastatin, which our mind goes to generally when we are talking about statins, should not be used when we are talking about lorlatinib-induced hypercholesterolemia or hypertriglyceridemia. The reason being they have more interaction with CYP450 enzymes and might affect the activity of lorlatinib. So the only time you stop lorlatinib or reduce lorlatinib, if at all, it is a life-threatening cholesterol of more than 500 or triglycerides of more than 1,000, and then you step down to one dose lesser, which is 75 milligrams per day. So CNS side effects, they can occur in any way. It can be cognitive, function, mood, or speech, generally mild. And Indians somehow, I don't think, come back and report them, or they're not sensitive enough to come back to the clinic and report them, but it is our duty to sensitize the patient about the occurrence of this. And very few patients, though they had, needed a dose reduction in the Crown study. So in the adverse events, there were no grade 4 CNS side effects. Most of them were mild and tolerable. And this is the CNS effects. How do you manage them? So even if there is a mild, you have to hold the dose. For hypertriglyceridemia and hypercholesterolemia, only when it is severe, you hold the dose. Here, even if they report any mild neurocognitive side effect, you got to hold the dose until the symptoms resolve and then start at a lower dose of 75. So grade 2 or grade 3, withhold until it reaches grade 1 and re-challenged at one reduced dose level. But life-threatening and if at all an urgent intervention like hospitalization or ICU admission was needed, it becomes grade 4, and that's when you permanently discontinue lorlatinib. So the key takeaways, it has a significantly longer PFS, higher overall and intracranial response rates, and the matched global quality of life compared to what we knew with crizotinib. And the safety profile, if well understood and well treated, is definitely manageable. Although grade 3, grade 4 were more frequent with lorlatinib and crizotinib, majority were asymptomatic and could be managed easily. So this is reflected in the guidelines. Lorlatinib has now become a category 1 recommendation by the NCCN. So this is a very important slide where we are seeing how do we get the best PFS in a patient with ALK mutation. Do you sequence crizotinib, ceritinib, and then go to lorlatinib, wait for the mutations to occur? But mind you, what we know in most metastatic cancers, there's a dropout rate. If 100% start at stage 4, by the time we come to second line, all of us are going to see only 60%, at the max 70%. 30% is already gone. And second line to third line, that will be another 50% drop. Only 30% will remain with us in third line. And especially in a country like India, after every progression, I'm sure a patient will go to a new doctor. So keeping this in mind, giving them the best TKI in the upfront setting is something, especially in our country, plays a huge role. So if we see what is the data that is available and how do you sequence it, again, we see that starting with lorlatinib, where the median PFS has not been reached yet, seems to be a smart option at this point. Thank you.
Any question, please?
Thank you.
Thank you very much.
Thank you, sir. The next speaker is Dr. Kunal Joban on the evolving landscape of locally advanced and metastatic urothelial carcinoma.
Good evening, and thank you for this opportunity. So I will be discussing today on mainly the evolving landscape of the metastatic and urothelial carcinomas, which has changed recently, particularly focusing on the use of enfortumab and pembrolizumab combination. So, as we know, the incidence of urothelial cancers, the urothelial cancers world over. So we know that the prevalence of urothelial cancers is more in the Northern Americas and the European countries, while in India it's marginally lesser. And if we see in the Asian countries, then the countries which rank higher in the incidence of urothelial carcinomas are the China, Taiwan, and the Southeast Asian, while India ranks lower, but then the mortality is compared to the incidence, the mortality is much higher. So what about the exact incidence? So incidence is around 1.6% of all the cancers, and it's 17th most cancer according to incidence wise and 19th according to the mortality wise. And the urothelial cancers, the trend reported from the tertiary care centers, the referral centers in India, that the trend is towards the upward trend. So what are the unmet needs of urothelial cancers? First of all, if we see early muscle invasive urothelial cancers, we see that even after appropriate perioperative therapy constituting of neoadjuvant chemotherapy followed by surgery or surgery followed by adjuvant, there is a sizable proportion of patients who do recur. And we have the data of adjuvant nivolumab, which is still awaiting the final results, and also the ambassador trial, which turned negative, which was reported 2 days back. So there is an unmet need in the early muscle invasive bladder cancers, urothelial cancers. Also in the metastatic stage, there are hardly patients who survive beyond 5 years. And also the proportion of patients taking subsequent therapy is also lesser by progression on subsequent progressions. So this was the abstract which I had presented at the NZOP meeting, and which showed that out of 186 muscle invasive bladder cancer patients, after appropriate latest perioperative therapy constituting neoadjuvant or adjuvant before or after surgery, there are 64 patients which recurred, and out of that, half of the patients we could not offer salvage systemic therapy, mainly because of poor performance status. And the patients receiving subsequent third or fourth line therapy are almost negligible. So how has the systemic treatment of urothelial cancers changed over the last few decades? Previously, we used to have only the conventional chemotherapeutic agents, and then after a long gap of 3 to 4 decades, we had immunotherapy and then targeted therapy, mainly the FGFR and the antibody drug conjugates. So as I mentioned, only 5% of patients survive in the metastatic stage or the locally advanced unresectable urothelial cancers beyond 5 years. And how do we decide currently? So current treatment paradigm, as what we do so far, is the Javelin bladder approach, Javelin B100 trial, and primarily we assess for platinum eligibility in first line metastatic urothelial cancers. So platinum eligibility patients could be subgrouped further into cisplatin or carboplatin eligible, while platinum ineligible in general are patients having create clearance of less than 30 or ECOG performance more than 2. Also, one needs to remember that ECOG PS2 and GFR of between 30 to 60 were defined as platinum ineligible, and rest of the definition we already know. So in the first line platinum based chemotherapy, we have got two options. It could be cisplatin based or the carboplatin based options. We see some marginal difference in the cisplatin versus carboplatin in the first line metastatic urothelial cancers. We see that the response rate, the PFS and the overall survival were better when we use cisplatin in the fitter patients compared to the carboplatin. Yeah, so the Javelin bladder 100 trial selected the patients who had good response. So there were biological selections, and patients who didn't have progressive disease, they received subsequent maintenance avelumab. And these patients, the benefit of avelumab was seen irrespective of the platinum agent used and irrespective of the number of cycles administered, or also irrespective of the response which was seen in the response evaluation after the 4 to 6 cycles of platinum based chemotherapy. So newer antibody drug conjugates are being evaluated in the breast, in the bladder, and we know that the recent antibody drug conjugates is the enfortumab vedotin and the sacituzumab, which have been evaluated in the bladder cancers. So these are the NCCN updated guidelines, which mentions that the preferred first line therapy so far in the NCCN guidelines has been the platinum based chemotherapy followed by avelumab maintenance, be it GemCis, be it GemCarbo, or be it DD-MVAC. From the extrapolation of the data. While in ineligible patients, they have mentioned pembrolizumab and enfortumab based on EV-103 trial, and also subsequently gemcitabine and paclitaxel or immunotherapy agents. So how is the data evolved over the years? So around 2 to 3 decades of long gap of any further improvements in the survival. After that, we had use of immunotherapy, but immunotherapy has been very intriguing in bladder cancers. There are few trials which have turned negative, there are few trials which are positive, like the Checkmate 901 and the EV302. So why is such discrepancy, and what needs to be understood? So when we had the Javelin data, after the Javelin data and the EV302 data, now we are touching the overall survival up to 31 months. So these are the various immunotherapy with chemotherapy combinations which have been studied in the first line management of bladder cancers, and we all know that the use of pembrolizumab and the atezolizumab was didn't show significant overall survival benefit, while the checkpoint 901 and the EV302 showed significant benefit. Let's see how it turned out to be. So as we know, Javelin B100 trial, 700 patients were included. Patients whether platinum, cisplatin or carboplatin eligible, and the PFS was 5.7 months versus 3.7 months in the PDL1 high population, and there were complete response of only 6%, and the median duration of treatment was around 24 weeks, that was around 6 months. Rest of the trials which studied the atezolizumab, be it IM Viger 130 or Keynote 361, were not statistically significant. So this is the schema of the Javelin B100 trial, which used avelumab maintenance at 10 milligram per kg versus placebo. And the median overall survival which was reported was 23.8 months versus 15 months. With a hazard ratio of 0.76 and PFS of 5.5 versus 2.1 months. Adverse events, I think everyone agrees that the avelumab maintenance is fairly tolerable. This is another upcoming study which used erdafitinib with new immunotherapy saprolizumab, and again the data is promising. However, I will jump to this study, which was a simulated disease modeling study, because we know that the percent of patients who receive avelumab maintenance in real world settings is very less. So this study tried to evaluate what proportion of patients are actually feasible for avelumab, and then it compared the patients who were included in the Javelin B100 trial. So after the simulation modeling, the median OS was calculated to be around 15.9 months. Now let's have a look at the EV302 study, which has almost changed the way how we are managing metastatic urothelial cancers worldwide, at least not in India. So this patient had a very wide inclusion criteria, including all comers, previously untreated, treatment naive, metastatic urothelial cancers or unresectable locally advanced urothelial cancers with eligible for platinum. So EGFR was kept as about 30 and ECOG performance status of less than or equal to 2. And they were naive for any treatment, naive for immunotherapy, and they were randomized into 2 arms, combination of enfortumab vedotin with pembrolizumab. Here the enfortumab dose was 1.25 milligram per kg day 1 and day 8 every 21 days with pembrolizumab for maximum of 35 cycles, or randomized on the other arm, which was platinum based chemotherapy for maximum of 6 cycles. And there were dual primary endpoints of EFS and OS. So what was the rationale of this combination? So combination of enfortumab vedotin with PDA1 inhibition improves the anti-tumor activity, as shown by the increase in the macrophage recruitment. And the enfortumab vedotin consists a cytotoxic payload, which is known as monomethyl orostatin E. So the exposure of the tumor cells to this payload subsequently increases or upregulates the co-stimulatory molecules which are required for immunomodulation, and the combination proves out to be synergistic. Not even preclinically, we can see in the clinical data also. So if you see the overall response rate, it is 67.7% versus 44.4%, and 38.7% had partial response, and whooping 29.1% had complete response. Now, if we see the overall survival, never seen before, it is crossing 30 months, 31.5 months versus 16.1 months, and this is after a median survival follow-up of median follow-up of 17.2 months. According to the subgroup, again, this subgroup data was presented 2 days back at the ASCO GU, and it showed that the combination of enfortumab with pembrolizumab improved overall survival irrespective of the subgroups, be it platinum eligibility, be it cisplatin or carboplatin, be it PDL1 high or low, or irrespective of the sites of metastasis. Even in the patients having liver metastasis, the predefined subgroup population had a significant benefit with the combination compared to the chemotherapy arm. So according to cisplatin eligibility, the combination arm showed median OS of 31 months versus 18 months, while in cisplatin ineligible patients, the median OS was not reached, and in the chemotherapy arm it was 12.7 months, with a hazard ratio which was around 0.4 to 0.5. This was another trial which has again kind of created a new standard of care potentially. That is a Checkmate 901 trial, but here the patients which were included were only cisplatin eligible. And the key inclusion criteria were treatment-naive population, cisplatin eligibility, and ECOG PS of 0 to 1, which allows administration of cisplatin. And the stratification factor was PD1 more than or less than 1%, and liver metastasis. And here GemCis in addition to nivolumab followed by nivolumab maintenance was used in the place, and the other arm was standard GemCis arm. Then the endpoint again here was OS and PFS. And basically it had two cohorts, but the first cohort didn't show a significant benefit. That was the combination of Nivo plus EP. And the second cohort which was there, this was a negative study of combination of Nivo plus EP. It clearly says that platinums are inevitable when we are using immunotherapy alone. And the OS results in cisplatin eligible population was 21.7 months versus 18.9 months with a significant p-value and hazard ratio of 0.78. Again, creating a confusion in our minds which one to be used, whether it is Javelin B100 approach or the Checkmate 901 or EV302. And here, compared to the EV302, which showed marked significant benefit across all the subgroups, Checkmate 901 showed particular benefit in patients who were treatment naive previously and not received any chemotherapy past, or PDL1 which was higher, more than 1%. And if you see the response rates, it was 57.6%. And compared to 43.1% in the chemotherapy arm. And interestingly, 22% of patients had complete response, and patients who received who had complete response, the median OS reached up to 3 years, 37 months. So we need to define what's we need to have biomarkers and need to define the beneficial population who could have this complete response and can reach to a median OS of 37 months. Yes, and treatment-related adverse events, nothing surprising, same which we experience in platinum-based chemotherapy and the immunotherapy. Now, subsequent therapy, again interesting part. So, if we see the EV302 study in the EV plus Pembro arm, around 24.9% of patients received platinum-based chemotherapy on progression, and if you see the chemotherapy arm, 58.6% received immunotherapy subsequently. Out of this, 32% of patients received maintenance avelumab as a part of the control arm, and rest of the patients, 22% of patients received immunotherapy on progression. So very interesting, because this we will compare with the Checkmate 901. So here, Checkmate 901, 20% of patients received immunotherapy before progression, that is in maintenance, and 40% received overall. And if you see the EV302 trial, the control arm, 32% of patients received maintenance immunotherapy before progression, and 59% of patients received any subsequent immunotherapy. So better, though we see that only 32% of patients received maintenance immunotherapy, but even we see in the real world, the chance of giving avelumab maintenance is the real world is much less, I think, for around 40%, 30 to 40%. So that is consistent. And if we see the response rates across all the trials, we see that EV302 scores remarkably well compared to all the other trials, followed by Checkmate 901. Now, most important part is the treatment-related adverse events. So why, what are the potential treatment-related adverse events, and how are they different from the conventional chemotherapy? So as we know, the antibody-drug conjugates present with a unique range of side effects, and for EV302, there are 4 to 5 side effects which need to be kept in mind, and need to have some experience in managing those. So what are these? So the major side effects which were of concern were the neuropathy, primarily peripheral sensory neuropathy, skin rash, diabetes, and ocular side effects, and some incidence of lung toxicities. Again, important part is the median number of cycles administered. Though 35 number of cycles were allowed, but the median number of cycles which were there administered in the trial were 12 cycles for the combination of EV plus Pembro. So grade 3 adverse events were 56% in the EV plus Pembro compared to 70% in the chemo. So though the incidence of side effects of grade 3 side effects are much lesser, but then they present with a unique set of side effects, which I mentioned. So there are again interesting questions that what we should do if patient, for how long should we continue EV What are the financial and the toxicity implications? Can we stop EV can we stop EV at 6 months or when the patient has reached complete response? And any de-escalation strategies. So this needs to be studied subsequently. And if you see the first side effect, which is the skin reaction, so the most common type of skin reaction is the maculopapular rash, which was present in around 11% of grade 3, 11% of patients having grade 3 or more maculopapular rash, and around 1/3 of patients having maculopapular rash in general. So 2/3 of patients had skin reactions, and out of which 1 out of 5 had severe grade 3 reactions. So how do we manage it? Yeah. So I'll have a slide of the management of the skin reactions, in which we use topical steroids or oral steroids depending on the grade and severity of the side effect. So these are the specific warnings and precautions which I mentioned: uncontrolled diabetes, neuropathy, ocular disorders, emphysema, skin disorders. So what is the range? So if 65 patients had skin reactions, out of which 89% of patients had resolution and 3% had improvement to grade 1. And skin reactions usually present in the early part of the administration, that is within the first cycle. And but the interesting part is the neuropathy. Neuropathy, 43 patients had neuropathy in the study, out of which only 23% of patients had resolution, while 46% of patients had improvement to grade 1. And this neuropathy usually starts at around 2 to 3 months. Yeah. So what is the cause of such unique set of side effects? That is because of, as we know, that enfortumab vedotin, that is targeting the nectin-4. So nectin-4 is expressed also in the skin, also in the eyes, and the skin reactions, majority which we saw, as I described, was the mild to moderate reactions, and onset is typically in the first cycle of the treatment, and grade 3 to grade 4 occur in the 12%. With subsequent increase in the severity of the side effects, we also need to keep in mind the severe side effects, which are the Stevens-Johnson's and the toxic epidermal necrolysis. Also, we need to examine the flexural and the intertriginous areas before every cycle, and look for particular changes of the skin, which could be pustules or papules or blistering, or the maculopapular rash. And we should have a dermat consultation and skin biopsy for severe reactions. So yeah, as I mentioned earlier into the earlier part of presentation, that there is a subsequent percentage of patients in bladder cancers who are not eligible for even systemic therapy upfront, primarily because of the poor performance status and the frailty and the age and the comorbidities the patients present. And with subsequent progression, we know that the patient attrition is very high. So for second line, as we know, the current data, we know that FGFR, there is alterations in urothelial carcinoma more in upper tract compared to lower tract, more in low grade versus high grade. And we have data of erdafitinib usage in patients having FGFR3 alterations. Erdafitinib, which was, erdafitinib, which finally we use at a dose of 8 milligram OD until disease progression, and which again, erdafitinib also has got a unique set of side effects, namely hyperphosphatemia because of FGFR inhibition, skin side effects, nail effects, very severe nail changes, and also need to remember that is a central serous retinopathy which is seen in erdafitinib usage. And this is the EV301 study, which used enfortumab vedotin in patients who had progression post-platinum and post-immunotherapy. And here the control arm was the second line chemotherapy, which is the docetaxel, paclitaxel, or vinfluninin. And here the median OS, which was reached of around 12 months compared to 8 months, and median PFS of 5 months was 3.7 months. And the response rates were 41% versus 18.6%. So this we already know before the advent of EV302 study, that based on EV301, enfortumab vedotin was approved for the subsequent line. And again, in this trial also, EV301, the side effects were mostly consistent with what we discussed in the previous study. That was the peripheral neuropathy, rash, and hyperglycemia. This is another antibody drug conjugate, that is the sacituzumab govitecan, which we use in breast cancers. And again, it had a similar control arm. And this is the trophy. I will just jump to the Tropic 04 study, which compared sacituzumab versus the chemotherapy in patients having progression on platinums and immunotherapy, and again here it showed PFS benefit. So before the presentations of Checkmate 901 and EV302, how do we used to manage patients? That was purely platinum-based chemotherapy. If feasible, then the best option was Javelin B100 approach. And in patients who were ineligible for cisplatin, we used to give Carbogem followed by avelumab maintenance or EV Pembro based on EV302 data. EV103 data. And in patients ineligible, platinum ineligible patients, we used to just offer immunotherapy. So if we start using EV302, though it will be much late depending on the cost which would be released. So what could be the best second line therapy? That is a major question here. And again, the second line therapy could be platinum, cisplatin eligible and cisplatin ineligible patients. Again, we need to see what is the performance status at that point, what is the attrition of the patients when they reach, when they have a clinical, when they have a progression of disease post EV plus Pembro. And beyond second line, we have options of FGFR3 inhibition or sacituzumab or chemotherapy. So what are the questions with this data? So again, which I mentioned, what is the best second line therapy post EV302? How do we de-escalate? Is there any option of de-escalation and providing finite number of cycles of EV and then continuing pembrolizumab alone? What is the underlying biology behind the complete responses and good responses of EV302 and the Nivo plus Gemcis? Can we identify complete responders? What is the role of EV plus PEM? Now it will be use of EV plus pembrolizumab in the neoadjuvant setting in the muscle invasive bladder cancers. And what about affordability and accessibility? And how do we choose Javelin B100, EV302, Checkmate 901? So I would think that in patients who are highly fit, affording patients, EV302 is a way to go. In patients who are not that fit, I think Javelin B100 again will be a significant part of our treatment management, at least in India. And for Checkmate 901, we need to identify patients who get that 1 in 5 complete responses and reach 3-year OS. Thank you.
That was really a good presentation, covering so much in so less time.
Thank you.
Any questions? The Checkmate trial had only one problem: to select gemcite cisplatin was so rare in only eligible.
Now we have Dr. S.K. Raghunath on agonists versus LHRH antagonists. Dr. Raghunath. Do we have Dr. Raghunath with us?
I think I'll be filling in for Dr. Raghunath. My name is Dr. Aditya Murli. I'm a medical oncologist at Apollo Hospitals. I know it's the last session of the day. It's been a very long day. Having said that, this is a old drug that we are trying to discuss. However, there is enough number of reasons for us to discuss about this drug to try and tease out how we can differentiate in which setting what drug to use. So the next 15-20 minutes I'll be talking about the unleashing the controversy, LHRH agonists and LHRH antagonists. These are my disclaimers. I've been contacted by AstraZeneca for this meeting. We know that in India prostate cancer is very common. In fact, as per the ICMR, it is the second most common cancer in Indian males. the incidence rate is nearly 9 to 10 per 100,000 population, which is higher than any other part of Asia and Africa. So I think it's very important also to know that when that Globocon 2018 data came out, 1 in 15 people, men over the age of 60, between the age of 60 to 69, did end up having prostate cancer. So when we look at the journey of prostate cancer, there is the high risk, localized, not too many patients present at this particular stage. I would say in common clinical practice, we would have about 30% who come present at this stage. Locally advanced, about another 20%. A vast majority of the patients in India, because there is no frequent screening program in terms of the serum PSA testing, although the benefits of that have not yet been documented, they do present in the metastatic hormone naive setting. And then we all know the castrate resistant setting. So almost up until the high risk localized and the locally advanced setting, it was mostly in the domain of the radiation and the surgical oncology colleagues. Of late, at every step, medical oncology has found its space in this particular malignancy. So LHRH agonists and antagonists prevent the testicles from receiving messages to make androgens. The LHRH agonist is synthetic protein which is similar to LHRH. It binds to the LHRH receptor in the pituitary gland and ensures that testicles are not stimulated to produce androgens. The example of LHRH agonists are leuprolide, goserelin, triptorelin, hysterelin. We have got the first three, leuprolide, goserelin and triptorelin with us. When we talk about the antagonists, they bind to the LHRH receptors in the pituitary gland. Again, the testicles are not stimulated to produce androgens. The example for this is degarelix. Where is the differentiator? So if we look at an antagonist versus agonist, the antagonist does ensure that the patient reaches a castrate level within the first 96 hours of delivery, as compared to 3 to 4 weeks when we use an agonist. In terms of androgen flare reaction, the antagonists do not have an androgen flare reaction, but the agonists do have some androgen flare reactions. PSA failure rates, it can be debatable. The antagonists do have a better PSA failure rate, but that is almost always offset by the local injection reaction, which is fairly high when we talk about LHRH antagonists. So LHRH antagonists are important in patients who need rapid reduction of testosterone. Example, patients with severe symptoms or with impending emergencies like spinal cord compression or severe bone pain or bladder outlet obstruction. And these are the exact 3 indications where we use LHRH antagonists. When we look at the antagonist, the pharmacokinetic profile of goserelin, which is LHRH agonist, so the 3.6 mg is one of the formulations, the 10.8 is another formulation as compared to degarelix. In terms of the plasma protein binding, degarelix has a nearly 90% plasma protein binding, and that does contribute very much to all the data that we saw on the last slide. So no dosage adjustment for mild to moderate hepatic impairment with goserelix, unlike degarelix. Goserelin has clinical data across 3 key prostate cancer settings. So we know that a patient who has had prostate cancer will go through the whole spectrum from the localized state to the locally advanced state to the metastatic state. And if we have a particular molecule which acts in which has got data to show efficacy in each of these 3 settings, nothing like it. So for the next few minutes, let me talk about the various trials. The trials, I will not go too much into the details of these trials, but there was a EORTC 22863 trial which used goserelin in the adjuvant setting. Here the key to note is that the goserelin was used at a dosage of 3.6 milligrams for a duration of 36 months. The primary endpoint for this trial was clinical DFS, which is not almost always the endpoint for prostate cancer trials. So the 10-year prostate cancer mortality and the DFS benefit with goserelin adjuvant therapy was seen when it was combined with radiation alone versus radiation alone. So it is an established fact that in patients who've got high risk localized or locally advanced prostate cancer, there is a DFS benefit of adding goserelin to radiation therapy versus radiation alone. So there was a 40% improvement in 10-year overall survival with goserelin as an adjuvant, followed by radiation versus radiation alone, and the hazard ratio was 0.6, very significant. Then came the DART 0105 GCOR trial. This looked at, a setting of a T1C, T3B localized prostate cancer. So no nodes, no mets, T1C, T3B. This was the endpoint in this was a biochemical DFS. So it was not a clinical DFS. It was looking at a PSA level kind of a DFS. In this, the two arms were short-term androgen deprivation, wherein goserelin was given for 4 months, versus neoadjuvant goserelin for 4 months, radiation and adjuvant goserelin for 24 months, which is, and this trial kind of, led to the current clinical practice that we have. There was a statistically significant improvement in the biochemical DFS with long-term versus short-term goserelin therapy. The 5-year DFS was 90% with the long-term goserelin radiotherapy over here. Even when you look at the 5-year overall survival, there was a 95% 5-year overall survival in the experimental arm versus 86% in the standard of care arm. So goserelin has clinical data across 3 key prostate cancer settings. There is data in the localized prostate cancer setting, there is data in the locally advanced prostate cancer setting, and data in the metastatic prostate cancer setting, and a 46% reduction in the risk of progression over 10 years when added to radiation alone versus RT with a very significant hazard of 0.54. The RTOG 8610 looked at adding goserelin in the neoadjuvant setting. So this looked at neoadjuvant goserelin plus flutamide for 2 months, followed by radiation, and then again goserelin versus radiation alone. Maybe in this, the standard of care arm could have added a goserelin in the adjuvant setting also, but the primary endpoint was loco-regional control for this particular trial. Then there was a TROG 9601 trial. This had a very interesting arm, okay. So this included all our high-risk prostate cancer settings, T2B, T2C, T3, and T4. The 3 arms were 6 months, wherein neoadjuvant goserelin plus flutamide was given for 6 months, starting 5 months before the radiation. There was another arm which used neoadjuvant goserelin and flutamide 3 months, starting 2 months before radiation, and then radiation alone. And if there was a relapse, hormonal therapy was permitted. So in this, if you see, there was an improvement in the disease-specific mortality, and there was an improvement in the prostate cancer-specific mortality. Survival results with neoadjuvant goserelin and flutamide and RT versus RT alone were far better at the 10-year of follow-up. The next trial, again, this was a GETAG AFU trial. This looked at 6 months of goserelin plus radiation versus radiation alone. Here, the primary endpoint was a progression-free survival. This looked at a 46% reduction in the risk of progression or death with adjuvant goserelin post radical prostatectomy. In a forest plot wherein almost all the subgroups are on the side of the experimental arm, shows that there is definite benefit of adding goserelin to radiation therapy. Goserelin has got clinical data across 3 key prostate cancer settings. There is localized prostate cancer, locally advanced prostate cancer, and metastatic prostate cancer. And for us, I think this has got to be one of the big take-home messages, that be it localized prostate cancer, locally advanced prostate cancer, or metastatic prostate cancer, goserelin has got clinical data. Again, more trials, 2 phase 3 trials, which looked at goserelin at a dosage of 3.6 milligrams versus orchidectomy. So basically, this slide is trying to tell whether medical castration was equivalent to surgical castration. We can see that the outcomes over here, be it the mean time to response, the median duration of response, or the median OS, goserelin is as effective as surgical castration in clinical outcomes. Goserelin has clinical data across 3 key prostate cancer settings. Even in the locally advanced prostate cancer setting or the localized prostate cancer setting, the improvement ranges anywhere between 40 to 46% with a fairly long follow-up of nearly 10 years plus. So there is recommendation for ADT across disease states, and it is consistent between NCCN guidelines, EAU guidelines, ESMO or ASCO guidelines at any stage. So if we have a high-risk localized disease, then we would want to recommend adjuvant goserelin for a duration of 2 to 3 years. If it's a locally advanced disease, then I think the prevailing clinical practice is neoadjuvant hormones, followed by adjuvant radiation, and then radiation followed by adjuvant therapy for 2 to 3 years. When we look at the metastatic setting, it is beyond doubt proven that goserelin has got a benefit. overview of LHRH agonists and antagonists in the prostate cancer setting. So if we look at it, there is data for degarelix only in the antagonist, only in the metastatic setting. But if we look at data for goserelin, or for that matter, to be honest, leuprolide, across all three settings of prostate cancer, we have data to say that. I think a more practical or a more important point to make over here is how is the dosing and how is the administration. So this is available both as a 3.6 milligram and a 10.8 milligram implant, which is a depot formulation. This is a single step delivery system and minimal administration time, which are the big advantages as compared to degarelix. In terms of degarelix, it's a monthly depot formulation, unlike the 3 monthly with goserelin that we can use. So with the biggest drawbacks for degarelix are there is a more frequent dose administration. There's a longer time required for the injection reconstitution. If I don't know how many of us in the audience here has actually tried to ever give degarelix. It's incredibly hard to try and push a degarelix injection. I mean, you will end up using thick bore, wide bore needles to try and push a degarelix in. So that does end up leading to not just the inconvenience, but a higher incidence of local site reactions. When we look at head-to-head comparisons in terms of efficacy, not too much of a difference. Maybe the time to reaching castrate levels is faster with degarelix, but apart from that, absolutely no difference. So to interpret, all direct comparison trials were open label, included patients at different stages of prostate cancer and were designed primarily to prove that degarelix is non-inferior to goserelin, and degarelix could not, most of the randomized control trials compared the 1 monthly formulation of both the drugs, and these studies had inherent limitations in study design, conduct, and statistical analysis. So some more data. This is again East Asian data, which we have a change from gonadotropin release in GnRH to GnRH agonist therapy does not affect the oncological outcomes in hormone-sensitive prostate cancer. So shifting patient from degarelix to goserelin was associated with the improved 5-year survival. This was just one data, but tough to draw any conclusions from this. I think let me just skip on to the safety data, and this is a point which I actually do want to make, especially for many of us who want to use it in a day-to-day setting. Injection site reactions is a big problem. In fact, anti-degarelix antibodies have been observed in 10% of patients after treatment for 1 year, and nearly 30% of the patients after 5.5 years. So we know that prostate cancer, at least local or localized advanced prostate cancer, is going to be a chronic disease. So we would not just want to look at immediate side effects, we would also want to see if there are any mid-term side effects and make sure that patients do not have any QOL, quality of life problems in the mid to long term because of injection site reaction. So there is a higher incidence of injection site reaction in this study, which was attributed to a higher maintenance dose and injection volume and more number of injection sites required, which was only 1 site required for 1 month regimen versus 2 sites required for the 3-month regimen. Individual studies, head-to-head comparison studies, and meta-analysis demonstrate a significantly higher incidence of injection site reaction with degarelix as compared to goserelin. There is always a doubt in our mind whether GnRH agonists are safe if a patient has got cardiac comorbidities, which is more often the case in many of our own Indian patients. There are studies which showed no difference in major adverse cardiovascular events at 1 year between patients assigned to degarelix versus leuprolide. This is a phase 3 study. It's some Chinese data, so it has to be taken with a pinch of salt. But even as per this study, the safety findings showed that the incidence of treatment emergent adverse events was higher with degarelix than with goserelin. The most common serious adverse events were cardiac disorders, which occurred in 5 patients in the degarelix group, as to only 2 patients. Number of very small Chinese studies, should not draw too many conclusions from this. The clinical interpretation ultimately is that degarelix definitely achieves a rapid achievement of castrate testosterone levels. This enables that it has to be used in aggressive disease with a lot of disease burden. However, a wider use of degarelix is restricted by the lack of a dose that lasts more than a month and the higher frequency and severity of injection site reactions, which is a very big practical problem. Also, there are reports of degarelix used to ensure rapid testosterone suppression without a flare, followed by a switch to a more tolerable and easy to administer LHRH agonist strategy has shown a superior 5-year survival, although we don't do this routinely. This is something which we can do, especially for patients. I have done this when patients have had very bad injection site reactions. NICE report has also suggested that despite the advantages of degarelix providing more rapid or improved disease control and no testosterone flare, the LHRH antagonist should not be used as first-line ADT treatment. Goserelin has been effectively used since more than 3 decades. I think above all for any of us, all doctors who want to treat prostate cancer, which is right now almost like a chronic disease, there is a data of nearly 3 decades alone or in combination with other therapies in patients with localized, advanced and metastatic prostate cancer. So to conclude, the LHRH agonist form that most widely used form of ADT and are considered first-line therapy. Goserelin is a widely used form with a large evidence base with established short-term and long-term clinical efficacy. Survival benefits with the broad spectrum of patient population have benefited from this. The evidence with regards to cardiovascular safety has so far shown comparable results for LHRH agonists and degarelix. I thank you all for a very patient listening. Happy to take any questions. Thank you. Thanks.
Do we have Dr. Estevan with us here? Thank you, sir. We'll conclude the session in this hall. Please join for dinner. Thank you.
ಸರ್ ನೋಡಿ ಮಲ್ಲ ಸರ್ ಓಕೆ ಅಲ್ವಾ ಹೌದಾ ಫ್ರಂಟ್ ಬೇಕು ಅಲ್ಲಿ ಹಾಕೋಬೇಕು ಅಲ್ಲಿ ಹಾಕೊಂಬಿಡ ಅದೇ ಚಾನಲ್ ಇಲ್ಲಿ ಬಂದು కింద పెట్టాను అంత ఆట ఫ్రంట్కి ఎత్తుకొని వచ్చి